emergency healthcare. An exclusive pediatric emergency wing offers a comforting space for children in their natural environment while mitigating the risks of contact infections from adults. The departments of laboratory medicine, radiology, and nuclear medicine offer comprehensive investigation and imaging facilities. Digitized voice reading of radiology. Continental Hospitals is nestled in the western suburbs of the city of Pearls. Hyderabad is the destination for the world's biggest and brightest IT conglomerates, and Continental Hospitals is one of India's premier healthcare facilities, with state-of-the-art infrastructure, the finest of clinicians and surgeons, and a quest for redefining patient-centric care. Established in 2013 by Dr. Guru N. Reddy, Continental Hospitals has pioneered several firsts in the Indian healthcare space.
The fundamental mission of Continental Hospitals has been to provide patient care with utmost compassion, with empathy and service excellence. Throughout the organization this past 8 to 9 years, we have fostered service delivery systems in collaboration with our entire staff, including our nurses, our paramedical staff, and all other stakeholders who come in to take care of patients and give them the best.
Becoming the first hospital in the world to secure JCI accreditation within 2 years of inception, first hospital in India to secure gold certification by QAI for WHO Standard Patient Safety Hospital, NABH and NBL accreditations amongst several others. Over 1.4 million square feet of built-up area, 18 floors, 800 beds and 16 modular operation theaters, Continental Hospitals brings together over 50 specialties and 7 centers of excellence. With advanced logistical, clinical, and trauma care facilities for any kind of medical emergencies, including stroke, vehicle accidents, falls, burns, or any other medical emergency, Continental is your preferred destination for 24/7 emergency healthcare. An exclusive pediatric emergency wing offers a comforting space for children in their natural environment while mitigating the risks of contact infections from adults. The departments of laboratory medicine, radiology, and nuclear medicine offer comprehensive investigation and imaging facilities. Digitized voice reading of radiology procedures, which then directly integrates with the patient's EMR, bring a greater level of accuracy, transparency, and convenience to the patients. Equipped with PET-CT, dotatate scanning, digital mammography, MD-MRI, and gamma cameras amongst others, Continental Hospitals is your one-stop destination for all advanced diagnostic imaging needs. Not just treatment, Continental Hospitals believes in and seeks to promote preventive care. The Adult Vaccination Center and Comprehensive Health Checks program is a testament to our goal of promoting a holistic preventive health and wellness program. A dedicated floor of patient amenities including food courts and canteen allow patients a wide spread of options for their meals, post-investigation snacks, and a space to unwind and relax. The newly unveiled, state-of-the-art, spacious OT complex comprises of 10 modular operational theaters, a suite of pre-operative and post-operative beds. Built to international standards, with perfect airflow sterilization, and designed to minimize surgical site infections. Our suite of OTs is technologically advanced, scientifically designed, immaculately thought through from safety point of view. The highlight of new OT complex is a dedicated, integrated robotic surgery and minimally invasive OT. The ultra-high-definition monitors and sophisticated instruments will assure precision, safety, and surgical dexterity that will transform the surgical experience of patients and patient outcomes. Premier economy, deluxe, and suites, catering to every individual from every economic background, Continental Hospital is designed to allow natural, unfiltered sunlight into our OPDs, in patient rooms and ICUs to aid faster recovery and improve patient experiences. Every suite is a treat to the eyes, and is a space designed for healing and recuperation at the earliest. Our 50-bed premium economy wing offers private, single-patient cubicles along with all the features of a world-class quaternary care healthcare facility at a highly affordable price. Continental Hospitals offers excellence in treatment care to patients from over 14 countries of the world, providing them a space that is reflective of their culture and language, making them feel right at home. Envisaged keeping in mind every single patient need, and it remains our everyday endeavor at Continental Hospitals to provide every facility that makes patients their attendance visit to the hospital a convenient and delightful one. An embodiment of collaborative and multidisciplinary care, our doctors come together to make collective diagnosis and plan treatment pathways, resulting in excellent patient outcomes, and it remains our everyday mission to provide best quality care for every patient with compassion while promoting integrated clinical practices in partnership with our medical staff employees. Hyderabad is the destination for the world's biggest and brightest IT conglomerates, and Continental Hospitals is one of India's premier healthcare facilities, with state-of-the-art infrastructure, the finest of clinicians and surgeons, and a quest for redefining patient-centric care. Established in 2013 by Dr. Guru N. Reddy, Continental Hospitals has pioneered several firsts in the Indian healthcare space.
The fundamental mission of Continental Hospitals has been to provide patient care with utmost compassion, with empathy and service excellence. Throughout the organization this past 8 to 9 years, we have fostered service delivery systems in collaboration with our entire staff, including our nurses, our paramedical staff, and all other stakeholders who come in to take care of patients and give them the best.
Becoming the first hospital in the world to secure JCI accreditation within 2 years of inception, first hospital in India to secure gold certification by QAI for WHO Standard Patient Safety Hospital, NABH and NBL accreditations amongst several others. Over 1.4 million square feet of built-up area, 18 floors, 800 beds and 16 modular operation theaters, Continental Hospitals brings together over 50 specialties and 7 centers of excellence. With advanced logistical, clinical and trauma care facilities.
This is Dr. Nishchala, clinical pharmacist at Continental Hospital. My colleagues and ladies and gentlemen, good morning to all of you. On behalf of Continental Hospitals, I welcome you all in this delectable morning charisma to the International Symposium on Medication Safety and Clinical Pharmacy, organized by the Department of Clinical Pharmacy by Dr. Nishchala and Sophia, along with the management of Continental Hospitals. At the outset, I would like to extend my Easter greetings to all of you. Each one of you seated here pursue our own individual and collective goals towards, and all of us know deep within that constant learning is the fuel that gives flight to our dreams, and today this is the foremost objective that brings us together to learn from each other, with each other, and about each other. The field of clinical pharmacy is an emerging one, and it is the one which has both immense impact and potential. According to the WHO, unsafe medication practices and medication errors are the leading cause of injury and avoidable harm in healthcare systems across the world. Globally, the cost associated with medication errors is estimated to be about $42 billion. It is thus imperative that each aspiring pharmacist should improve your personal skills and widen your horizons of learning by coming to conclave like this to further the learnings. Education is one of the most important things which start from our childhood and begins at home and continues throughout our life until we reach the tomb. Our former President of India, Dr. APJ Abdul Kalam said, "Learning gives creativity. Creativity leads to thinking. Thinking provides knowledge, and knowledge makes you great." Whether it's a developed or underdeveloped, modern or industrialized world is running on the wheels of education. To survive in this competitive world, we all need education, as a torch to lead the way. And our chairman, Dr. Guru N. Reddy, ever since the inception of this hospital, always insists that which plays an important role, that collaborative teamwork plays an important role for integration, innovation, efficiency, safety, and quality of healthcare. I now welcome the distinguished panel of delegates who have come from far and wide to enlighten us with their pearls of wisdom. I now welcome Dr. Subhrajyoti Bhaumik, who is a clinical director of academics and quality and clinical research at PLS Hospital and B.K. Roy Research Center at Kolkata. Ladies and gentlemen, please give him a big round of applause. He is a TED speaker too. And I now welcome Dr. Sangeeta Sharma, Professor of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences, New Delhi. She too is a TED speaker. And I now welcome Dr. Mohammed Hashim, Clinical Pharmacist at Cleveland Clinic, Abu Dhabi. And now welcome Dr. Sai Praveen Harnath, Senior Consultant, Pulmonologist and Critical Care Specialist, Medical Director, Apollo E-Access, Tele-ICU Service. Okay. I welcome Dr. Karthik Rakam, Co-Founder, Avenida Innovations. Welcome Dr. Akash Ani Paul, Lecturer at JSS College of Pharmacy, Believers Church, Medical College Hospital, Kerala. And I would also like to welcome our in-house faculty, Dr. Vijay Eladandi, who is the Director of Inflammatory Disorders Clinic, the most energetic doctor of Continental Hospital who saves the infections of the patients. And I also welcome Dr. S.K. Gupta, HOD of Hematology and BMT. I welcome Dr. Ramesh, HOD of Critical Care. I welcome Dr. Shilpa, Senior Consultant in Internal Medicine. And I welcome Dr. Bobby Ramesh, Director of Nursing. And I would like to conclude by saying that all of you all participate actively in the deliberations so that you can take away the outcomes in order to enhance your skill set for practicing as a clinical pharmacist. So ladies and gentlemen, let's fasten our seatbelts and listen to all the TED speakers today. Thank you all for your patient hearing and have a great day.
Thank you, ma'am, for articulating the vision and objective behind organizing this symposium. The complete event is being live streamed on YouTube. May I now request our guest faculty to kindly join our chairman and managing director, Dr. Guru N. Reddy, for the lamp lighting ceremony, followed by a commemorative photograph, while Ms. Gopika offers a prayer song for the auspicious unveiling of the symposium.
ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ವಿನಾಯಕ ವಿದ್ಯದಾಯಕ ದೇವ ವಿನಾಯಕ ವಿದ್ಯದಾಯಕ ದೇವ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ಪಾಶಾಂಕುಶಧರ ಮೂಷಿಕ ವಾಹನ ಸರ್ಪಾಲಂಕೃತನೇ ಗಜಾನನ ಪಾಶಾಂಕುಶಧರ ಮೂಷಿಕ ವಾಹನ ಸರ್ಪಾಲಂಕೃತನೇ ಗಜಾನನ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ವಿನಾಯಕ ವಿದ್ಯದಾಯಕ ದೇವ ವಿನಾಯಕ ವಿದ್ಯದಾಯಕ ದೇವ ಶರಣು ನಿನಗೆ ಶರಣು ವಿನಾಯಕ ಶರಣು ನಿನಗೆ ಶರಣು
Thank you, everyone. With the formal inauguration now completed, I take this honor to invite Dr. Guru N. Reddy, Chairman and Managing Director, Continental Hospitals, to deliver the opening keynote address for this symposium. Dr. Reddy is the visionary and guiding light behind this international symposium and is one of the leading healthcare business leaders in the country. Dr. Gurunath Reddy is the founder, Chairman and Managing Director of Continental Hospitals, Hyderabad. He graduated from Usmania Medical College with several gold medals and was named the best outgoing student of his batch. He subsequently moved to United States for his higher education at the prestigious Baylor College of Medicine at Texas Medical Center in Houston. And following a highly successful and accomplished clinical career, lasting 3 decades in the US, Dr. Reddy returned to India to serve his motherland and set up the state-of-the-art Continental Hospitals in 2013. Under his visionary leadership, Continental Hospitals has made a lasting impact across the Indian healthcare paradigm, becoming a healthcare institution of international repute within a very short span of time. Dr. Reddy has inspired sweeping changes in perspectives and practices, with the aim to make Continental Hospitals the poster child for new age Indian healthcare. And he continues to strive towards consolidating Continental with best doctors, best nurses, and best ancillary staff, and make it the Mayo Clinic of the East. Recently featured in CEO magazine, Dr. Reddy was named Legend of the Year in Gastrointestinal and GI Surgery at the Times Healthcare Achievers Award in 2017. And the Healthcare Entrepreneur of the Year at Six Sigma Healthcare Excellence Awards in 2015. His complete list of awards and accomplishments is both exemplary and exhaustive. Over 4 decades of stellar clinical practice and leadership, Dr. Reddy has truly redefined healthcare excellence all the way from Hyderabad, India to Houston, USA. Thank you.
Good morning. Thank you, Nishala, for
I'm truly humbled with your introduction. On behalf of the faculty who are here, my colleagues, the nurses, the pharmacists, and all other healthcare providers who joined us this morning, I once again extend a very warm welcome. Actually, I should be egg hunting with my granddaughter, but unfortunately she lives in California. I had no such luck today. By the way, happy Easter. So on a wonderful Sunday, while the world is celebrating Easter, we all have come together under this roof, in this city, at this hospital, to educate ourselves, to learn, and give our best as healthcare workers to our patients and to our communities. And that's indeed a great sacrifice. And such sacrifices are always called upon us throughout a career and life as healthcare providers, no matter who you are, in what capacity you're working. This is the one profession, such demand we can never undermine. Otherwise, we have no place in healthcare. So in my keynote address, Nishal has asked me, who has organized this wonderful event, a very proactive young pharmacist. When she wanted to do this, I kind of was a little doubtful. Could she really pull this off? This was one of the very few events in the last 9 to 10 years journey here at Continental. I have seen someone who independently put everything together. Of course, as management, we have to consent, or we have to guide, we have to advise, but there's no such scope for us other than consenting. Nishal, you have done a fabulous job. And certainly the topics that you choose and the faculty that you have assembled, will do great justice. And for all the delegates who have come here today, this will be a fantastic learning opportunity. Now let's briefly talk about the history about pharmacy. How did this evolve in this world? I'm always intrigued in healthcare to learn about the origins and history. I'm sure most of you know about the virtue of being pharmacists, reading such history, but it antedates to literally about 2000 BC, where for the first time the concept of pharmacy was born in this world, somewhere in Iraq, Baghdad, or Mesopotamia. The first pharmaceutical books or rendition that happened apparently was in Mesopotamia. The first pharmacies that were built was in the 8th century later on in Baghdad. And the 9th century, Pharmacy Regulatory Act came to that country. It was the Islamic Golden Age, and during that time they had tremendous encouragement from the Caliphate of Baghdad. So in the world history, the first pharmacies were born for us to know about this. Now, prior to this, somewhere around 1500 BC in India, a lot of things were happening in terms of the birth of the Ayurvedic medicine. You all know that Ayurveda simply means, Ayur is life, Veda is science. The science of life and how we can preserve and how we can progress and prosper. So the medicines for Ayurveda were just giving its birth. Basically, we all know that in Ayurvedic medicine, the plants have contributed tremendously. During that time, the origin of Ayurvedic medicine was rooted in the Vedas. The 4 Vedas that we have. It was the Atharva Veda which was extraordinarily important for contribution to the Ayurvedic medicine. And the people who were dispensing this medical knowledge and taking care of the patients were all called Vaidyas. And even till today, Vaidyudu, correct? Which means in Telugu language is a doctor, And even in Hindi, the word Vaidya is associated with. So its origin is several thousands years ago, and we continue to really enjoy, that particular term. So the world, it was not the Americas, it was not Europe, but this has happened in Asia, in Middle East, and in Far East, where the roots of pharmacy, the roots of pharmaceutical drugs, took birth. And thereafter, we have seen tremendous progression, where the father of the Indian pharmacy school was responsible for establishing for the first pharmaceutical college, who happens to hail from West Bengal, etc. So where are we today, after that origin, and how medicine, as science has advanced, where different forms of practice of medicine have been rooted in various, pharmaceutical approaches. From Ayurveda, we had homeopathy, then we have allopathic medicine. Allopathic and homeopathic medicine apparently historically, have parallel origins in this world. So there's various different types of practices of medicine that went into managing civilization diseases, has been in continuous evolution even till today. There are roughly 1.6 million registered pharmacists in India, but some quote as 4.6 million, but 1.6 million registered pharmacists. Now 4.6 million apparently from the World Health Organization are the pharmacists throughout the world. And if you look at that, 30 to 40% of the world pharmacists are in India. That's an incredible number. That's an incredible number. In America, we have 352,000 pharmacists for a population of 350 billion people. The world's most intense pharmacist availability and the ratio to the population is Belgium, which said roughly about 1.27 pharmacists per thousand population. And the least pharmacy patient ratio apparently is Netherlands, which is 0.25, 0.27. So if you look at these ratios, we are somewhere out there in terms of the availability of licensed pharmacists in our country. At a time when we see there is a huge deficit of doctors, hospital beds, nurses, as we believe that India needs in the next 20 years 3.5 million hospital beds, 3 million doctors, 6 million nurses, all at a cost of roughly about $250 billion. So while we are fascinated by this growth and expectations to come, the potential and the enormous opportunities for you as pharmacists is absolutely incredible. I think for you to choose this profession and be a part of the healthcare team and contribute to our patient's journey is incredible. So never doubt even for a single moment, why did you take, or why did you choose pharmacy as your profession? Yes, we had to go a long way in this country in terms of the respect, in terms of our educational opportunity, in terms of the quality of education, in terms of proper licensing and subsequent credentialing, in terms of economic packages, pay opportunities. We cannot have any more healthcare providers, not to be recognized in proper compensation. So while these things are going to be debated for the future, we will continue to learn into this expanding world and see what role pharmacists are going to be playing. As far as I am concerned, the definition of a clinical pharmacist, whether it be at the hospital, whether it be in a community setting, whether it be in a compounding setting, whether retail pharmacy setting, whether it's an industrial pharmacy setting, I feel it is the same. And what is that? The ability to decipher the prescriptions as written by the doctor, and the ability to think carefully and dispense that with a strong advocacy to our patients is essentially the definition and role, in my view, and this has been clearly, understood across all countries and nations. It is as simple as that.
you're working hand in hand and in tandem with your doctors to deliver the medications to your patients in a very safe manner and avoiding errors. But that is changing. So far, we just believe that you have to read a prescription and make sure there's no drug-drug interaction, there's no adverse event the patient can manifest, and this patient's life will not be in jeopardy. Now, how is it changing? It is changing in terms of the roles that you're demanded to accept in terms of as an educator, as a clinical leader, in fact, as an independent provider. During the COVID times, America has proven where it has empowered the pharmacists in the large pharmacy chains to go ahead and make the decision in terms of running the COVID testing, in terms of providing the vaccinations. And today, pharmacists are playing a very active role in that country where the rights have been given both federally as well as at the state level in terms of participating to the extent of patient care at certain basic level. It's no longer a physician's necessity for some simple ailments and things of that nature that a prescription is needed. And many drugs have migrated to over-the-counter. So the pharmacist becomes a great educator. When a patient comes to the counter and asks, I'm suffering from common cold, I'm suffering from back pain or a knee pain or a leg pain or a headache or a migraine or stomach pain, you're getting to be empowered to make the decision where you can give that medication, certainly, which does not require a prescription. Now, I loved pharmacology during my career as a medical student. In fact, all the time I used to kind of compete with my classmates, by quizzing, particularly before the exams. Now, we had two books at that time. All of you know, one was Satoskar, and during my time, the Bible was the Goodman and Gilman. So for me, Satoskar ended up to be a very small book. It has only 1,000 drugs, medications probably in that time. As in all my friends, 90% of them were reading Satoskar to prepare the exam. And I used to have Goodman and Gilman on my desk, pour into myself, understand, the basics of each drug, its mechanism of action. And I said, why I was torturing myself? At a time in fourth year medical school, you're supposed to take pathology, microbiology, forensic medicine, pharmacology. I have all these subjects. But something naturally, I was inclined towards, pharmacology. And thanks to my past, I think I got a distinction or a gold medal, in that subject. Then I came to understand, when I went to my final year, what are the three important things in a doctor's career in terms of learning, which is physiology, pathology, and pharmacology, the three Ps. If you're a master of these three things, you'll be an outstanding physician or outstanding healthcare worker. For all of you too. You can't just be learning pharmacology and memorizing drugs. You need to understand behind the physiology, for what purpose that drug is being administered, the pathology, which is the disease, for why and how it influences the disease outcome for a given patient. Unless and until you have these three fundamentals, knocked off, we will not be that good. I can tell you very openly. So, in your world where things are changing rapidly, with evolution of every day, almost a new drug, literally, and the basic formulation of the drugs, the invention of these drugs has migrated to a completely different platform. The reason that happened is because scientific advances have taken us in unraveling human disease to the level of our DNA, to the level of that cell in the human body, to the level of all the inflammatory, biochemical, and various chemical mediators that have taken shape today are understood. And scientists across the world have been trying to design and make the drugs to be more effective and conquer human disease. And most of you who are in practice or dispensing medicine, I'm sure you're seeing that. Whether it's the world of oncology, infectious diseases, gastroenterology, you name a specialty, cardiology, for example. You have so many new receptors, so many receptor blockades and all of those things. So you're being challenged immensely. But for you to understand without any confusion, without really kind of getting, sometimes challenged to the point, can I really do this, is to understand the basics. If you understand how the drug works, the mechanism of action of a particular drug at the end of the day, then I think that journey becomes very easy. Non-understanding of a drug, where you're just made to memorize or just look at it and basically dispense, like a check mark, the dosage is fine, I can go ahead and dispense it. I see majority of the times that's what is happening. We need to get away from that. We all need to go into more deeper learnings in terms of mechanism of action, so that becomes, very easy, to understand the evolution of the newer drugs and have interest. So many times I see when I'm rounding in the hospital, I ask the nurses. The nursing is a very important sector. It's not this whole burden is not just on the pharmacists. We all work in tandem, doctors, nurses, pharmacists, at the end of the day. So sometimes I ask the nurses, do you know that why are you giving this medication? Do you know how this medication works? Do you know what's the dosage of the medication? In the Indian circumstance, one thing I realized is none of their fault. I fault the educational standards. I fault the quality of education that happens, that they're not given the opportunity to truly be exposed and to learn about and practice, safe medicine. Now, we all talk about medication safety, we talk about medication errors. I'm sure throughout the course of the day, there'll be a lot more enlightenment on this. There are statistics which say that in America, 1.3 million people suffer annually from adverse events, out of which 35% are admitted to emergency rooms at a cost of almost, 35 or $3.5 billion. In India, we don't have truly a good statistic at the end of the day. But it's time for us to really collect. I feel that number is probably can be multiplied or compounded by 100-fold or 1,000-fold. Because a lot of things go unreported, even the so-called big hospitals. So digitization is another thing that will help us in medication safety. All of us know that will be the next frontier. The next frontier that is going to happen in healthcare, which is already happening, is digitization. We at Continental in 2013 implemented the electronic medical system. We were the first hospital in the country to successfully implement. Prior to us, many hospitals, or a few hospitals, they tried, but they could not succeed. But we implemented it because my vision was that to really practice safely and being accountable at the end of the day, we need digitization. And the so-called SIPO system that originated in America and Europe, has made an enormous change. It's time for us in this part of the world to focus on that. So your futures are going to be defined. How well you'll be learning the digital aspects of dispensing, digital aspects of understanding and communication, with your patients. For example, today we are seeing that pharmacy or drugs, they're being ordered online and being delivered to the patients. So there is a shift that is happening from a retail marketplace down to a domestic or home-centered care, which is happening in healthcare, which is happening in the world of the pharmacy. So when this is going to be transitioning, the question comes, what will be the role of the pharmacist? You're not at the counter, you're not in a particular physical space, but things are moving digitally, somebody else is delivering. So be prepared. Be prepared for these changes that are coming. So in a nutshell, I define the role of a pharmacist as, or the characters, the skill sets that you should produce, you should have at the end of the day, or you should produce, or you should practice is, number one, is communication skills. Number two, efficiencies of scale in terms of understanding. Number three, good thought process, thinking ability. Number four, numerical strength is very important. You cannot be very weak in math because you're calculating dosages in milligrams, if not in nanograms, in milliliters, and all of this stuff that's happening. So you need to have a very strong numerical strength. Number five, an ability to observe, which is very important. Observation skill, not only for you but everybody else. But these 5 or 6 skill sets, if you possess and constantly keep on working on them, that will help you to be confident, that will help our patients to keep them safe. And ultimately, we're going to improve our healthcare system. So with these few words, I once again commend the Continental Pharmacy Department and Nishala and the team for putting this together, our nursing team, and the rest of the hospital staff who really came together to organize this. And I'm looking forward to, at least for a few sessions, to learn myself. It has been a long time, I think, where I learned about pharmacovigilance and certain other interesting topics today. So enjoy. I think you should have a nice lunch. You should have a good breakout. The couple of breakouts that you have, hopefully you have a warm cup of tea and coffee and some snacks while you're engaged in this learning process. Thank you very much.
May I request you to be please seated on the dais? Thank you, sir, for your insightful, informative, and inspiring words. This is Nikita, PharmD 5th year student, and I will be one of your hosts for the day. Let us now welcome our first faculty for the day, Dr. Subhrajyoti Bhaumik, who will be speaking on the role of prescription audit in medication safety. Dr. Bhaumik has completed MD in Pharmacology from IPG-MER and a PG Diploma in Diabetes and Endocrinology from the Royal College of Physicians. He obtained certifications in patient safety from Johns Hopkins University and clinical research administration from Stanford University in the United States. He is the lead clinician surveyor for the American Accreditation Commission International. Dr. Bhaumik is also the assessor for the National Accreditation Board for Hospitals and Healthcare Providers. He is recognized as the most promising healthcare professional in patient safety by the Asian African Chamber of Commerce and Industry. He is one of the subject experts in pharmacology in the WHO-sponsored MBBS DM MD Curriculum National Review Meeting. Currently, Dr. Bhaumik is the Clinical Director of Academics, Medical Quality and Clinical Research at Peerless Hospital and B.K. Roy Research Center, Kolkata.
Good morning, and thank you for that warm introduction. So, good morning, everyone. And at the outset, let me thank the organizers, especially Dr. Nishala, for inviting me here. And I'm really, really very happy to be here. And congratulations on this great initiative which you've taken. My friend, old friend, Bobby Kamath is here in the audience. She's been my co-NABH assessor. And to speak on a topic which Chairman Reddy sir has actually spoken about is, I think, this is very, very pertinent to start the day. Sir said that one of the important things, can you put this? Yeah, okay. So sir said that one of the important aspects of the people who are in the pharmacy is actually to look at prescription and also decipher it. I think you already mentioned what I'm going to talk in my topic. So my job today is to talk about prescription audit and medication safety. I have an expert speaker after me, so I'm not going to get into details of what medication safety is. But ladies and gentlemen, prescription, is a medico-legal document. It is a physician's order which you need to follow. And every component of prescription is important because you need to administer the medication accordingly, and you need to follow the doctor's order. Now, let me tell you, I know this is a crowd of pharmacists primarily, but then I am made to understand there are few nurses as well as few doctors. We need to understand that these prescriptions, if they're inadequately written, they have a huge burden of medical legal consequences for all the hospitals where they are written. What is the cost of poor prescription writing? You know, we can go on and on and on. And Sir was mentioning that Indian data is really sketchy. We have done some bit of work. We have actually one of the few hospitals in Eastern India where I really thank my management at the PLS hospital to allowing us publish what medication errors we did. But if you look at the statistics, you know, India's medical error death is nearly 5 million a year. But this is not in the COVID-19. This is before COVID-19. We know what happened in COVID-19. 5 million must have been into, I don't know what, 3, 4, 5 times now. So it is really scary. And if you really look at medication errors, I'm not going to get into details. Rough statistics across globe, whether they are developed countries, whether they are underdeveloped countries, you know, there is one error happening per patient every day. So we need to be very careful when we actually analyze prescription. And we say I'm talking about the clinical pharmacist, I'm talking about the pharmacy people who are going to be an important component to identify this. Now, drug-related morbidity and mortality are estimated to be huge in economic consequences in the United States. For them, every dollar matters. But let me tell you, Indian scenario is changing. In fact, India also monitors a lot. But then the situation in India becomes very difficult because we are the generic capital in the world. We have hundreds of formulations. We have so many names. You know, I'm not going to get into details. I'm just look at this example. Medzol for midazolam, Medzol for pantoprazole. I mean, if you are not very, you're not going to be vigilant, then you probably might inject a fast midazolam into a patient because you might have dispensed it. I mean, say you are not going to do it, probably the nurse, and we must believe that we are all working. So this is a tragedy waiting to happen in every hospital. Not in my hospital, not in your hospital, in every hospital. So medication errors can happen at any stage. And today I'm going to actually talk about the prescription errors because this is what is picked up by the very important prescription audit. Now, many of the prescriptions, and this is not at Continental Hospital, I can tell you this is not from my hospital as well, but this is the situation which is probably in many of our government-funded hospitals and where majority of the patients go. We can't read this. I mean, situation is really alarming. How do we improve the situation? We can improve any situation by doing audits. What are audits? Audits are the way in which care of the patients can be improved by a multidisciplinary approach. Now, there's a mindset. Prescription audit means only the pharmacist will be involved. No, please remember, prescription audit is a multidisciplinary mindset. So audits have to be multidisciplinary. You have to conduct to look whether appropriately you are doing the right thing or not. And very important thing is we have to do a systematic, logical review of the care, and this has to be patient-focused. Don't pick up topics which are not patient-focused. I'm now talking about clinical audits here, but many times people ask us, can we do this as clinical audit? Can we pick up that topic as clinical audit? If any audit does not have patient in focus, it really doesn't matter. What is prescription audit? Prescription audit is a very important tool which can be used to generate data in several aspects of medication. You collect information on existing practice together with information on appropriate practice is being done or not. So whether you're prescribing appropriately or not, that is what is prescription audit all about. Now, there are various purposes of prescription audit, and the management is here. You know, many times we have to justify. When I say we, the clinical pharmacy team has to justify we need more people for prescription audit. So I'm going to present a small case why prescription audits are required. We need to look at completeness of prescription. This is one of the very important things which all of us are doing. We need to detect errors. But you know, any effort for detection is incomplete if you don't prevent. Sir was mentioning about pharmacovigilance, and I'm really scared when he said he's waiting to learn something on pharmacovigilance. So, I mean, very important in India, you know, we are very good in detecting, but we don't know what to do with after detection. We need to devise policies, we need to devise strategies on how we prevent, and prescription audits are a very important tool for preventing medication errors. We also need to understand prescribing practices of the practitioners. Now, this is a very important thing. I think Professor Sangeeta Sharma is there. She is one of the stalwarts of standard treatment guidelines. But many people prescribe left, right, and center. I think COVID-19 was a perfect example where we saw that if we don't adhere to standard treatment guidelines, what can happen to people. So whether we are adhering to standard treatment guidelines should also be a component of your prescription audit. Now, drug utilization. Pharmacies procure a lot of, they procure a lot of medications. They keep it in the pharmacy. Whether that particular medication is being utilized in that way or not. Anti-inflammatory medications, immunomodulators, do a prescription audit for drug utilizations as well. Detecting ADRs. I think pharmacovigilance is another very important part of medication safety, and I'm not going to get into details because we have a session later that if you have to detect ADRs, this is a very important tool. In fact, there is a huge relationship between medication errors and ADRs. They believe 10% of the ADRs are actually a result of medication errors. So if you detect medication errors, you detect ADRs, you're actually probably looking at a medication error which might have happened. Now, there are various indicators which could be used, and I would say adhere to a standard indicator. These are few indicators I picked up from the WHO. You can go into them. I'm not going to get into details. But the most important thing I want to put into your conscience is that adhere to standard indicators. Don't discover your own indicators. You adhere to standard indicators. What is the method? Prescription audit is just like a systematic research. If you have to do research, all of you have done a research, so you first define your design. Of course, this doesn't go under ethics committees because this is part of the quality improvement process. You have a cross-sectional design, prospective design. You can define your population. Majorly, as my experience as an NABH assessor, as well as an AACI assessor also, I would say, majorly the pharmacists are engaged in doing the prescription audits in the IPDs. OPDs is a very difficult area to conduct prescription audit, but focus on OPDs as well. You must define your inclusion criteria like any other research. You must define your exclusion criteria. In our hospital, we probably sometimes exclude daycare patients because they are there for a couple of hours, they leave. Sometimes the emergencies are left because the patients eventually move out of the hospital or they go into the ICUs or they go into the wards. Now, sample size. A huge discussion can happen. What is the sample size? People will say 20%, 30%, 40%. I like the NABH assessor, if you're really making them happy, if you pick up a 10% of the sample size, you're happy. So if you have 1,000 indoor admission and you only show me 40 prescriptions as audited, that's not going to work. That is what you have to keep in mind. You have to also look at IPDs and OPDs. This is something which is a major non-compliance in many of the prescription audits which are performed. So you have done an excellent job in your IPD, but you have not done anything in the OPDs. Now, pharmacists play a very important role in prescription audits, and I would say that if you have resource constraint, go to the focus area of the WHO medication safety program. Look at your high-risk settings, your high-risk patients, patients with kidney disorders, patients with liver disorders, patients on high alert medications which are in ICUs, patients who receive polypharmacy. Geriatric population is increasing in India. By 2030, India might become the geriatric capital of the world. So we are progressing. It's not that India is not doing bad, it's not doing good. India is actually, people are living longer. Lot of medications people are taking, and definitely a transition of care. So I would say pick up these three areas at least in your prescription audit. Data collection can be done through OPD cards, and you must collect it daily, you must review the prescription, there must be an extraction tool. With high-end hospitals like Continental hospitals, you probably might take it directly from the electronic data set, but majority hospitals in India still use the way of looking at it from the handwritten prescriptions. So look at from there. And data entry has to be really, really perfect. What I really loved, what Chairman Reddy sir said, is that we must know our mathematics well, because many a times, you know, they would put, if the analysis is wrong, then people don't take it very, very nicely. There could be various studies variable, and this is one of the few variables. And please avoid prescription audits which don't have any standards. You know, these audits are not audits. Please, whenever you are selecting standards, talk to somebody who knows evidence-based medicines. Look at your literature, where the audit, on what audit has been performed. Look at published literature. Please always display a team effort. The nurses who have played an important role, the doctors who have played an important role, please acknowledge their role. This is extremely important. Please don't perform numerical errors. Don't tell the cardiothoracic department, no harm to them, please, with due respect, that you have done 80% of your prescriptions wrong. No, it's actually 8%. So that zero makes a very big difference. And always, always present your data in a nice, gentle way. Nobody likes to be, criticized. You always put gentle curves and don't put figures in prescription audits. Now I'm going to end with our prescription audit experience, which we went to publish in the QAI journal, and this is done by my team. We are very happy to share over 6,000 prescriptions were published from our hospital. And because Eastern India, a lot of work is being done, but not much is published from that part of the country. So 6,406 prescriptions, and these were all handwritten prescriptions which were looked by the clinical pharmacist. And the very important thing which was included is that we wanted to sustain improvement and monitor evaluation. This is something which is extremely important. One cycle of audit is not going to help. It has to be followed by a re-audit to see where you have reached. Because if somebody says 100% of the prescriptions are compliant, then you have to really not believe it, because nowhere on earth 100% compliance will come in. So be very, very, we need to be pragmatic as well. So this is how the prescription happens in our hospital. So thanks to Dr. Snehal. In fact, sir, he happened to be a gastroenterology resident as well. So with his permission, we have used his picture. This is the prescription card as it is available, the Cardex, which is available in any other hospital. And we use the NABH checklist, which is the checklist because we wanted to show this to our assessors because they are very strict when they come to us. So we use this particular checklist, and we looked at many things. We looked at therapeutic duplication, prescriber signatures. We also were very strict on drugs written in capital letters or not, because this is something which the NABH really focuses on. So our team took this few basic things as safe prescriptions, where all the names of the drugs were written in capital letters. The drug allergy must be captured. This is another area, ladies and gentlemen. If the prescription is not capturing drug allergy, a lot of medication errors and adverse drug reaction is waiting to happen. Please, please, please inculcate this in your system. Whether they're using any error-prone abbreviation, whether the drug dosage is mentioned in the correct format or not. So we were not doing that great, at the beginning of the audit, the compliance rate of drug allergy just documented was only in 62%. And we were very worried about it. The medication errors were not written in capital letters, and we are a teaching institute as well, so we have over 50 DNB residents who come from various parts of the countries, and you can look, these are all prescriptions written by them, and this is a high chance of dispensing error happening because it is whether it's 10 or 100, we don't know. So this percentage was only at 93%. The dose was not mentioned incidentally in many, many, many prescriptions as well. So this is another very bad indicator. So we actually we were very concerned when we started looking at these data. The starting date is very important for few of the drugs because In antimicrobial resistance program, we have a session here on antimicrobial stewardship. Duration is extremely important. If you're not sure on when you started the medication, you probably are doing more harm to the patient. So we need to do that, to mention the starting date. It was only present in 96% of the prescription. The error-prone abbreviations, was also not at a very good state. 12% of our prescriptions had error-prone abbreviations. So this is really, we're very, very worried about it. So we came with the quality team and the clinicians. We discussed this in our Drugs and Therapeutics Committee meeting, and we did the root cause analysis and found out, especially the junior doctors, they were unaware of the good prescribing practices. There were no dedicated programs on GPP, and no communication existed with clinicians with the quality of prescription which was being generated. So we had multiple discussions every month till we conducted the training programs. In fact, my acknowledgement to all the clinical departments who sent their residents for trainings, we shared the results with them as well. There was marked improvement. I won't say that there was a real great improvement. There was marked improvement. People started writing, at least even writing that this is not known. Allergy is not known in the prescription card. They started writing this starting date. They started writing the drug dosage, frequencies, and in capital letters, though we are still struggling. We are still down below 90% now. And there has been a substantial change, I would say, which we are trying to monitor. So if I would say the summary of our improvement story is kudos to our clinical pharmacist, because who was round the clock going, talking, looking at the thing, and she was noting the prescription audits. And then, this very senior man you can see here is Professor A.K. Paul. He has over 40 years in clinical medicine, and takes a lot of courage to speak to him that, sir, your prescription did not have the starting date, but we kind of empowered our clinical pharmacists to talk in a bit gentle way, and definitely bringing all the clinicians back to the class. So this just went on and on and on. So I think if we conclude our story at our hospital, with this, then some part of it was definitely before COVID. I would say prescription audits are extremely important because they improve the quality of prescriptions. And this is the very important thing, because medication safety starts with safe prescription. Safe prescription reduces medication errors. And I strongly believe that, dedicated team of clinical pharmacologists and clinical pharmacists have to be there in every hospital, because they will perform prescription audits, they will do regular communication with the clinicians, which is the need of the hour. So I would like to acknowledge my team here who are working with me in my hospital, and nothing is possible without a team effort, because with team we achieve more. Thank you all, and let us all join hands to have medication without harm focus from WHO being implemented in the right way by doing proper prescription audits. Thank you.
Thank you, sir, for so lucidly articulating the role and importance of prescription audit in medication safety and enlightening the audience with your pearls of wisdom. May I request you to be please seated on the dais. I'm sure every one of you all have noted all the NABH requisites for prescription audit and implement them in your practice. Before I introduce the next speaker, I request everyone to kindly send in your questions. Do mention the name of faculty you wish to address your question to, and send it on the Symposium WhatsApp group we have created, or the number we have mentioned in the brochure. The same group will be used for some fun activities that have been planned for a little later in the day. And these activities will help you win some fun prizes. So do watch out for those. All right then. Coming back to the sessions, we have our next speaker, Dr. Sangeeta Sharma, and she will be providing us insights on the role of clinical pharmacists in medication safety. Dr. Sangeeta Sharma, Professor and Head of Department of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences, Delhi. Dr. Sangeeta's core expertise areas include clinical pharmacology, promoting rational use of medicines, especially antimicrobial use and antimicrobial resistance, medication safety, quality in healthcare. She has an extensive professional and managerial experience in healthcare. She worked as the India WHO Essential Pharmaceuticals Programs Technical Coordinator, a medical superintendent and secretary, and a member of the Indian Medical Council. She has conducted more than 300 workshops to build capacity for doctors, nurses, and pharmacists. Dr. Sangeeta is the author of Standard Treatment Guidelines, a manual for medical therapeutics, 6th edition 2021, which several Indian states have adapted, and Pharmacy Management, Standard Operating Procedures, and Lippincott Illustrated Reviews, Pharmacology. She serves on the Ethics Committee of several national and academic institutions. Dr. Sangeeta is the State Nodal Officer for AMR Containment, Delhi State.
Thank you. Thank you for such an elaborate introduction. Good morning to all of you, and thanks to Dr. Reddy, Nishchala, and the organizers for inviting us here and speaking to a very important stakeholder in medication management. I must thank Dr. Reddy again for making my job easier. He has already, I think, covered that part, your role, overall role in healthcare. So let's, in this thing, because the time is also limited, medication safety is something which we can speak for hours, days together. There is a lot to do about it. So I'll try to focus on the medication safety part. I think all of us agree here, goal of any healthcare system, be it in a developed country or a developing country or a city like Hyderabad or a state, we want to improve access to healthcare. Everyone should have access to healthcare. Universal healthcare goal, this is the year week being celebrated for this, and all of us need to work towards that. But all this has to be done at the, we need to control the healthcare costs at the same time, because we've seen that costs are escalating like anything, and many people are not able to afford it. And one serious illness in the family can be catastrophic. People have to sell their house, they have to, compromise on education, nutrition of other children, because all of us are working with meager resources, so that we need to see to it that they are optimally utilized. Unfortunately, the public health system has not geared up to take up this. We've been taking baby steps. But baby steps, will take a long way to go. So we need to really be working on this. How do we improve access to this? And as far as medicines are concerned, most of the treatment part, if you look at the management part, more than 60% of the part is being played by the medication. We do procedures for the patients, counseling and other things do help. But if you look at the management part, more than 60% of the part is related to the medication. So that's the, the canvas size for you where you need to work on. And the pharmacists are in position to work in concert with the patients and the patients' other healthcare providers to promote health, prevent disease, assess, monitor, initiate and modify medication use to assure that the drug therapy regimens are safe and effective. And the goal is to optimize patients' health related quality of life, have positive clinical outcomes within realistic economic expenditures. And the role, there has been a paradigm shift in the role. Historically, pharmacists used to be seen as a dispensers only. Unfortunately, many people still have those notions, but to me, pharmacists pharmacists are a very, very integral part of the healthcare team. You cannot function optimally without, having their active role being played here. Now, increasingly, pharmacists, are being looked upon as provider of personalized patient care and improve patient safety and healthcare outcomes. The role, has changed. They play a pivotal role in providing standard patient care in a hospital and serve as a link between physician and the patients. Patients feel much better, closer to the pharmacist. In my more than 30 years of experience of working in this area, I find, patients hesitate asking questions to their clinicians. Somehow this has been Indian, this thing. They hesitate, but, the moment they come in contact with the pharmacist, they have hundreds of, questions for them. So that's where your role comes in. You should be in a position to answer those questions because they feel closer to you and they feel that you are the custodian of the medicines. So you would know much better than the clinician. Clinical diagnosis related questions, they'll reserve it for the clinician. But for medication related questions, they will always be, looking forward to you to find an answer. Now, we need to be worrying about these medications. On one hand, they save lives, they improve quality of life. But on the other hand, they can be dangerous too. They are double-edged swords, do dhari talwar hai. They have effects, they have side effects too. So it is, the person who is holding or using or prescribing, dispensing is in a position to use them optimally so that patients do not suffer from adverse drug reactions and medication errors. And of course, they are expensive too. If you look at your hospital budget, even in Continental, in public health hospital, after salaries, the next budget head is medicines. So they are expensive too, and they can be misused and abused. When we say abused, most of us think in terms of opioids, morphine, and habit-forming drugs, but misuse, very common example is antibiotics that is being misused and has a lot of repercussions. I'll be talking about role of pharmacists in combating AMR. I will skip the numbers. Numbers are huge. We don't know. We are living in ignorance. Many of us thinking that maybe our system is better because patients are getting better, but you never know what's happening at the ground level. And the most important part which I want you to take home is the most errors are in a study done, they have shown that 40% of the errors happen at the prescription stage, 40% errors happen at the administration stage, then transcription and preparation errors happen. Now, the good part of it is the 40% of the prescription errors can be picked up by the pharmacist. Because all these prescriptions will come to you, to a pharmacist, and you can pick up. So that's the, improvement scale that you can have. And this is, continuing, errors are continuing because, somehow there is less of a societal recognition. People think pharmacists are dispensers. They just dispense. Technicians are doing this job. So if a qualified person does it, perhaps the situation would be much different. Subrojyoti touched upon this. Our challenge is a very, very big challenge here because we have hundreds and thousands of formulations available in the country. More than 70,000 formulations are there with one letter difference in the name. Brand names are there, so there's a lot of confusion. About 40% of the fixed dose combinations are available, and majority of them are irrational. There is no rational. If you apply your pharmacology knowledge there is no benefit as far as combining, but they are available. And all these, with I pardon my clinician colleagues here, but they use these fixed dose combinations all in the name of promoting compliance. The adherence would be more if we use FDCs, but you need to look into the rationality of these, and then the quality issues come. And as far as dispensing errors, we may say, we are all human beings. When you work, you make mistakes also. Agreed. Busy people make mistakes also, but we are in a profession where we cannot afford to make these errors. On the lighter side, you may say, anything, but we can't afford to have these errors. And as I told you, the other reasons that, medication errors are significant at all stages are because of free over-the-counter availability. Many of you may take up a career in the community pharmacy or in the hospital pharmacy, outpatient pharmacy, but you need to really look into it, because there are many look-alike, sound-alike pairs which are available in the market. There are hundreds and thousands of such examples, so you need to really be having a good knowledge about the basic composition of a formulation. Many of us go by the color of the label, size of the ampule, and don't just think that these lookalikes are there for parenteral medicines only. These lookalikes are there for the oral formulations as well. Even I make mistakes. I have a pouch of medicines at home, and one day I was just, I thought I had kept all my day's medicine in my pouch, and I was taking them one by one, and then I realized I was taking metoprolol, which I was not supposed to take. So even a person like me can make mistakes, so think about the patients, who do not have much knowledge about this. I think I'll skip this. Medication safety, medication without harm. Because of the extent, magnitude of the problem, WHO took this as a priority, and they have launched these programs. Also, there are many factors responsible for it. Let's focus on, what you can do about this. Dispensing is the critical part. This is the most critical part, where you can pick up these errors. And each step has its significance. So I would urge you, all of you, if you are dispensing or supervising dispensing, please do look at that all the steps are being followed as far as dispensing is concerned. Then at the time of discharge, this is another area, you have a large patients here. As I told you, patients feel closer, and they need to be prepared while discharging from the hospital. Very often you'll see that the patients get better in the hospital. You did a wonderful job, wonderful procedures, but when they go back home, they come within 1 week, 10 days to you again. Because most of the time, either there was an omission, an important drug which should have been continued, got omitted because discharge summary did not mention about it, or there was a duplication. You also wrote about a medicine here in the discharge summary, and the patient was also taking prescription from other. This multitude of prescription is a very common problem these days. Patients visit several, I call this medical shopping. They go for a medical shopping. They'll consult one person, then another person, third person. So many of them will be writing the same medicines, or an important medicine may be omitted. So at the time of, this is the critical time that you can catch hold of the patient and talk to them and make a list. Medication, this is called medication reconciliation. You make a list of all the medicines being taken by the patient, give them up-to-date list. Very often I have seen in the prescription, they say say this patient was admitted for a lung infection at this time, but the patient is also hypertensive diabetes, you take your hypertension and diabetes as prescribed. That's how the discharge summary looks like, but that's not the right way of doing it. And also many of the patients at home are also taking, they may be taking herbal medicines, they may be taking vitamins, they may be taking other Ayurvedic medicines, which they don't consider them as a medicine. So, but they may have interactions with your prescription medicines. So discharge is the time, I think, in this hospital, this would be one step, if you can, involve the pharmacist and do this reconciliation, that would be a great step in the, and also, patients, the discharge summary medicines may also be all right, but if you haven't explained to them how to take them, when to take them, for how long to take them, when to come back in emergency, when not to worry about these are also important considerations. Because otherwise, if there is an ADR, the patient may get frightened and may stop the medicine on his own, which may be very vital for his medicine. So pharmacists will come in there. I think I already talked about the appropriateness of the prescription. Dr. Reddy was talking about the empowerment of the pharmacist. I am also a very great advocate of this, because but you have to also come up to that standard. When you are talking to a clinician, you need to be very up to date with your knowledge and this thing. You can't be affording mistakes. Oh, I didn't know. Okay, maybe this was wrong. So you have to be confident about all these things. Reconciliation, I talked about it. At least, if not daily is too much with the current loads that we have, but at least 3 times, at 3 transition points, at the time of admission, at the time of patient being transferred from one patient care area to another area, and at the discharge time. If you can do this reconciliation at 3 points, I think majority of these errors can be taken care of. And majority of these errors occur because of the safe and ineffective medications. And of course, you can participate in adverse drug reaction monitoring programs. You can talk to the patient, because patients, share their, concerns or whatever happens after taking medicines. You can, if you know them, I strongly believe in, we will see what we want to see. That's very, very much true. If you have trained your mind and eyes to look at these things, you will find them. If you yourself don't know, you will never find them. So train your mind and your eyes to look for these ADR. And then reporting, clinicians often find that they don't have time, they have heavy patient loads, maybe they are also not sometimes willing to do this job. So you can chip in, do this job for them. And reporting, of course, is important. There are many signals are being generated because of these reporting only, and then you would know that you will provide only the safe medicines for your patients. And of course, you have a role in making drugs available. Making a list of essential medicines and rational selection and use of medicines is a very important part, where clinical pharmacists play a significant role. A hospital, no system in the world can work with unlimited list of medicines. Everybody has to define a limited list of drugs depending on the scope of their hospital. So you have a role, depending on your scope of the hospital, to select a hospital formulary. Selection involves a lot of, evaluation. The 4 most used criteria, foremost is efficacy. The drug should be efficacious, it should be safe, it should be suitable, and it should be at the affordable cost to the patient and to the health system. It shouldn't happen that they have to pay, acute care, you may not worry about the cost part, but chronic care, hypertension treatment, diabetes, epilepsy treatment, asthma treatment, you need to be taking care of this, whether patient will continue to take these medicines because of this cost factor or not. Then standard treatment guideline, many hospitals I see that they have a hospital formulary, but the doctors write something else. Or the drugs mentioned in the hospital formulary are not written in the standard treatment guideline. So clinical pharmacists again can come in with the knowledge of having both the sides, can match this hospital formulary with the standard treatment guideline and make those drugs available at the hospital so that they can be optimally used. Prescription practices, audit part that you can do, and then you can also, with audit, one thing, I would like to mention here is many of us do this job wonderfully well. As part of the accreditation, all of us are supposed to do the audits, but all of them remain a document in the file. That's not the purpose. The purpose is to improve, make a change. And how will that change happen? Unless you give feedback to the concerned providers. And which I see missing most of the time. 90% of the time, audit is done, findings are there, but feedback was never provided. So focus on that. Nischala, yes, you can take up that, that you regularly give feedback to your... Good feedback is also equally important. It's not only the purpose to find faults. If you're doing something well, celebrate that as well. Right? So feedback, you can take on that, and then training of the people, then collaborating with healthcare teams, chronic illnesses, you can, empowerment part, some of the load can be taken off from the clinicians part, depending on your policies and procedures. You can devise protocols, what a pharmacist can do and what a clinician will do, and additional roles are communication with the physicians, economics part, you can do economic studies, comparing two different regimens, two different ways of managing a patient, cost effectiveness of a particular medicine, management part, and consumer educations. Then you can be an important member of various committees in the hospital which are focused on medication safety. Drugs and Therapeutic Committee, or some people call it Pharmacy and Therapeutic Committee, Patient Safety Committees, then this Antibiotic Policy Committee, or Stewardship Committee, whatever the hospital may be having. So you can contribute significantly being member of all these committees. And lastly, the role in AMR. We have had good antibiotics, but this fight between the germs and the antibiotics is ever going on, and it seems that germs are smarter than us. They have always remained one step ahead of us. Please take this home. We cannot conquer these germs. They will remain in this universe. We need, just give me 2 more minutes to finish. We've had a good antibiotic era. Penicillin was a game changer. We thought that the infectious diseases are conquered, no longer a problem. But what do we see today? What do we see today? Even today, patients are dying because of the infections. 50%, 60% of the healthcare load is because of you do a good job here, good procedure, surgery, but you see patient is dying in ICU. My heart saddens, when I see somebody dying in ICU just because of an infection. And this is, not happening only because of the use of these antibiotics in humans. They are also used in animals. We fall sick, they also fall sick. But what is worrisome is when we use these antibiotics for forced growth of these animals. And today, you'll see all of us are eating animal meat laced with antibiotics, milk laced with antibiotics, crops sprayed with antibiotics, so you can't escape antibiotics. And it has become a global health threat now. We have all faced this COVID-19 pandemic, and I think it's a dual pandemic. AMRs is silent. We are not able to appreciate. COVID was like a tsunami. This is silent. We are not appreciating, but both of us, these pandemics are related, so we need to fight this, and pharmacists are an important part of antibiotic stewardship committees. You can sit on these committees and define the hospital pharmacy. Very often, if you look at I don't know what are your findings here, look at, if the antibiotics are used prophylactically in your hospital. If you just pick up this topic, this will give you the entire picture, what's happening about the antibiotic use in your hospital. Then, if you are in a community pharmacy setting, you can counsel patients. Many of the patients come directly to the counter because it saves them the consultation time. So they may be asking, I'm having running nose, diarrhea. So you are in a perfect position there to counsel them not to use antibiotics, because most of these illnesses, 90% of the time, are viral in nature. You don't need antibiotics. None of your pharmacology teaching ever taught you that antibiotics will work for viral infections. Please remember that. Okay, I think that's the chronic diseases. You can take on some part of follow-up, adherence, monitoring these ADRs, helping them how to minimize these ADRs and improve compliance with it. Then patients, you can help with the patient's compliance and therapy. You take on the rightful role, participate in medication safety, rounds. You learn a lot from them when you join them. Initially you may be lost, but over a period you will start realizing what are their needs. What is it that the clinician is looking for, and where can you pitch in and provide the support and to make the patient management more comprehensive. Sorry, I overshot my time. But
thank you, ma'am. May I request you to be please seated on the dais. Thank you, ma'am, for the brilliant talk and underlining the role of us clinical pharmacists in promoting medication safety. At this point, we will take a few questions from the audience, and these are the questions that have been sent in our WhatsApp group. Based on the time, we might not be able to take up all the questions. We'll take as many questions as we can in no particular order. First question is for Dr. Clinical Pharmacist at Continental Hospitals.
Well, obviously I've done a bad job for someone asking this question at the end of the day. The scope, as I spoke about this morning, is essentially limitless, because truly I consider every critical of healthcare profession in a hospital setting or a community setting to be equally valuable. So that at hospitals, as both the speakers have so eloquently illustrated this morning, you have a lot more role to play beyond just thinking you're a dispenser, beyond just thinking that you're verifying a prescription and just making it safe. That's not a big part. Here, you have enormous opportunity. You can be what you want to be. As Madam has just spoken about, you need to work with your doctors, you need to work with your nurses, and build a very formidable, collaborative team. At the end of the day, I wonder that why are we putting so much of burden on the pharmacists? The entire pharmacotherapy is not just your job. I constantly tell to a nursing director, Bobby, who's sitting here, many times we run into kind of jam our heads together, because when I say it's nurse's responsibility, and when we say it's the pharmacist's responsibility or the doctor's responsibility, I think this debate can only be solved, all of us coming together. In a nutshell, there is an extraordinary bright future. I believe all the pharmacists who are working in this city should aspire to work at Continental. I think Nishala is nodding her head there.
Thank you, sir. We have a next question to Dr. Baumick. Can you elaborate on the tools used in prescription audits?
So, as I mentioned, the tools are as similar as you would have it for your paper-based audit. So, you would actually look at, so when you do the digital prescription audit, the advantage is that sometimes these things, they come inbuilt in the you can discuss it with the supplier of the software. Can we pop-ups going up when the dose is being prescribed? Do you have pop-ups going up when you are giving drug duplication? So this is the advantage when the electronic system is being used. And at the hindsight, what happens is probably the time consumed for prescription audits is less when you're using a digital medium to do it. So it comes inbuilt in the system, and it, again, I would say it would be a prospective study design where you always have to define the parameters which you want to look at. And in many of the digital systems, you would have these inbuilt captured. It just needs to be understood. Manual effort, these piles of papers need not be there. So it's a very, very effective measure because it saves time. And we all know in healthcare industry, time is very, very crucial for the patients, for the industry as a whole, for the hospitals. So definitely I'm a big proponent of clinical decision system tools and digital prescribing tools. But having said that, many of the hospitals are not able to afford. And if you look at the public healthcare system in India, it's still a long way to go for them. So it is a desirable thing to have, but definitely not an essential thing to have for doing prescription audits.
Thank you, sir. Our next question is to Dr. Sangeeta Sharma. Ma'am, what do you think, can you elaborate on the measures to improve history taking and patient counseling?
History is an art that you have to take history about the presenting complaints, for what they can do for a prescription or a consultation in a hospital, and then what all counseling is the part, it could be related to the precautions, do's and don'ts related to the disease, how do you prevent that. Second part could be when a medication has been prescribed to you, what are the do's and don'ts with the medications. For example, simple thing like iron, when you start the patient on iron therapy, it causes black, coloration of the stool. And if you simply just don't explain this to the patient, he may get worried, he may get alarmed. The mother may say, my initial problem hasn't gone and another problem has been created with this medicine. So you just prepare the mother, or maybe counseling may be involving here. For example, diarrhea is something, number of stools passed is something which is very, very concerning to the mother. And, the history, she will come and say, the child has passed 10, 12 stools in just 4 hours or 5 hours time. So she is very anxious about this. So in counseling, the mainstay of treatment in diarrhea is rehydration. Deaths in diarrhea happen because of dehydration, not because of the septicemia. Death is not because of the septicemia. Death is because of the dehydration. So you can counsel. So, and then similarly, adverse drug reaction counseling part is very, very important. Many a times, doctors, they get confused because the presenting disease and the ADR may be looking just the same. For example, in my hospital, in psychiatry hospital, these patients have tremors. And they are prescribed valproic acid. Their mood stabilizers are prescribed. So these tremors increase in frequency or severity. So they cannot make out, is it the disease or is it the drug? Very often people label it to the drug. So, I always tell them, when you take history, take the temporal relationship between the first dose of the drug being taken and the onset of any new symptom or any exaggeration or exacerbation of the previous system. If tremors were already there and it is still continuing, perhaps it was the disease which was causing it. But after the tremors, after you gave the first dose, few doses of the mood stabilizer here, and if the tremors increase, certainly it would be due to adverse drug reaction. So that's the kind of relationship that you need to establish. Temporal relationship. We will be talking about other details, how do you detect these ADR, but simply history taking is important to establish a relationship between the drug and the adverse drug reaction.
Thank you, ma'am. We have another question for Dr. Guruvan Reddy, sir. Do the clinicians accept the interventions done by the clinical pharmacists regarding the medication errors, dosage adjustments, and rational use of antibiotics?
I think you're turning to be a little dangerous to me. Well, I think to give you a honest answer, good physicians, they should accept. Okay, physicians with the ego, which most of us are, at the end of the day, we think, we are walking gods and we don't kind of care what others are saying. It's a bad thing. But all physicians, I think, should listen to their co-workers. As I mentioned, your co-worker is your nurse, your co-worker is your pharmacist, your co-worker is your operations man. So we have to listen to them. Then only we can improve the system and make things safe. So in a nutshell, you're absolutely right. Doctors should listen and advise, educate, counsel, train, be lifelong mentors to their co-workers. And so do pharmacists. You should be learning lifelong, you should be mentoring lifelong, you should be educating lifelong. When we all do together, then we build a perfect system.
One way of convincing the star performers, star clinicians, star in your hospital is go back with the audit data, anonymous data. Just remove, which ward, which this thing. Just go back to them and just show them if they are happy with it, fine. But most of them will then appreciate when they see, what's happening.
I'll tell another story. When I was in the US for 3 decades, my initial responsibility in the early 30s was I was the chair of the P&T committee, which I truly enjoyed. And after my 3 years of term, I requested the hospital, CEO, I would like to serve again, which almost 5 to 6 years. The biggest trouble was with the star physicians. Now, the hospital CEO always had the greatest difficulty how to really discipline the star physicians. If you're going to go too strong against them, the physician may quit. So very often there is a soft accommodation by the hospital management to the so-called star physicians. How to get over it continues to be a challenge. So I think, we have failed in the US. There were always the same old doctors on that committee, those 3 or 4 physicians and one of those doctors, Dr. Zenuski, she was an endocrinologist, and probably even the Chinese script would have looked much better than what she just scribbled on the prescription. But she was a very popular endocrinologist. Nobody has any guts to say anything. So it's a challenge. It's a problem. It's not easy one, as
I
Dr.
know,
Sharma.
but I can share one experience. I was in Delhi, one of the very renowned hospital in Delhi. I delivered this talk on antibiotic use and all that. And after a few years, I went back again, and I had the same star physician. To get them on these programs is really very difficult. I understand that. But then he mentioned, ma'am, last time आपने बोला था कि अगर abscess है, so you can do with incision and drainage. Why do you need to give antibiotic for this? And I've been practicing this for so many years now, and I don't do this, don't prescribe antibiotics. It was heartening to listen to that. So, you cannot change everyone. In a group of 30 or 40 people, if you are able to make a change in 1 or 2 people, that's good enough.
Just to add to what Sir said, I'll just add another very important quality of physicians. They're very, very competitive by nature. So if you can instate any kind of competition in them, and I would say not even name them, just name the department, gastroenterology versus cardiothoracic surgery versus pediatric medicine, and we show that pediatric medicine has a compliance rate of 98%, and cardiothoracic surgeons have compliance rate of 38%. And you just kind of send that data, you will get a call from the Department of Cardiothoracic Surgery. No, I don't know who will call, not the HOD, but definitely a call will come, and then we can work on it. I think the most important thing is to have some kind of competition, celebration of the successes which we get on a smaller basis also. Because if somebody is showing 100% compliance rate, I'm very, very, very... I'm not ready to take that data. So we have to understand there will be non-compliances because healthcare people come and go. There are a lot of new people coming into the system. And physicians are here to stay. So
is another way. Storytelling is another way.
Storytelling, and also I think what Sir said, 5 mantras, communication skills. One way to tell somebody you're very badly dressed today can be said that you look so good, you could have been dressed better. So, that's how you actually pick up these over a period of time.
One other thing they've introduced in the US is giving report card to the doctors, a quarterly report card at the hospitals. This started about years ago. Now, what is this report card? Gives you your prescription pattern, which is extremely important. For example, in gastroenterology, we write PPI drugs, your proton pump inhibitors. Then they give a percentile information. This is against your colleagues, you're writing, you stand, you rank here. So that has started scaring people. Why are you in the 95th percentile of prescribing a particular drug? And repeatedly get this report card, you're summoned in front of the risk management committee of the hospital. So this is another thing. What you're just basically illustrating is about different committees sending this report card. This is how you stack up against your peers, and that should be really kind of help them very softly. So Nishchal, I'll just start report carding here with the help of respective HODs at the hospital.
Everyone, I now request our director, Shri Raghuvan Reddy, to kindly come forward to felicitate our speakers. They have provided such amazing insights and set the perfect tone for the day ahead of us. Can I at this point request Dr. Sangeeta Sharma to come forward for the felicitation? I would now request Dr. Subhrajyoti Bhaumik to come forward for the felicitation. I would now like to request Dr. Guru and for the felicitation. Thank you, ma'am. It's time now for us to catch a quick breather as we take a break for tea. Kindly be back in the auditorium by our next session. We'll be kicking it off with a fun activity as promised before.
Number, registered name in the screen name. If the registered name not you will from the quiz. Once everyone joins, the quiz can be started. Each one will have 20 seconds for you to answer.
Mind. There are marks for fast answering fastly too. Okay, 67 of the members have answered correctly. The answer is glucagon. Let's see on the top. Okay, Nida, you're in the first. Let's move on to the second question. And the timer is...
Answer quickly.
Come on, guys. True or false question? Oh, 152 have answered wrong. The correct answer is false. Let's move on to the leaderboard. Phobia is competing.
ratings are according to the timings. So answer first.
The third question. We know this. Okay, we really know this. Time is running.
Fastest finger first.
Okay, you have answered correct. The correct answer is AS inhibitors. Let's check the leaderboard. In the top, we shall find. Oh, Sobia, congratulations. And okay, we're taking time for this one. Oh. Enter.
Answer.
Top.
Here is the
last chance to redeem yourself. Come on, we know this one. Running. Okay. Only 58 members got it wrong. The correct answer is isoniazid. Who's on a leaderboard? Oh. I request the winners to stand at their respective seats. The volunteers will be handing over the prizes to the winners. The top 5 are Dr. Sai Chaitanya. Please come on to the dais. I request the Sai Chaitanya Ganapati, Kake Vijay Kumar, GMJ, Sobia Zainab. GMJ has been disqualified because of the name, as iterated earlier. Can you please say which college are you from?
I'm from Mallareddy College of Pharmacy, Kompally.
Okay.
Vijay Kumar from Sri Venkateshwara College of Pharmacy, Madhapur.
I'm Dr. Sai Chaitanya, clinical pharmacologist at Citizens Hospital.
I request Sobia, Zainab, Nida, Unnisa also to come on the stage. Dr. Ashwini Saumya. Could you please introduce yourself?
I am Nida Unisa from Pratap Narendra Reddy College of Pharmacy. Thank you.
I am Dr. Ashwini Saumya, clinical pharmacist from AIG Hospitals.
Thank you. For round, sir. Yeah, please.
I've done my 3-month internship at Continental Hospital in 2009. Thank you.
Okay, so hope that was fun. And it's time now for us to get back to our session. We'll be kicking off our second session with a panel discussion on a day in the life of a clinical pharmacist. Can I request Dr. Nischala Reddy, clinical pharmacist at Continental Hospitals, to kindly come forward to moderate the discussion. Dr. Nischala Reddy, Hyderabad. Dr. Nischala works as an organizing secretary for Pharmacy and Therapeutic Committee and Antimicrobial Stewardship at Continental Hospitals. She is designated officer where she evaluates the adverse drug reactions and performs root cause analysis. She is also experienced in preparing and implementing SOPs regarding medication management policies such as antibiograms, chemotherapy drugs, drug protocols, emergency medicines, narcotic and high alert medications. Dr. Nischala has some major contributions in training clinical pharmacists, students and other healthcare professionals to provide the best clinical services at Continental Hospitals, Hyderabad. We welcome you, ma'am.
That was a warm welcome. Now I request the discussion to be first is Dr. Shirpa Aralikar, Senior Consultant, Internal Medicine, Continental Hospitals, Hyderabad. Dr. Mohammad Hisham. So the Department of Clinical Pharmacy at Continental Hospitals, we have morning shift, night shift, we have PharmD interns and 5th-year students. So we have taken this initiative to start 24-hour clinical shift so that we can give a better patient care. And we have PharmD and 5th-year colleges as well. These are the roles and responsibilities I'm going to talk about. The first and foremost important thing is the medication reconciliation, daily ward rounds, prescription audit, area monitoring and reporting, training programs, this medicine counseling, antimicrobial stewardship, pharmacotherapeutic committee. In this slide, I'm going to quick brief about area monitoring and reporting. So we do the Continental recognized as Adverse Drug Monitoring Center, and we do report all the adverse drug reactions to PVPI. Once the adverse drug reaction is noticed by any nurse or a clinical pharmacist, So they quickly alert the physician. And then we do root cause analysis of the adverse drug reaction, whether it is a side effect, whether it is an adverse drug reaction. Thereby, we have a digital portal to raise an incident of all the adverse drug reactions so that everybody gets an alert that this patient has experienced an adverse drug reaction. Coming to the training programs, we have meticulous training programs that we conduct on daily basis to all the nursing staff, to the PharmD interns, fifth-year students. And next, coming to pharmacotherapeutic committee. In pharmacotherapeutic committee, we assess all the medication errors that have been reported in a month, all the areas. We do root cause analysis. We also look into whether in the root cause analysis, whether it is structure, process, or outcome-related errors. And thereby, we correct each step so that we can prevent medication errors happening again and again. And also, we redefine the formulary, drug formulary in pharmacotherapeutic committee. The remaining things I'm going to discuss in the further slides. So this is the connect that the clinical pharmacist should have with the patient. First and foremost important thing that I've mentioned is the medication reconciliation, which starts from the start of admission and the unit transfer to the discharge. So how we take care of a patient from the time of admission to the discharge is very important. During admission, we take medication reconciliation, which includes past medical history, medication reconciliation, and allergies. This note gives a proper document for a physician to decide what are the current drug orders to be written in the prescription. This, in a way, avoids drug duplications, adverse drug reactions. In the hospital stay, we do ward rounds and prescription audit. Why ward rounds are important? Can anyone? Let me just explain about that. So ward rounds with the physicians and ward rounds by the clinical pharmacist going to the patient care areas is very important to understand what are the signs and symptoms that patient has. For suppose, day one, the patient has written with the painkillers or any symptomatic treatment that we have written on day one, whether it has to be stopped on day 2 or day 3 in the subsequent days, so as to reduce the cost burden on the patients. And ensuring 5 Rs. What are the 5 Rs that we ensure? Yes, right drug, right dose, right route, right frequency, right patient. So these are the very important things that we have to ensure while we are doing a prescription audit and during our ward rounds. Therapeutic drug duplications are the most important thing because they could lead to serious adverse drug reactions. Drug interactions, dose adjustments, which include pediatric dose adjustment, renal dose adjustment, and hepatic dose adjustments. Area monitoring, as I've already mentioned, we have also taken an initiative to design an allergy card which we give to the patient while they're getting discharged, because we cannot expect all patients to remember the allergic medications that they are counsel them while we are giving the allergy cards as well. And the unit transfer reconciliation, even Dr. Sangeeta has spoke about this unit transfer reconciliation, which was very important when the patient is being transferred from different patient care areas. Coming to the discharge part, discharge medication counseling, where in a way to check and avoid drug duplications. Again, it is very important to counsel a drug why a drug is important for them to administer it. This in a way improves a medication adherence. Monitoring parameters, there are many medications where we have to explain them why monitoring parameters are important. Insulin administration education. The site of administration and the techniques of administration of insulin is very important. We have seen many adverse drug reactions because usually patients tend to rub the injection site, whereas like IV and IMs, like IMs usually we rub it, not for subcutaneous injections. We have to educate patients which route of administration it is and whether to rub the injection site or no. And inhaler administration techniques. We have different types of inhalers like rotahalers, half-puff kits, and nebulizers. When the patients are getting discharged on inhalers, we have to counsel them. Especially when the patients are getting discharged on steroid inhalers, gargling is the first and foremost thing that we have to counsel. Moving to the next slide, antimicrobial stewardship program. We have meticulously designed antimicrobial stewardship program. We have divided in 3 cycles, and whatever shortcomings we have observed in each cycle, we have been implementing in the next cycle. So our antimicrobial stewardship starts with capturing of RAM data in a RAM antimicrobial form, which we have designed in the first cycle. Then it follows with follow-up of culture reports if it is prescribed empirically or directed therapy. If it is empiric, again within 48 hours we have to follow up the cultures with microbiologist, and ID specialist also plays an important role whether it has to be escalated or de-escalated. And ID specialist takes a call. The same thing will be discussed with the primary consultant or the prescribing physician, whether if it has to be de-escalated, we communicate the same thing to the prescribing physician. For any reason, for any clinical condition, the physician wants to continue the RAM antibiotic, we have created a platform, de-escalation review form, wherein they can give justifications why they want to continue a RAM antibiotic. And all these justification forms, along with consumption data, and we do DDD as well for the antimicrobials, that we present in monthly AMS meetings. This complete data will help us to design the antibiograms. The extra mile that the clinical pharmacist, PharmD students are doing at Continental hospitals, we do clinical audits. The main important clinical audit that we have taken up is the antimicrobial stewardship program. The quality improvement projects, we have taken up medication errors as our quality improvement projects. We do failure mode effective analysis for the quality improvement project, and then we improve in each cycle. The paper publications, we have 3 studies underway, which we are going to publish in the future. As part of 5th year, PharmD 5th year curriculum, we have academic theses as well, and then clinical workshops, which will be continued every year. We have PharmD 5th year students and interns, as I've already mentioned. So I design all the postings based on their interest, their area of interest as well. So PharmD 5th years, we have OPD postings. They join OP rounds, IP rounds, and then they'll be working on thesis projects that they are assigned with, and they'll be collecting cases. Ward rounds with the consultants also they'll be doing. PharmD interns, they have IPD postings. They'll be overshadowed by the clinical pharmacist. They'll have full practical experience of how to obtain a history and how to explain a discharge summary, as well as they'll also follow the physician rounds. So we have scheduled weekly classes for all the PharmD students, interns, and clinical pharmacists that we conduct on weekly basis. Whenever there is a new case or a new study that comes up, we keep it in our weekly classes. Every Thursday, we conduct the classes. These are the questions for the panelists. So moving to the panel discussion, the first question would be to Dr. Shilpa. What do you think, ma'am? What is the clinician's perspective on a clinical pharmacist?
Yeah, good morning to all. Since I've seen what Nischala has projected, and I've been very closely observing the role of a clinical pharmacist at Continental, with Dr. Guru Sir's vision, who always thought that a clinical pharmacist is a need in a tertiary care hospital like this. But many physicians come from a background training where they don't know how to utilize best the services of the pharmacist. Here is growing. I think the role of the clinical pharmacist is strengthening, with all physicians also being made aware the utilization of a pharmacist in the hospital. I would divide it as IPD setting, OPD setting. So even the clinical pharmacist who's there in the OPD pharmacy plays an important role. We have a vaccination center where if vaccinations also, not only the IPD areas, but even critical care units where medication administration. So the time the physician writes medication and the delivery time, that's a big, long gap which has to be bridged well by the help of a clinical pharmacist. So I would say, I would put it as a very important role, consistent role, and you take the lead forward to make sure your is felt. If we go back to the previous, yes, no, other one. place. So we should make sure that the medication reconciliation is looked into, continue their statin and aspirin and not miss it out because they are unwell with a different reason. The antihypertensive can be continued. So that has helped a lot for better care of patients and not being out on their old medications. If he has a dengue fever and the platelet is down, we make sure the antiplatelet at that particular time. So that's very important. Now we have it on paper as well as in the computer, the online system. Having rounds help us ensure that they understand what orders are being discussed, what medical condition is being treated for. ADR, yes, very important. And discharge. So that it cannot be something that is written on the discharge. Make sure don't write the higher antibiotics at their own whims and fancies. So fear can't be a driving factor. There has to be a rationality in thinking when writing medications. So some feel only meropenem as a prophylactic drug during surgery may help, but that's not the case. So that is also re-looked, and this RAM form system has helped in building rational decisions. So that's the most important role I would put it. Yes. And each day is a learning, even for physicians, to highlight and understand the importance. And we are thankful.
Thank you so much, ma'am. Be in outpatient care areas to Dr. Shilpa Aralikar.
Yeah, so in the recent times, we had clinic joining as physician assistants. So that gives them one-on-one learning. So after they come out of college, many times they are like lost people, what to do, how to work. Though the internship is like, I think, a one-year program where they work in the hospital setting, but a one-on-one association with a physician helps them understand and move around these according to their area of interest, so they can gather information. So some days it could be, most of the times it's fixed, but if kind of say that they are more interested, maybe not surgical, internal medicine, it can always be rotated. So that exposure helps on one learning about drugs.
Thank you, ma'am. Next, moving forward, this question is to Dr. Grace. How a clinical pharmacist can help in antimicrobial stewardship? Can you please elaborate?
So, if you take the sequence of CDC, for any stewardship program to work, elements that they have set. First is a leadership. Your administration should be convinced that antimicrobial stewardship programs are important to tackle AMR. Next, a person who is accountable. A person for the program to run in a hospital. Having a good program in place is much higher than, so they revised it from 2017 to 2019. The core element by the CDC itself, they revised that the accountability can be with the ID physician or with the ID pharmacist. The third is regarding the drug. right? When you write a drug, when you prescribe a drug for specific indication, you need an expert to see the form what you are treating for. So if you take my hospital, for example, we do not have a full-time physician. Pharmacists run antimicrobial stewardship program. So we have an ID pharmacist driven program, and it's a very successful program. So we go for rounds. See, throughout my this 7 years, which is nothing but 7 years of experience, slowly we have collected things, we have studied the guidelines, we have done the board certification. So now we are confident enough to know what is rational and what is not. And applying the guidelines, applying the right knowledge, we are able to say, make sense of prescriptions in analyzing, analyzing the rationality of that antibiotic. So one best thing that I've seen is that, see, many hospitals struggle with the antimicrobial stewardship program because, like everybody was saying, the staff physician, it's difficult. I understand it's difficult. Why not go for the low-hanging fruits when it comes to antimicrobial stewardship rather than going for, straight away conflict with your staff physician? So the first thing that I do at 9:30, after coming after the classes, 9:30, we have something called the micro rounds. So the set of clinical pharmacists go to the microbiology lab, or our clinical microbiologist and us will come together to the critical care, either these two areas, with the cultures. We see the cultures which are positive so that it's easy for us to step down, rather than going around the bush with, talking in the dark, saying that this infection. If you have a culture, if you have a sensible culture, it makes so much difference. First example that I can give is Staph aureus bacteremia. That Staph aureus is a killer. It's a killer. And you won't believe how many rounds who are being mismanaged when it comes to Staph aureus bacteremia. There are bundles for Staph aureus bacteremia saying that you need to get a negative culture, you have to document the negative culture. So repeated cultures are necessary for Staph aureus bacteremia. And then from there onwards, 14 days of IV therapy is mandatory for Staph aureus. You have to roll out endocarditis. You have to get an ophthal consultation. So many bundles are there when it comes to Staph aureus bacteremia. So such small things, but life-saving measures. Similarly, so the same thing applies for Canada. Such small, gentle things, if you start with antimicrobial stewardship program, once you have the confidence of your physicians to run a program, rather not getting into the conflicts, it's easier to run. So first is a culture. So we get the culture, see the quality of the. If we are getting a sputum with a lot of epithelial cells and no pus cells, and saying that it's Pseudomonas aeruginosa, we know that it's a bad sample. We should not be treating that patient based on the clinical picture. So the culture is one thing. Then we get, like, I believe the RAM you said is the antimicrobial. This is second one. Patients on meropenem and above, or you set your own. For each hospital, they have antibiotics that are restricted. Linezolid is one good drug that can be restricted. It can be used in the OP because it's not audits and prescribing patterns. Talk to the doctor with confidence. See, that one question started with is, if I de-escalate for this patient, rates, will you take the response? Right? Yes. And it's right for the physician to ask that, right for the doctor to ask that. If you are confident enough, you can say yes. If you're enough, if you can be part of the treating team in convincing the patient, in the bystander, in talking to them, becomes the key. So so I had many conversations with many of the doctors, and now I know that they trust me to that extent that when I say a specific thing, like, a pharmacokinetic related thing, they're convinced that, this patient will not go into an adverse thing. And therefore the acceptance towards the interventions are much more. So that is the restricted antimicrobial antibiotics. Then we have monthly antibiotic audits, weekly audits, and we also have set in place. See, one of the best drugs that we have after time is ceftazidime-avibactam. Yes. Right? So empirical use of ceftazidime-avibactam is strictly prohibited in our hospital. So if they want to get ceftazidime-avibactam to have an ID consult, we have to check. You know, we give them that 24-hour time ID consult where we will see whether the patient needs that, and we'll talk to the doctor, and based on that we'll decide whether to go ahead with ceftazidime-avibactam or not. So this is what a daily activity of, you know, ID pharmacist for me. That teaching a lot of people, you know, starting then something that we are.
Adding to that, ma'am, how do you convince a consultant if it is a gram-negative cultures for it to be de-escalated?
Gram-negative cultures to be.
If the cultures are if the cultures are negative, how do you convince a consultant to de-escalate a ram antibiotic? If the cultures are negative. Culture negative
infections are difficult. I'm not saying it is easy. It is difficult. But see, the is to have a good rapport with the physician already. Yes. Okay. Before going and jumping the gun and telling them you have to start. See, if a patient is coming in septic shock, you have to give meropenem. Yes. You have to give a carbapenem. So, and see, when it is culture negative, it is quite difficult because you have to see your, you know, the ESBL rates and your specific to that syndrome that you're treating. Based on the you are having at hand, if the ESBL rates are not so much, it is good enough to tell them that as per, see, that is based on our policy also.
Yes.
When it comes to culture negative, it comes with the empathy therapy itself, right? It's directing convince the doctor saying that this is as per the guideline, because our ESBL rates for this certain infection, it's not so high. But like when you're having a ventilator-associated pneumonia, we know that Acinetobacter and carbapenem resistance is high. So giving colistin is in a way, you know, rational to save the life. That based on syndrome, based on your resistance, then already have a rapport trust of your doctor, then it becomes easy to convince them to shift to the policy, antibiotic policy for the empirical treatment.
Thank you so much, ma'am. Now I direct the question to Dr. Hisham. So what are the roles and responsibilities of a clinical pharmacist in emergency department?
So roles and responsibilities of clinical pharmacists in ED, it's quite easy to understand and identify what your ED needs. So patients on that, but I'll just quickly brief you on 3 concepts which. So in our hospital, we start with ED pharmacists, keeping in mind we'll start, our problem was identifying medication reconciliations for patients who come through ED. Most of the hospitals, more than 80% of admission happen. So a lot of things which could be in that point, like through admission, that could be identified and be sorted if you have an ED pharmacist. So 3 things which we particularly looked into is, one is admission medication reconciliation. Through ED, like we were able to achieve good numbers, we'll be sharing as next slide. So this is, second, we will look into the used in the hospital. So there's a prescribing inertia. An antibiotic is started in ED, it goes on to the floors. Yes. So it's very difficult to stop after that. So why can't we sort it at that point? So if I have prescribing inertia, it's already, you've done the majority of the job of. So that was one point. So these are for patients who were getting admitted. Second, we were reviewing prescriptions for patients who were treated from ED, particularly antibiotics, who went home. Was it rationalized? So this is another aspect where an ED pharmacist could work on, not only for patients who are getting admitted, but also patients who are going home with medications, particularly antibiotics, because this is something which has been commonly used as prescribed in the ED. So these were two things. The third thing is the role of pharmacist in codes and alerts. So a pharmacist plays a major role in codes and alerts. So for example, based on the hospital, what kind of they have different alerts, like code blue, semi alert, stroke alert, pharma alert, sepsis. A pharmacist, three aspects which we looked into, and we did it over a period of time, for which I would be showing the data and our results. And this worked really well in terms of results and for our patients, and it was it was really amazing to have ED pharmacists and set the department, because throughout the patient's journey, a lot of things which needs to be right in the initial part.
Thank you so much, sir. Thank you for sharing insights in various departments.
Can we have... May I now request Dr. Mohammed Hisham to come forward, as he will be providing us his insights into integrating clinical pharmacy services in the emergency department. Dr. Mohammed Hisham, clinical pharmacist, Cleveland Clinic, Abu Dhabi, clinical assistant professor of medicine, Cleveland Clinic, Lerner College of Medicine, the USA. Dr. Hisham works with the antimicrobial stewardship team and emergency department at Cleveland Clinic. Sir SEPTA for ASHP accredited pharmacy residency and pharmacy internship program. He holds multiple adjunct faculty positions and is the advisory committee member for various pharmacy programs in UAE and India. He holds American Board Pharmacy certifications in critical care, and he is also the author of over 25 publications and presented over 35 research papers worldwide. Dr. Hisham is a peer reviewer for the American College of Clinical Pharmacy's self-assessment program for infectious diseases. We welcome you, sir.
That's good. Yes, thank you so much. So next 20 minutes, it's taking you through the journey of ED pharmacist. So it's how we set up an ED pharmacy department, and how can you do it in your hospital, or it could be even if you're doing your rotations. Why don't you think about having an ED pharmacy rotation? So it's all about in this talk, and let's. Good. Okay. Not moving.
Closer, yes.
So I get 1 more minute. I was looking at the timer. So yeah, so I do not have any disclosures. So the learning objectives, by the end of this presentation, you'll be able to identify the barriers of having a clinical pharmacy service in the ED, key strategies to implement this service, and discuss effective ways to measure the impact of clinical pharmacy services. This is what we'll be discussing in these presentations. So you look at barriers in ED, there are quite a lot of barriers So most of them are like, it pulls you back from doing something and it's going at a very fast pace. So few of them are highlighted here. It's mostly physician related because it depends upon what level the physician is at, and there would be a knowledge gap, and sometimes those, because of that, the physician may be risk tolerant, and practice background may also differ based on physician, whoever practices in ED, and ED is quite a lot of turnaround. It's quite rapid decision makings and in limited duration. So that is one biggest challenge, and a lack of access to follow-up of these patients. So these are few challenges which are physician related. And if you look at the ED environment, it is like overcrowded EDs at some times. Time pressure is there. You want to quickly leave. A physician has 4 or 5 patients to take care, and it has to happen very fast. Possibilities of medication errors are also high, and multiple interruptions. He may be looking at a patient, another patient is jumping, shouting, or like code has happened, or that patient gets very sick, and it is like a multitasking. A physician is multitasking. Anyone who works in ED may be multitasking. There's a lot of things happening around at one time. And if you look at the next aspect of it, it is patient related, where health, it's big factor, where they may demand needing medications. They may demand, these are biggest factors. Emphasis on patient experience. A physician might feel uncomfortable sending patient without medications because he may, if this patient does come back to our hospital or does not come back to me next time and chooses someone else. These are few biggest challenges. Apart from that, the diagnostic uncertainty. Because when you see these patients on the floor, they have all those diagnoses, workup, everything. You have something there on chart saying, okay, this is the problem. But in ED, you have to start from scratch and zero, and that makes it more concerning and a challenge. Where do you actually, this is something which you have to look into, as I've mentioned. You have to look into what is the need for your hospital, what data your hospital needs, and working on that. You could do like a basic analysis by doing collecting and start analyzing where you can which are very important. Then we looked into timings. You have to work on the ED heat map, looking into what time the patient flows into ED and when the ED is busy. So these are aspects which are very important, because you don't want to be there in the ED and you have nothing to do, because it's not always the same ED. ED may be very peaceful. You may have nothing to do, to be very honest, but there may be times at which ED may be and you will have quite a lot of things to do. That's the time when you have to pick, and that's the time when you have to set when is the shift coming in. So we started off with a dedicated ED pharmacist, being in ED, taking responsibilities and roles, and it started off with an 8-hour shift based on the heat map, say starting from 11 to 7 p.m. That's the peak hour during that time, and we extended that to a 12-hour shift for every day. So this was only weekdays, then we extended that to over the weekend, and 12-hour shift, 9 to 9. And this kind of upgraded because our complexity of patients coming through ED also went on. So this was one point which helped us as well. So this is what we have after having our ED pharmacist in the setting. So 6% of the hospital orders were verified by the ED pharmacist, because that much of patients come through ED and that much of prescriptions are there in ED pharmacy. By the way, we use electronic medical records, we use Epic, and Epic, we've put it in such a way that any orders, any prescriptions comes through the electronic medical records, verified by the pharmacist, then only it could go on to the patient, or patient could get it. Exception for any emergency situations where a caregiver at the bedside can override this. Very few exceptions, but still majority of the orders comes after pharmacist verifies. And I told you the first major thing was medication reconciliation, where 43% of the hospital's admission, medication reconciliation was done through ED. And order verification time it takes to do for ED verification was less than 1 minute, because you actually know the patient. Call duration for a month was like 192 minutes, because we have pagers. So this is not like you have a whole conversation. 192 may look small in numbers, but all these calls might have lasted for 20-30 seconds. But followed by something which you have to do. So that would take another 5-10 minutes, or meeting someone, or being in a resuscitation bay for doing something. We have automated dispensing machines or cabinets where the medications are placed in the cabinet. Customized the automated dispensing cabinets so that 94% of the medications, they don't have to come down from the pharmacy. It's already there in the ED. So we customized based on prescribing practices. And transactions were quite good for the month as well. If you look at intervention, these are few interventions just for numbers. Most of them were dose changes, therapy recommendations, stewardship, drug discontinuations, and drug informations. This was during that initial phase. And if you look at admission medication reconciliation, our KPI was hospital KPI is to set above, like pharmacist sees and does the admission medication reconciliation for patients less than 24 hours, and it should be more than 90%. If you look pre and post data, it was somewhere on the 60s, and we could easily achieve, we could touch 94, 97 at some times, and all the time it was above 90s, because most of the admissions come through ED, and we could see those patients over there. If you look at taking part in emergency responses, a pharmacist has a huge role in these responses, because these are times when you get the doses wrong, or you get the medications wrong, or you need an expert to be there to tell them that this is the dose, and someone to proactively think. So you think that ED is a very fast moving place where you can't wait for the patient to get bad. You have to understand that what happens if this patient gets bad, 1, 2, 3. Those are your options. You won't get time to go back and refer and come back when you're in between a code or in between an alert. So you have to be very quick, and that has to be at very rapid pace. You have to be an expert to know the drug doses, indications, and contraindications. These are most common places where I would actually recommend, if you are starting ED pharmacy in this hospital, start with admission medication reconciliation, look into participating in these responses. If you have, we are not a trauma center, so I've not mentioned a trauma code over here, but code blue, yes, we do take part in patient. Then you start preparing all those medications there in the ED. Again, if patient's getting intubated, rapid sequence intubation, where you have to know exactly muscle action, sedation, analgesia, the dose, indication, and contraindication, because if you don't, you give it to the wrong patient, it goes completely wrong. And you have to get the right dose to the right patient for the right indication, which makes it very important in ED, because that decides the patient's thing, whether he gets well sooner, or whether he stays longer in the ICU, whether something deteriorates or not. These are few things. Plus, we have sepsis alert, where we make sure that bundles are followed. We give antibiotics, cultures ahead of antibiotics, all within the time of the bundles. Resuscitation is done. We have resuscitation bay, where apart from these code responses, pharmacist takes part in, say for example, anaphylactic shock or any other shock. Pharmacist plays an important role. STEMI alert, we are a chest pain center, so we have STEMI as well as stroke center. So these alerts are there. Pharmacist plays a major role in thrombolizing a patient or giving the medications like before patient goes for PCI. Disaster management is something which is quite important, where I've come across it's mass casualty. I've come across 3 times when a road traffic accident causing mass casualty, where a surge of patients, 20 patients or 10, 15 patients come all together at one time. Fire in a building and like gas explosion in a restaurant, things like that. So you need to be prepared, because ED pharmacists can play a role in preparing things ahead of time. And as an ED pharmacist, what I've done is I made sure that we prepare ahead of time, so that when a disaster management, no one panics, we are ready to get these patients. Education training plays a very important role. Training the residents, interns, weekly training for the nurses, monthly training for the physicians, having classroom and hands-on training for all the staffs of there. Basically, training focuses on how to operate the automated dispensing cabinets properly, so that there are no discrepancies, and scanning. We have barcodes medication administration, where they have to scan the medication to administer, so that less errors happen, and all these things are looked forward into. And again, dose, infusion, rate calculations. We have pumps, but still the initial dose would be calculated by the pharmacist, and the nurse would always needs a double check when pharmacist there directly goes onto the pump, and medication administration policies and protocols which you could put in place. We also play an active role in multidisciplinary teams, like in committees where operations, council, patient experience committees, quality improvement and updating the ED formulary, as well as patient safety meetings and something for the patient which improves the quality as well. We have our own antimicrobial use guidelines for the whole hospital. So as I've mentioned, there is prescribing inertia, so that getting the right antibiotic at start, it's very important. So we made sure that this is not just a PDF document available in your desktop or as a printout. Because we have electronic medical records, we made sure that this comes as order sets, which I would show you in the next slides, and physician can't deviate from our guidelines. So this makes a role even easier for the pharmacist. Like, so for example, this is we have, because of the electronic medical records, we built order sets in such a way that you can see these order sets, like patient ED order set, where cystitis, pyelonephritis, COPD, meningitis. You have options where they can click. Now we're coming into pneumonia, where it's non-ICU admission, like looking at patient's risk factor for a resistant bug or not. We're looking, we can give azithromycin plus amoxiclav. If patient has a risk of QT prolongation, we skip azithromycin, we give doxy plus amoxiclav, and then if patient's allergic to penicillins, then you go for moxif. Similarly, we also have other order sets for patients going into ICU. Plus, like we've already mentioned, it's not only for it's for all the infections we come in. Another problem we had is over-treating patients with skin and soft tissue infections, where symptoms where only incision and drainage was recommended, antibiotics being given. Based on this, protocols where patient did not have signs and symptoms, it would them not to prescribe, over-prescribe. And we also did a study pre and post, got published in Open Forum Infectious Disease, and it had a quite good significant improvement of appropriateness of empirical antibiotic, which helped us on the long run when the patient went to the floors. So that was one thing. And let's quickly go on to a case study. A 25-year-old female presents to ED with abdominal, no anorexia, fatigue, back pain, vomiting, constipation is not there, no localizing urinary symptoms, no allergies, comorbidities is not there, vitals are normal, pregnancy test is negative, urine analysis unremarkable, no pyuria. In ED shows E. coli, 1 lakh colonies. Would you treat this with antibiotics, or you do not treat this with antibiotics? How many for yes? Raise of hands. Antibiotics for this patient because E. coli is there in the urine. Okay, I have few hands, very few. How many for no? Okay, that's very good. But this may be very easy for us, but it's not. In practice, it's very difficult because patient may end up getting treated for asymptomatic bacteria. So this was one problem, either over-diagnosing, unnecessary urine culture. First of all, yeah, you don't have to treat, but you didn't have to even send a urine culture for this patient. Yeah, so that is first thing. So you over-diagnosing and over-treating. Maybe if the physician didn't know, they go and end up treating this patient. And this was one problem we identified. Our interventions were prospective audit and feedback, physician education, stopping the urine reflex, and pharmacist-led urine culture review, which is a study which we're going to publish. So our process, like, say, for example, a patient comes to ED with urinary symptoms, the physician sends urine analysis and urine culture. They initiate empiric antibiotic, or if the symptoms are kind of mild, they wait. There is something called delayed antibiotic prescribing the ED. Then the patient goes home, gets discharged from the ED. Cultures come back after 2-3 days. It comes in physician's in basket, and based on that, physician tries to order antibiotic and calls the patient and informs that you need an antibiotic. So this was a place where overdiagnosis, unnecessary cultures, plus unnecessary antibiotics for asymptomatic bacteria over there. What we did is, we had a detour for all of these. Diagnostic stewardship, we went in to stop urine analysis, urine cultures in our electronic medical records had to have an indication. Why are you ordering a urine culture? So that should be there. If not, you will review. Again, people misuse that as well, but still that would be also another thing which we are auditing, but still it's better than overdoing it as well. That is one. Pharmacists got access to physician in basket messages for the urine cultures. The pharmacist reviews this urine culture first. They stop treating asymptomatic bacteria. Appropriate cultures are treated based on what is recommended and timely prescribing. There's no delay, and also there are de-prescribing as well as shorter course of duration for antibiotics. These are the results I have. 26% reduction of treatment of asymptomatic bacteria, 17% inappropriate empirical antibiotics reduction was there, 4.9 reduction, 30 days readmission, because some patients may not get treated appropriately. They like cystitis when a patient has pyelo, and they end up getting readmitted, may also have hospital admissions. This is a result note which has been placed by the pharmacist. It says, for the same patient which I've presented before, it says patient has no urinary symptoms, urine analysis is completely normal, abdominal pain is related to previous gastro problem for which he is following with DDI clinic, suggests no treatment for asymptomatic bacteria. Next, on top you see a physician reviewing that, and it says, we call the patient, she has no urinary symptoms, so no antibiotics were prescribed. So another point where we looked into is, does really penicillin allergy exist in India? Because you don't have data, but looking into saying that patients have penicillin allergy, these are only few things which I could pick up from my literature search. It says cutaneous skin reactions or hypersensitivity. When you go into details, they say beta-lactam or some sort of penicillin allergy. This is a big concern in our hospital as well, or most of the hospitals who look into allergy. You see if patient has allergy or it's not a proper allergy, they end up getting higher spectrum antibiotics, and that goes on. So we created something where a pharmacist-led penicillin allergy assessment was done in ED. If it's not a true allergy, not an IG mediated or a non-IG mediated, we delabel the patient, and we have a protocol. We also place in notes, and we actually put them, and we kind of bring the antibiotics down. This has helped us. Another data which has been published in a very good infectious disease journal, 37.8 reduction in inappropriate antibiotics, reduced use of Moxif, Cipro, Vanco, and azithromycin for these patients because they were kind of it was labeled wrongly, and 23.9% of these patients were delabeled from having a penicillin allergy to not having. So that is something which is huge. So all these happened over a period of time. It's not something which happened quickly or over 1 year. So this is the timeline of how it happened. All of these happened after we did a pilot data analysis or point prevalence survey, and we also have to keep a track of how things happen after we do this. It's not just at one point you implement and okay, my job is done. So we kept analyzing that, and if you look at that, 2018 we did initially, I think I'll have 2 minutes. Yeah, because of that technical. Yeah. So, so the pilot study was done. So all of these, whatever things were implemented in between, we did these pilot study After that, we published protocols, data, we had our own data, we looked into pre and post, we published this, we presented this in international conferences, and we could improve our practice. So it does not stop in only doing things or getting things done. It should end up in going up ahead and publishing and putting this into literature so that hospitals in the region or other hospitals can learn from your practice and can start from where you exactly stopped. So these are a few important things. More opportunities for stewardship in ED is, I would say, expanding the ED culture follow-up. This would be expanding more into pneumonia and STDs, and again, skin and soft tissue infections. You expand pharmacists reviewing these, understanding the prescribing behavior for physicians so that we could improve our antibiotic prescribing further. No antibiotic viral infection order sets, developing ED diagram which would help learn better and where we see throughout the period. So how we measure data is we look into few aspects, like this is, we looked into process measures where are they compliant with the guidelines, they put in the indications when they order antibiotics, and are they compliant or not. It's like a Cardex on an electronic medical record. So it's this is just a part of it, but you look into most of these. Plus, as Dr. Guru has mentioned, you see who are the top prescribers. You take, so these are the list of antibiotic use measures where you look into DOT and you look at which provider prescribes more. The greens are the one who are within the limits, reds are the one who has gone beyond the limits. You go prospective audit and feedback. You speak to them, you mask these, but you tell them this is our level, but you've not here. Anonymous messages or things like that, or masking the names and goes off. This is how we measure. Identify the problem and problem areas. This is the most important take-home message which you should do having, and like also have a baseline data related to the problem. Assess the resources and the manpower you have. If you can opt for that, I would definitely, this is a big aspect because patients, 80%, more than 80% admissions are through ED. Start with low-hanging strategies, like I've mentioned, these are very common ones. Think innovatively, progressively, and as an ED pharmacist, you need to be very proactive. I would like to thank my colleagues who are also part of my team, and are my director and my manager. Thank you so much. With the 2 minutes, I think I want time.
Thank you, sir, for that wonderful talk on integrating clinical pharmacy services in the emergency department. I'm sure every single one of our delegates had something to take away from that. Okay, at this point, we will take a few questions from the audience. So our first question is to Dr. Nishchala. How do you find transfer of patients, and what are the transfers you are considering for reconciliation Continental?
So we do have patients from moving from different patient care areas like emergency, outpatient OPD areas, and from ICU to IPDs and IPDs to ICUs. So we ensure unit use the transcription errors which could minimize duplications, drug duplications, which could lead to medication errors. And I have 100% capturing of medication reconciliation that we are doing.
Thank you. Our next question is to Dr. Grace. It's to intervene in case of culture-based reports, but what if no cultures were sent in view of financial concerns?
Cultures were not sent in view of financial. See, that is, then you have a problem, just like how Dr. Hisham just presented. That is an area where you focus. See, how many times will you patient with antibiotics? The cost of that itself versus not sending the culture by itself will, justify the need for sending the culture in the first place. So for no financial reason, not sending a culture and by treating it with a high-end meropenem and piperacillin tazobactam is not just right. That's a problem area that needs to be corrected, identified, and, to be dealt with.
Thank you, ma'am. Our next question is to Dr. Hisham.
Can you please elaborate code STEMI or code stroke with any example and pointers for us?
So I'll start with stroke alert. So what happens in a stroke alert is you get a hospital alert sending it through the mic saying that it's a stroke alert. All the physicians, whole team members, you have a CNC or coordinator, nurse coordinator. For stroke, you have a neurologist, neurosurgeon, radiologist, ED physicians, pharmacist, and whoever is involved with the whole team comes to ED for seeing this patient. And it happens, they are alerted ahead of time so that when the patient comes, you are ready to see what happens with the patient. So that is one. And what role a pharmacist plays is if it's ischemic stroke, a pharmacist plays a role in thrombolysis. Okay, the checklist for thrombolysis. Plus, you look into again, we actually what we've done is we train the nurses to quickly dilute the thrombolytics by doing workshops, which with the kind of sample drugs or expired medications. That is one. Again, if the pharmacist is there, they do this. Second, blood pressure management for these patients with hemorrhagic stroke where the blood pressure is quite high. You need to know all these blood pressure cutoffs for all these stroke patients. Before thrombolysis, after thrombolysis, hemorrhagic stroke, you can't bring the blood pressure down from 240 to 120. So these are few things you need to keep in mind, what agents you give and what you need to monitor. A pharmacist is actually there doing these. So if it's a STEMI alert, what happens is the ED is already alerted through the ambulance. It's connected to the line in the system. So we see the ECG, we are ready, and even before the patient comes, we are alerted. When the patient arrives in the ambulance bay, they alert the STEMI so that all the people involved, like the stroke team, like interventional cardiologist, cardiology, or cardiothoracic surgeon, whoever is there in that STEMI team comes up in the ED, and they quickly make sure that we meet the time. So you know there are time for all these stroke as well as time bundles for stroke as well as STEMI. So you make sure that patients quickly taken for PCI if that's the only indication, things like that. Or like again, what happens? What a pharmacist does is that make sure that all the loading doses of drugs are given properly. We have order sets for that. We load it up appropriately. Plus, we also look into criteria if they've given loading doses in the outside hospital, things like that, so that they don't end up with double dosing, things like that, in the panic of time. So these are few roles, and as being there, you are drug expert. Anything else happens after this, in case patient gets intubated or gets worse and sick, hypotension, any of these patients, you exactly know what to do. This is always the common practice. Rarely all these happen, the hypotension or like rapid sequence intubation for these patients.
Thank you, sir. Thank you, everyone. Next up, we have Dr. Vijay Yaldandi, Director of Inflammatory Disorders and Infectious Diseases Clinic at Continental Hospitals, to provide us a clinician's perspective on medication safety. Dr. Vijay Yaldandi is a educator and a board certified in infectious diseases. He is a clinical professor of medicine and surgery at the University of Illinois, Chicago. He is the faculty at Public Health Foundation of India. He has over 3 decades of practice in both the USA and India and is experienced and knowledgeable in treating immune system ailments and inflammatory disorders. He is a resolute advocate for patient safety and infection prevention. He has received numerous awards for excellence in teaching and leadership for public health in India. Dr. Vijay is a member of Community of Practice for Implementing Public Policy, Harvard Kennedy School of Government. We welcome you, sir.
Thank you. Good afternoon, and thank you for the privilege of spending some time here with you, Dr. Nishtala Reddy and Dr. Gurunath Reddy. I will tell you, you heard a little bit about my professional areas, but more than that, I'd like to tell you that I first encountered the healthcare system at the age of 2. That's when I became a patient of poliomyelitis. And I have had numerous encounters with the healthcare system, not always particularly good. And therefore, I would beg your indulgence in understanding my emotional reactions to any kind of patient injury. I've been injured myself, so I know how it feels like. So I will tell you that when I was training 40 years ago now, it was rather, a very paradoxical situation. On the one hand, I was particularly concerned about ensuring that I never injured anybody. And at the same time, I was a rather self-assured young man. Dangerous situation. So I still distinctly remember a patient of mine that I saw. I still remember his name, Aloysius Duffy, a middle-aged gentleman with obstructive lung disease that came into my care. And, as an intern, I did the initial evaluation, wrote all the orders and took care of him and everything else. This man, by the time he came to us, was struggling because he had an acute exacerbation of his lung disease and was a retainer of carbon dioxide, pretty bad lung disease. Yeah, and I thought I had done a wonderful job, took care of detailed history, did all the orders, everything, picture perfect. And the next day I walk in along with my attending on rounds, and this man is practically comatose. And I said, what on earth? I did everything picture perfect. And my attending is going through the chart and looking at all of my history, the physical examination, and the orders. And then she sees this one medication and says, why on earth did you give this medication? And I said, look, that's part of routine orders. Everybody who comes to this hospital, I have been instructed as an intern that it is part of my duty, along with all of the admission laboratories and imaging and blah, blah, blah. This is one medication that everybody gets. It was culture. Guess what that medication was? Flurazepam. You give flurazepam to a man who has got bad obstructive lung disease and is a CO2 retainer. No surprise, his PCO2 went from 55 to 90. His pH all the way down, and he almost coded. I just fortunate that he didn't actually code, because had he had morbid obesity in addition to chronic obstructive lung disease, he would collapse his entire upper airway, and there was no way on earth we would have resuscitated him with a benzodiazepine on board. So I said, Vijay, you idiot. You're so self-assured. You are convinced that you will never hurt anybody, and here you go. All right, that was my first sort of awakening that the road to hell is paved with good intentions. You need a little bit of understanding what to do. And believe me, as a young physician in training, it created an incredible amount of emotional distress. I was so distraught. I couldn't sleep, I couldn't eat for days after that. Right? There's yet another one that I encountered. There are many such stories, and we could go on, but I was told 20 minutes, that's it. So I will not bore you. All right? I will tell you that as a chief medical officer, I investigated many, many such instances of bad outcomes of patients. This is a recurring theme that we will talk about. But I want to talk about yet another very interesting, or I should not call it interesting, I would call it memorable experience that is seared in my consciousness. I was asked to come and evaluate a patient with fever and rash, and she was very, very ill. So I walk into the patient's room, and this is a patient with Stevens-Johnson syndrome, very ill. So I said, what happened? So this was a young woman who was on dialysis. She was on her way to the transplant clinic to get, evaluated for transplant and so on and so forth. And unfortunately, on the way to the hospital, she had a seizure. So the emergency people, the ambulance, diverted her to the nearest hospital, which is where I was. And the emergency room doctor, very nice, good, conscientious, careful doctor, saw this patient. She had a wristband that said seizure disorder and said allergic to Dilantin. This was dutifully noted by the emergency room doctor in the notes. Allergic to dilantin, will not give dilantin, will use Cerebrex. Just so you know, in the United States, dilantin is the proprietary name for phenytoin, and Cerebrex is the proprietary name for fosphenytoin. So yet another example of how very well-meaning, good people can make mistakes. All right? So this is what we look at. Whenever we see a bad thing happening, and I've investigated a lot of bad things, as I told you, I look at the bad outcome. And then when I see a bad outcome, I start investigating. Are the people, the method, the measurement, materials, environment? It's a very systematic way of looking at things, because that's what caused a bad outcome. So the key thing that we should remember is recognize high-risk situations and improve the risk. That is to prevent human error, and then stop. Find an expert. So it's a high-risk situation, high-risk behavior that leads to an event of harm. So believe me, if you ask any young person who has just learned driving, what a thrill they get by speeding. Okay? And then you say, look, do you realize that if you go too fast, you might end up in an accident? He'll say, of course. I never do that. There's stupid people who speed and end up in accidents. And then, you know, after you've had your first glass, which I did as a young teenager, of alcohol, I say, you know, yeah, I know, I'm a very responsible drinker. But the only trouble is our ability to count the glasses of whiskey stops at the third glass. After the third glass, it's always the third glass. All right? So if you combine these two things, you know, 3 drinks and a new motorbike, you get a donor for hearts and kidneys and livers. That's why we call motorcycles donor cycles. All right? So that's the key. High-risk situation, high-risk behavior, bad outcome. Now, why does all of this happen? Because we as human beings, we are used to linear thinking. You know, there is an action, there is a reaction. This is the Newtonian cradle, right? Very simple system. The problem is, now to make this a little bit more understandable, you should always think, you know, if something is going to happen, think about, you know, how frequently does this happen? If I walk out of the house, am I going to be hit by lightning? So, yeah, very unlikely. I've got to go to the hospital and worry about it. It's not going to happen. Okay. But, you know, on the way, and get into a traffic jam. Happens all the time. Then you got to think, okay, if there's a traffic jam, what am I going to do? I'm going to take an alternative route and come there, right? So we always think prior probability, then we adjust the probability, and then we come at a posterior probability. This is what we all do. How many times have you heard, doctor, don't worry about this, I've given this medication 1,000 times, nothing happens? Have you heard it? By the way, I forgot to mention, I am so elated. Firstly, Nischala is leading this entire thing. So many women. So, yeah. So, this is the other thing that you think about. You know, when we are going into the hospital or any system to take care of patients and into back. Or, you know, you just heard previous speakers, hey, in the ED, we should have all of these protocols, blah, 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 everything. We are ready. Boom, 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 boom. The problem is that nothing goes according to plan because, like, strategy that survives first contact with the enemy. So you got to be prepared to improvise. So this is what the US Army did. They introduced this concept of volatility, uncertainty, complexity, and adaptability. And basically what this means is you got to be ready. All things are going to happen. You orient, you decide, you act. And there are lots and lots of feedback loops. This is called the OODA loop. Nowhere is this more important in care systems. Because all of health adaptive system. What does that mean? What's the difference between a simple system, a complicated system, and a complex system? A simple system is a Newtonian cradle I showed you.
A complicated system is trying to work for a boss who doesn't like you and you don't like. Big problem, very complicated. The difference between that and a complex system is, in a complex system, there are many different agents all interacting with each other. And what happens is that all of these equations are nonlinear, not very easy to calculate. There's a boundary, there's input, there's agents, there's entropy, there's strain. I'll tell you what it is. But the bottom see what we call emergence. That's one, because all of these things interacting together cause something to emerge that cannot be predicted a priori with certainty. We call a sensitive dependence on initial conditions. This is the butterfly effect. A small butterfly, fluttering somewhere can just storm somewhere else. Then there is what we call a strain. Okay, a strain factor that has the ability of being predictable, ability to skew the entire system some way. This is your star physician in the hospital. So chaos. About 25 years ago, I read this book about chaos, and that's what got me thinking about all of these different things. So again, we talked about small differences in the initial conditions leading to big changes in total outcome. And climate, these are examples of. Now, the other thing that I want to think about between a normal distribution and a power law distribution. I'll tell you what this is. Because my good friend, Dr. Meeraji Rao, wanted me to talk about high-risk medications. So we'll tell you what these are. Now, remember I said that, most people are very comfortable. I've given this drug so many times, nothing has happened to me, I'm a doctor. Why do they say that? It's because of the normal. Anything and everything that happens usually has a normal distribution. That, most of the things happen over here. And if you take one standard deviation this way, that way, you got 68.2%. If you take two standard deviations, you got 95%. And if you take three standard deviations, you got virtually all of it. And this is our usual experience. This is why it is not always possible to persuade somebody that, look, what you are doing may not necessarily be a great idea. I know you've been on the motorbike a gazillion times. I know you've had 3 operated on very complex surgeries and nothing's happened. Something, this is what we call the Pareto principle, which means that 20% of the phenomena result in 80% of the outcomes. Okay, so this is what it looks like. Look at all of the bad outcomes, and you plot all of the bad outcomes over this here in the y-axis. And what you will find is there are very few drugs that result in all of the bad outcomes. Okay? And if you plotted this on a log scale, log this way, you will find a straight line like this. That's what is called a power law distribution. Now, interestingly, all of these things that obey the power law distribution, they are the tail end of the normal. Now, one way to understand this is, look at all of the people in this room. If I plotted all your heights, you would get a distribution. Most of you would be somewhere in between 5 and 6.5 feet. There are some very tall people I know, but, right? All right. And this is why you have to think that of all of the drugs in your armamentarium, there are a few what we call the usual suspects, and they all fall here. So think about your high-risk medications. Okay? So, don't put your patient on 3 different drugs that prolong the QTC interval and then call in Dr. Miraji Rao to resuscitate that patient. Not a great idea. All right? So this is the key that we have to think about when we think about safety. Now, why do I say all of this and why do I pick on drugs? The reason is, about 20 odd years ago, the Institute of Medicine came out with a publication, To Err is Human. And they found that there are probably 100,000 avoidable deaths in the US healthcare system, iatrogenesis. And believe me, the number 1 cause of iatrogenesis is drugs. The number 2 cause is invasive procedures. Okay? So this is why whenever I want to find preventable bad things, where do I go? I go to the intensive care unit. This is where all the drugs and all the interventions occur. All right? So I hope you've enjoyed that, because now you got to think about some human factors engineering. Why do people do things? Okay, and this is Ian Rasmussen, who created the SRK model. What do? There's skill-based performance, which is autopilot. You've learned swimming, you can swim all the time. You've learned bicycling, you can do it. Or you use a rule-based performance. There are certain rules, you obey the rules, you'll be okay. Or if you don't have a proper rule, then you have to use your knowledge and everything else and use ChatGPT to come up with some solutions. The problem is ChatGPT gives you wrong answers. The other day I asked ChatGPT, who was the person who decided that you should reinforce the non-bullet ridden parts of the warplanes? And ChatGPT told me a very strange answer. Then I started thinking, why is ChatGPT giving me the wrong answer? You see, I had asked warplanes, bullets, engineer, aeronautical engineer, Great Britain. So ChatGPT decided that England is famous engineer, Rolls-Royce. Warplanes, Britain had lots of warplanes. So it came up with the answer that it's Henry Royce that came up with this idea. And so it's completely wrong. A mathematician called Abraham Wald, who first noticed that looking at statistical data about what's happening, all the warplanes that were returning, they had bullet holes in particular areas. So he deduced that the warplanes that are not have got bullet. All right, so he said armor that area and more warplanes will return back. So this is one of the things that we should always think about. When we see something happening, there's things that we look at and we come to some sort of a conclusion, but about all the things you can see and have not seen answer. Now, these are all of the ways that humans make mistake. Forgetfulness, misunderstanding, wrong identification, lack of experience, willful ignoring of rules. This is, what we call this? We call this normalization behavior. I'll give you an example. My driver went through a red light. So I stopped him one day and said, Raju, what on earth is going on? How come you're going through a red light? He said, I never go through a red light. So why do I have this challan at home? Oh, no, sir, that time there was no policeman there, there was no traffic there, so I went through it. Okay, this is called normalization of deviant behavior, all right? And are inadvertent sloppiness, they don't think, they're slow, there's lack of standardization, there's surprise, there's something that they've never encountered before. But finally, there's criminal behavior that you cannot change. If you find criminal behavior, better call the police. All right? So that's all I had to say. So I'm glad that you are all becoming doctors. My definition of a doctor is somebody who does 2 things. You take care of people and you teach, because doctor derives from the Latin docere, which means to teach. And thank you for coming.
May I kindly request you to be seated on the dais, sir? Thank you, sir, for that amazing talk on a clinician's perspective on medication safety. Speaking with such immense clarity and simplicity, you have truly brought some wonderful insights for the audience. We now move on to our next subject on Antimicrobial Stewardship Program by Dr. Grace Mary John. Dr. Grace Mary John, infectious diseases clinicist and chief clinical pharmacist, Believer Church Medical College Hospital, Kerala. Dr. Grace is the first and the only American board-certified infectious diseases pharmacist in the country. She is the assistant professor of Department of Pharmacology for medical students. She is the international brand ambassador for the Society for Healthcare Epidemiology of America. She is also responsible for antimicrobial stewardship site observations at Detroit Medical Center, Carmenas Cancer Center, Detroit, Michigan Tufts Medical Center, Boston, the USA. Dr. Grace is the president of Federation of Clinical Pharmacists in India. We welcome you, ma'am.
Good afternoon. First of all, I want to thank Dr. Vijay for that absolutely brilliant that you delivered. Now coming to my topic, I'm given 20 minutes to have a case-based approach for antimicrobial stewardship. So we know that from the morning itself we've been hearing about the misuse of antibiotics. We have tons of data saying that there are so much of drug abuse, whether it's in animals, whether it's in humans, in hospitals and everywhere. And Dr. Sangeet pulled up this data saying that by 2050, we will, if not taken properly, antibiotic resistance will take over cancer as the #1 killer when it comes by 10 million deaths by 2050. Now, driven with this antimicrobial resistance, if you see on the left side, this graph that shows is that the amount of input a company puts in to develop a new drug and how much they get out of it. So you see that antibiotics come towards the last one. You put in a lot, but you don't get anything back. Therefore, all the major manufacturers are backing out from manufacturing or into the research of new antibiotics. And with the resistance rising, we see that it's dwindling. We are not left with a lot of antibiotics. And when it is particular with India, our problem is the numbers. Our problem is the patient load. We are such a populous country. I think we are about to overtake China, or have you already overtaken China? We have already overtaken China. So, with this much patient load and with this much economic restraints that we have, the reason I said economic restraints for expenditure when it comes to patients in India, you see India #1. If I get an infection, I have to pay it from my hand because medical insurance may not work for me, or maybe I don't have medical insurance. For most of the patients that are from India, this is a problem. So when treating an AMR, you are treating people with high-end antibiotics, high-end agents, which are costly. And one infection like Dr. already mentioned that, one infection can actually pull them from a middle class to a lower class because it's very costly. Now we know that the answer towards this is antimicrobial stewardship. Okay, and this is published with the ICMR with regard to the AMSP programs in India, and the last line there says that there is absence of physicians and pharmacists that are working and requires careful attention. I don't see a dearth of clinical pharmacists. I see a dearth of trained clinical pharmacists. So my dream is so that to train clinical pharmacists to become the workforce that drives stewardship programs in India with an ID physician or an ID trained pharmacist or even a clinical microbiologist who can run the show, and we as the workforce, drive the antimicrobial stewardship programs in our country. Now, before going into the cases, I just want you to have this workup framework
whenever you see a case, whenever you are seeing a case, you're basically looking at the rationality. You're justifying whether the drug is rational or not. These questions: is the patient really infected? What are the healthcare associated risk factors for the patient to have a multi-drug resistant organism? What is the source of infection? Mostly, we always skip this part. You know, we are so busy, treating the cultures. We tend not to ask ourselves whether the patient coming, what is the source? So what are the typical organisms that are associated with that site, so that you can choose antibiotics accordingly, and which antibiotic will give that cover for that specific syndrome, for that specific site, and for that specific risk factor for MDRO. And what are the patient or disease specific factors? If the patient is having chronic kidney disease, or the patient is having chronic liver disease, or whatever allergies the patient is having, so that certain number of drugs can't be given, which helps you to come with your empirical therapy. This itself is a lecture in itself, but I want you to have these questions in mind, and you daily reassess the patient for the rationality and deprescribing and your prospective audit. Okay, so this is a basic framework stewardship program for the prospective audit. Okay, now usually I go with the urinary tract infections to talk about the cases, but today I thought I'll shift gears and take pneumonia for a fact to tell you why it is important. Now, the epidemiology of pneumonia, the burden of disease is very high, because especially when you compare the mortality in the elderly, like in the morning, Dr. Bhaumik was saying that our geriatric population is going up, right? So the number of patients who are actually, dying of pneumonia are also going to go up. And this is the data that the mortality rate is very high. Now, the problem when it comes to respiratory tract infection is symptoms are vague. Whether it is common, whether it is pharyngitis, whether it is epiglottitis or laryngitis, bronchiolitis or pneumonia, you have certain symptoms that are very non-specific. So based on the presentation itself alone, you will not be able to treat a patient. Okay, I'll go to the cases. So you have a 26-year-old female. She's pregnant. She's into her 3rd trimester. She has no comorbidities. She's coming with fever, sore throat, running nose, and headache for 1 day. She's febrile. Pulse rate is 90. BP is okay. Respiratory rate is fine. And the respiratory system, the sound, everything is within normal. Now the question to you is, how would you manage this patient? Now I don't have much time, so you have to be very quick. So is it A, you avoid any treatment because the patient is pregnant? Please raise your hands. B, is it supportive therapy for her symptoms, like paracetamol, or because she's febrile? Yes, I can see some hands. You quarantine the patient and give her oseltamivir? How? No. Test and give oseltamivir? No. Admit and observe the patient for compliance? So those who have not raised their hands so far, which category do you belong to? So this is nothing but a common cold, right? See, this is where our arrogance comes in. We think we know the right answer, and we know that common cold is basically because of the viruses, and we have influenza. Okay, we have influenza A, B, and C. But do you know the risk factors for patients with influenza? Whom to treat and whom not to treat? So if you see there, the second risk factor is pregnancy. Okay? Therefore, for this patient, ideally treat with oseltamivir, especially in the 3rd trimester, because we currently have actually a patient who is, H1N1 positive, on an ECMO machine, struggling. She has already, a premature baby has been delivered, but she's struggling for her life because of influenza. So you treat in a female patient who is pregnant. Okay? Because usually we say that not to treat not to give antibiotics. Antibiotics I'm not saying you should give, but know where to give, how to categorize a patient, and what are the risk factors associated with a symptom. So you treat this patient. Now, antibiotics should not be used for uncomplicated influenza and to prevent a bacterial complication. Okay, because of this, do I get a bacterial infection is something that I should, avoid giving antibiotics for, but should be given for the high-risk population. Now, my second case to you is a 72-year-old male who's a smoker, who is known case of COPD, hypertensive, coming with fever, cough with expectoration. So this is nothing but an acute exacerbation, and the patient is having mild altered sensorium. There is pleuritic chest pain. The patient was complaining of pleuritic chest pain since 3 days. Okay. On examination, febrile, BP on the lower side, the respiratory rate is sky high, and saturation is also on the borderline, but it's a COPD patient. Okay. Creatinine is high, urea is high, okayish urine output, and you have fine crepes. And this is the X-ray of the patient. Okay. The case is clear. Now the patient is shifted to the ICU and started on piperacillin tazobactam, 2.25 Q6H, azithromycin 500 mg, and oseltamivir. Cultures were drawn before administering the antibiotics. So for this patient, you first see what is the microbiology. You categorize the patient based on severity. You find which all investigations you need to send, and resistance of for the organisms that you have, host factors that you need to consider before treating the patient. My question to you: you are this who is rounding the ICU team. Okay, how would you therapy? Please have a careful look at the answers. How many of you would hike the antibiotic from piptazole to meropenem? Any show of hands? Okay. How many of you would de-escalate the patient from piptazole to ceftriaxone? Again, show of hands. Stop azithromycin as it's not required. See? I can see some hands. Add vancomycin as the patient is sick. Thankfully, nobody has. Yes. I'm happy with the current treatment. Yes, I'm seeing some hands. Something else is bothering me. So I'll come to that. Now, you know the pathogens that are commonly associated with community acute pneumonia. It's in the literature, it's everywhere. So, based on your patient type, based on your patient who goes into more critical ICU or IP, you have various studies, the common pathogens that you're having at hand, and you also have something called CURB 65. You know this one, right? CURB 65. Urea, respiratory rate, blood pressure, 85. So based on that, you can decide whether you OP, IP, or ICU. It's just a guide. It's not that it should be done like that. It's just a guide so that to help you with your treatment. So for this patient, what is it? What is the score for this? Patient is having confusion? Yes. Uremia? Yes. Respiratory rate more than 30? Yes. Blood pressure less than 90/60? No. Age above 65? Yes. So it is CURB, right? Ideally, where should the patient go? To the ICU. Okay, so you admitted the patient in the ICU. That is the right? You require the blood cultures and sputum, which were already connected. And based on the, just to get some clue as to what pathogen it is. Usually it is the lobar versus the interstitial pneumonia. So this is something that can be helpful, but it can be very vague also. This is only a guide. It's not that this is how it is going to present. Now, based on the IDSA guidelines, how do you treat the patient for ICU? You give ceftriaxone plus you give azithromycin. Why? Because you need an atypical coverage. Okay. So are you happy? What was our patient on? Piperacillin tazobactam, azithromycin, and oseltamivir. Okay. Now I'll again come back to that question. How many say yes to one? I mean, A, hike the antibiotic meropenem? No. To ceftriaxone? Some hands. Stop azithromycin? No. Vancomycin not needed. I'm happy with the current treatment? No. Something else is bothering me. Now I showed you the IDSA guidelines. This is where you get, you know, in a way, misguided. Now CMR guidelines. Okay? This is the international, this is the ESBL rates are so high. ESBL means our third generation, the resistant to third generation cephalosporins are so high. This is for patient. Is this patient a COPD patient? A COPD patient is automatically, you know, comes under the high risk for Pseudomonas. So you need to give some Pseudomonal coverage. And because it's an influenza season, right? So actually the treatment is in a way right. But to me, the answer for that question is E. Something else is bothering me. Can anyone say what is that thing, that one thing that bothers me? I told you the treatment is right, but there's something that's bothering me. The dose of the antibiotic. Piperacillin was given to 6. Okay. Creatinine was high. I understand. If you calculate your or EGFR, it will come below 40. Therefore, yes, 2.25. Patient. Does this patient have a baseline CKD? This is a sepsis, and the patient is having good urine output. The patient is sick. So you're basically underdosing. You have not given your loading dose. Okay? The patient is having good urine output. To have a patient in the ICU. This is where I think, like Dr. Hisham was saying, in emergency, this is where, you know, having a pharmacist in the emergency matters so much, because the first dose usually goes from the ER. So if you tell your patients, you know, the loading dose, that itself is a big game changer. Easily that is something that you can do in your practice. And if it is a sepsis-induced AKI, because this patient is having a sepsis-induced AKI, okay? Patient is not in, but with AKI, with a good urine output, you can give full dose, at least for the first few days. Why is the patient having AKI? Because of the sepsis. So if you treat the sepsis well, your AKI will come down. Okay? So otherwise, like sir is saying, if you protect your kidney, you will deal with a dead patient. Okay? Okay. So one other thing, if the patient presenting with a BT bar 50, okay? This is, does any of this change in your treatment? The answer to that will be, you will hike your antibiotic to meropenem, because this patient who is coming in septic shock, carbapenem has to be given because our ESBL are above. Okay, so we have to treat with carbapenem for any, whether it's pneumonia, whether it's UTI, whether it's skin and soft tissue, septic shock, first line is meropenem. Okay, now you have a 37-year-old male with organophosphorus poisoning, stable on minimum ventilatory support. Day 6, new onset fevers and purulent ET secretions with increased oxygenation and PF, and there is a fall in PF, and there are scattered crepitations in the lower lobe, and chest X-ray shows consolidation. Now the patient is started on meropenem and vancomycin. Okay? You know the definitions of HAP and VAP. So this is a straightforward case of ventilator-associated pneumonia. Okay? Now, there are certain guides that can help you to assess whether the patient, you know, whenever a patient is on a ventilator, when they deteriorate, what are the things that you take care, you see whether to, you know, classify the patient into ventilator-associated pneumonia. These are the things that you can use. I will not go through this. The question to you is, what are the key you need to decide medical therapy? Do you need to give combination therapy? Do you need to add a gram-positive cover like vancomycin for this patient? What are the things you need? You need to to know your frequency of arrow and how whom you are treating with VAP. What always do who did what went bad, you know, the things that you can see, who did not survive, and what was the therapy, initial therapy that was started for that patient, and what was the culture, you know, eventually. So always see what was the treatment failures. So this is a good audit for all of you to do, and to ensure that you have the right cultures. And these are the risk factors, whether, you know, whether you need to see if you have to, because VAP, definitely you have to cover for MDRO, but do you cover for Pseudomonas or do you cover for MRSA? It is based on your ICU prevalent rates, the rates for MRSA and the ESBL and carbapenem and all these. So your local angiogram should have the ESBL rates and the carbapenem rates. So if your carbapenem rates are high, and if there's a patient who is having VAP and the ET cultures of your ICU is having more than 10% of carbapenem resistant, maybe you have to hike up to even polymyxin or colistin. And if your MRSA rates in the ICU is more than 20, that may be a reason why you add your vancomycin. And because I know most of you are students, these details you didn't know before, right? These rates actually matter. So I'll finish. So the patient was started on antibiotics, meropenem and vancomycin, fever settled, patient is better, oxygen rates have come down, secretions have stopped, culture showed Klebsiella pneumoniae, which is resistant to cefuroxime. What does that tell you? What MDRO is it? It's an ESBL. Third generation cephalosporin resistance is ESBL. Okay, so no MRSA in culture, so you step it down to Piptaz and you stop vancomycin. And the most important part, you need to treat only for 8 days for ventilator-associated pneumonia. You have very strong data suggesting that if the patient is actually improving on the treatment, you can stop within 8 days. So I'm just giving you a glimpse of, I've just taken one syndrome, I've just taken one organ, and I've just showed you how we can go wrong, where we can go wrong, what all things we need to know before jumping the gun and telling, hey, that is wrong, that empirical therapy is wrong. Okay, certain things we need to study. So with that, give you, can we be the antibiotic guardians? Okay, so thank you.
May I kindly request you to be seated on the dais, ma'am. Thank you, ma'am, for that wonderful talk on antimicrobial stewardship. I'm sure every single one of our delegates has something to take away from that. At this point, we'll take a few questions. First question is to Dr. Vijay. How does pharmacogenomics, antimicrobial resistance and stewardship?
So, you know, pharmacogenomics actually helps you in thinking about unusual adverse effects in somebody that you're going to give a drug. So the best poster child for pharmacogenomics really is warfarin dosing or clopidogrel dosing, right? Because you can predict a priori who will respond, who's not going to respond. Now, in infectious disease, what we have now started doing is using a lot of NAT diagnostic. Okay. Because it gives you of what kind of organism or pathogen you might be dealing with. And if you are able to predict what they're usually susceptible to, wonderful. Now we've gone one step further and we've started looking at predicting the presence of resistance, not susceptibility. Please underline that. Predicting the presence of resistance by picking up specific
for each one of them. Can I at this point request Dr. Mohisham to kindly come forward for felicitation?
By itself will, justify the need for sending the culture in the first place. So for no financial reason, not sending a culture and by treating it with a high-end European and piperacillin tazobactam is not this way. That's a problem area that needs to be corrected, identified, and to be dealt with.
Thank you, ma'am. Our next question is to Dr. Hisham. Can you please elaborate code STEMI or code stroke with any example and pointers for us?
So I'll start with stroke alert. So what happens in a stroke alert is you get a hospital alert sending it through the mic saying that it's a stroke alert. All the physicians, whole team members, you have a CNC or coordinator, nurse coordinator. For stroke, you have a neurologist, neurosurgeon, radiologist, ED physicians, pharmacist, and whoever is involved with the whole team comes to ED for seeing this patient. And it happens, they are alerted ahead of time so that when the patient comes, you are ready to see what happens with the patient. So that is one. And what role a pharmacist plays is if it's ischemic stroke, a pharmacist plays a role in thrombolysis. Okay, the checklist for thrombolysis. Plus, you look into again, what we've done is we train the nurses to quickly dilute the thrombolytics by doing workshops, which with the kind of sample drugs or expired medications. That is one. Again, if the pharmacist is there, they do this. Second, blood pressure management for these patients with hemorrhagic stroke, where the blood pressure is quite high. You need to know all these blood pressure cutoffs for all these stroke patients.
I said was pure balderdash. And we should all take some dofelatide to reduce the QTC.
I would now request kindly come forward for felicitation.
So heavy. She did a great job.
Thank you, sir. Now let's break for the lunch. Kindly be back in the auditorium by 2:45 p.m. We'll be kicking it off with yet another fun activity. Thank you.
JSS College of Pharmacy, Mysore. Dr. Aksa completed her Doctor of Pharmacy in 2016 and specialized in cancer care by completing her residency in clinical pharmacy in 2018. She is the first clinical pharmacy resident in India and has also presented and published several papers in the field of oncology in various national and international conferences. Dr. Aksa has conducted various outreach programs to create awareness about cancer in public and is currently pursuing her doctoral studies in geriatric oncology. I request the panelists of the session to kindly come on to the dais. Dr. Subhrajyoti Baumek, Clinical Pharmacologist, Clinical Director at Peerless Hospital and B.K. Roy Research Center, Kolkata. Dr. Vijay Aldandi, Chief of Infectious Diseases and Director of Inflammatory Disorders Clinic, Continental Hospitals, Hyderabad. Dr. Ramesh K.N., HOD, Critical Care Medicine. Dr. Sangeeta Sharma, Professor and Head of Department of Neuropsychopharmacology, Institute of Human Behavior and Allied Sciences. Mrs. Bobby Ramesh, Director of Nursing, Continental Hospitals, Hyderabad. I would request all the panelists to kindly come forward and be seated on the dais.
Good afternoon, everyone. It's my pleasure to stand before you with this topic as a panel discussion. At the outset, I thank Continental Hospital for providing an opportunity and conducting such a insightful and a wonderful session. I welcome all the panelists for today. So this is a case-based discussion on importance of pharmacovigilance in medication safety. So I'll jump directly to the case. So this is about a 38-year-old man weighing 50 kgs who was diagnosed with pulmonary tuberculosis 20 days ago at a government hospital. His lab investigation shows that the sputum AFP became positive, and the CBC and liver test are all normal, and chest X-ray is indicative of tuberculosis. He is a non-smoker and non-alcoholic with a mixed type of diet, and clinician referred the patient to a DOT center, that is directly observed therapy center, where he was put on treatment with first-line anti-TB drugs, that is isoniazid, rifampicin, pyrazinamide, and ethambutol, along with other medications. So the patient was asked to follow as per given schedule at DOT. 14 days after the treatment, the patient visited the hospital again with complaints of abdominal pain, yellowish discoloration of eyes and skin, and the treating doctor examined the patient and ordered for liver test. The liver test, the AST, ALT, and ALP, the liver enzymes were very much elevated. And reviewing the elevated liver enzymes, clinician suggested holding anti-TB drug temporarily. The clinician and the pharmacist reported this abnormality in liver test as anti-TB induced hepatotoxicity. So coming to the discussion, what do you guys think? Can we report this case as an adverse event? Yes? No? We'll ask our panelists, Dr. Baumik sir, what do you think? Can we report this case as an adverse event?
Hello. Yeah, so good afternoon and welcome back after the sumptuous lunch. So definitely, you know, the case is very, very evident that there is what we were speaking since morning, that there is a temporal association of an event which has happened after the certain medications have been started, because you showed us the baseline data where the liver enzymes were absolutely normal. And 14 days into the therapy, that has actually increased 3 to 4-fold times. So this is definitely has to be reported as an adverse event. Because as per the definition of the pharmacovigilance, you know, when we say pharmacovigilance, we will have to first report anything which comes our way, which is noxious, which is obnoxious, which is untoward following a medication therapy. Then comes the causality, which I think we'll discuss over a period of time, that for the pharmacists who are sitting here, I would say that very, very importantly, because underreporting happens with a lot of medication-related adverse events, the take-home message should be that whenever you are in two minds, you should always report. So I also tell this to nurses, I also tell this to junior doctors, that please report. Now, what will happen with the reporting is a different story altogether, which I think we can hear it from our discussion during the event.
Okay. So the next question is directed to Dr. Sangeeta Sharma. Can we attribute this reaction to any single agent? Because there are more than 4 drugs given here.
In this anti-tubercular regimen, 3 drugs can cause this liver injury here: INH, rifampicin, and pyrazinamide. So any one of these could be responsible for this. We would only come to know when we stop these medicines and restart. So you all must have read about D challenge. You know, After once you see an adverse event, whether it is an adverse drug reaction or not, next step is that you have to see the temporal relationship and then do de-challenge and re-challenge it. So de-challenge is when you stop the medicine, and if the reaction comes back to normal, the reports, lab findings, they come back to baseline, then you say de-challenge was positive. And then next is to prove that this was definitely due to this drug, you need to do a re-challenge. But this is a very scary thing, because you know already that a drug has caused discomfort, and it is noxious, causing harmful effect on the patient. And if you knowingly do the re-challenge, you will be reintroducing those things and harming the patient. Particularly, when you get dermatological emergencies like Stevens-Johnson syndrome, 10, there are many adverse drug reactions, idiosyncratic reactions, which can be life-threatening. So re-challenge is not attempted with those drugs. But ideally, if you have to prove the causality, you have to do all these steps here. In this particular case, these 3 drugs can cause this hepatic injury, but we don't know right now. At this stage, we cannot say. So first thing is that we need to do a de-challenge here. So drug has already been stopped here, and now we have to wait for 1 or 2 weeks. 2 weeks. It generally takes about 2 weeks time to return to normal. These elevated transaminases, they need 2 weeks time to return to normal. So once they are normal, back to normal baseline, then you have to reintroduce here. This is an exceptional case. I'm not telling you to do it in every case here, because for tubercular therapy, we cannot afford to stop this first-line anti-tubercular drugs. These are essential part of the regimen. So all attempts should be made that the patient should receive all of these anti-tubercular drugs. So what you can do is that you re-challenge one by one. You introduce these drugs one by one, and every 4th day you add another drug. For example, the first one to be reintroduced here could be rifampicin, that you give it for 4 days. If normal, the labs reports are returning to normal, then you add ethambutol. Ethambutol can be given right in the beginning along with the rifampicin. Then that last one would be to add is the INH. So that's how you do it. There are reports, some people say all of them can be reintroduced in one go, but then you won't know the causality, which one is it that was responsible for this hepatic injury. And suppose when you are adding this step by step every 4th day, and liver enzymes start rising again, then you exactly know which drug was the one was last added, and perhaps that is the culprit here, and then you can assign the causality to that drug.
Yes. Thank you, ma'am. Now the question is directed to Dr. Vijay. Is the data of what we have complete or adequate to assess this as a reaction?
So for all of the people who have ever worked with me or trained with me, I tell them about the golden Yaldandi rule. The golden Yaldandi rule is, anytime something bad happens to the patient, it's iatrogenic, it's iatrogenic, it's iatrogenic until proven otherwise. All right. So if you look at any time you have a bad event, automatically you start asking, what is the prior probability of that event happening? So just a brief comment about the regimen in this particular patient. It's a bizarre regimen. 50 kilogram man, you don't give 450 milligrams of rifampin. That's gross underdosing. You don't give 1500 milligrams of pyrazinamide. That's gross overdosing. So that's the first question you should ask yourself. What are you doing out here? Now let's go back and ask about
all of the patients who ended up with a liver transplant or dead on anti-tuberculous therapy. And this is a study that was done many, many, many years ago. And what they found is that all of these patients had something in common. They had abdominal pain and they started vomiting, or they had some other symptoms that were not carefully evaluated by their clinical team. So this is why, you tell patients, I am starting you on a new medication. If you have something that bothers you, you have to first stop the medication, come to me immediately so I can evaluate you. Right? And sometimes in people who have acute fulminant hepatic failure, initially the liver enzymes look okay. It's just that the patient's got severe abdominal pain and is vomiting. So you got to take that into context. Of all of the three drugs here, pyrazinamide is the most hepatotoxic and the least efficacious. So it's the first thing that will go out. Right? Then you say, look, I do want to make sure that this person is not lost to follow-up and does not fall through the cracks and stop treatment. So I will tell you our experience in Dharavi. In Dharavi, which is the biggest slum in Mumbai, in 1 square kilometer, you have a very large population. The largest amount of MDR and XDR tuberculosis is found there. And even during COVID, our staff went into that entire slum to follow people with drug-resistant TB and XDR TB. And you know what they did? To make sure that all of these patients were never lost to follow-up, didn't stop their treatment, is to monitor them for adverse drug reactions. You call them up. How are you doing? Are you doing okay? Any abdominal pain? So you don't wait for something bad to happen and then react to it. You respond. That is the first principle of an effective pharmacovigilance program. You follow patients. And guess what? The majority of these patients had very minor adverse effects that did not qualify as grade 2 or grade 3. You could easily overcome them by counseling them, making sure they were not doing something else that would cause trouble, like in this particular person, taking paracetamol, which is also a known hepatotoxin, or taking a non-steroidal, which is also a known hepatotoxin, right? Guess what? We brought the loss to follow-up down from 14% to under 3%. And we followed all of these people throughout and ensured that all of these people with extensively drug-resistant tuberculosis, and a lot of them on bedaquiline, had their ECGs, their QTCs monitored. By the way, this is just published on the 24th of March on World TB Day and an MMWR. So I encourage you to look at that publication. So that is the importance of a properly designed and executed pharmacovigilance program. Now, if you think about, okay, if I've got somebody, the rule of the thumb in anti-tuberculosis therapy is, if you have hepatotoxicity in less than 4 weeks, it is far more commonly due to rifampin than isoniazid. But are you going to take a chance? No, you take them off all hepatotoxic drugs. You can actually give them a non-hepatotoxic regimen to bridge them. Say, for example, proper dose of ethambutol, which is underdosed in this man, a proper dose of ethambutol. You can give them a quinolone. Unfortunately, in India, there is a lot of background resistance to quinolones for tuberculosis. So you have to think about other potential drugs that you can use. Say, for example, bedaquiline or something else, okay? Ritomanid. So many other drugs are now coming in. Linezolid. There are many, many choices. And then you can go back and ask, which drug am I going to introduce? So I would say that I would actually, based statistically, just probability, I would probably reintroduce isoniazid first. If that's okay, then rifampin, and probably try and see if I can get away without using pyrazinamide at all.
Thank you, sir. Now the next question is directed to Dr. Ramesh. Can you tell something about the causality of a drug and a suspected reaction?
Yeah, causality mainly indicates the assessment of the causal relationship between the drug and the event. So there is some criteria for that, WHO has causality criteria. So according to that, what it tells is, so there should be a temporal relationship between the drug, introduction of the drug, and followed by an event of adverse effect. as Madam discussed, and there should be a mechanistic plausibility. That means the drug mechanism of action should explain the adverse effect also, if that is there, or if there is a known pharmaco safety profile of the drug, in which in the phase studies and all, if there is in the list of adverse effect, if it is included in that, or if there are confounding factors, like what Sir has discussed, it can be medical related factors, like what is lacking in this clinical history is whether the patient has any chronic liver disease or not. Only OTPT will not tell us anything, whether the patient's bilirubin was elevated or not, INR was how much, imaging studies, whether ultrasound was done, echo texture was increased or not. So those information is lacking. And other confounding drugs also, Sir has told, concomitant drugs and co-suspects what we tell, because multiple drugs will be causing the same adverse effect. So all those things we have to rule out before going to the causative evaluation. And then, as Madam has explained, stopping the drug and evaluation whether the adverse effect has relieved or not, and reintroduction of the drugs. So all those are the criteria. 7 criteria are there. We have to remember that before taking the patient for the causative criteria. So these are all the WHO causative criteria. So coming back to the classification of causation, we grossly classify them as suspected causative or non-suspective causation and non-assessable. Okay. So there are one more classification like WHO Uppsala Medical Center classification, which tells us that certain causation is there, or probable causation, possible causation, unlikely, or non-assessable. So these are all the classification and causation. How to assess this? We have to see the next information of the patients. Based on that, whatever the lack of information what we have, those we have to see, and then we have to go for the next step.
Thank you, sir. The next question is to Mrs. Bobby Ramesh. Can the nursing department play a role in pharmacovigilance?
Thank you so much for that question, Dr. Aksa. Good afternoon, everyone, the esteemed panelists and all the delegates and the distinguished guests here. Yes, definitely nurses play a very important role in pharmacovigilance. We say nurses are everybody say nurses are the backbone, they are the spine, they are the heart and everything. All said and done, nurses are an integral part of healthcare. Though the doctors are in command, it is the nurses who execute the care plan, being with the patients 24/7. Hence, if any adverse drug reaction is happening, they are the first one to notice the same. So they can notice it. For noticing that, they need to be aware of it. So the main problem what occurs here is most of the adverse drug reactions go unreported because of lack of knowledge and awareness. So if the nurses are trained well into that, previously Dr. Sangeeta ma'am also in her talk said about it, that if you have a mind to look at what you want to look, you will be able to capture the same. So same things, if the staff, the doctors, the nurses, especially the nurses, I'm talking about nursing, they need to be trained on what are the things to be looked into, what are the signs and symptoms to be looked into in adverse drug reactions. Definitely, they'll be able to capture much more. And then how to manage those even before reporting that, because for some, the time duration matters a lot. Some anaphylactic reactions can be deadly. So they should be prompt enough in managing that, and they should be also taught the mechanism of reporting these incidents, what is the hospital policy and how these has to be reported, and how to external database we have to report, internal quality department, how to raise an incident report. If they are trained well, I am sure maximum of the adverse drug reactions can be captured. And here the clinical pharmacologists and the clinical pharmacists and the doctors also play a major role in training these nurses and making them aware so that they are well versed with the actions and side effects and complications of various drugs and various signs and symptoms related to the adverse drug reaction, so that they are prompt in their action in capturing and reporting the same. Thank you so much. Yeah.
Thank you, Dr. Bobby, Mrs. Bobby Ramesh. We'll get back to the case again. So what happened next? So during the same hospital visit, clinician provided supportive care for 4 days to the patient and asked him to wait for treatment till liver enzymes are normal. So after 1 week, Mr. T's liver enzymes were observed to be normal. the clinician wants to identify the offending drug and hence suggested to re-challenge with anti-TB drugs. So my next question is to Dr. Bhaumik. Can re-challenge be conducted in this patient, and why? If so, how?
I think Dr. Sangeeta Sharma has already answered this question, but just want to add here that re-challenge is basically an ethical issue. You know, when you see that it's a question of whether you want to expose that patient to the same suffering, vis-a-vis when you know that this suffering is justified or not. This particular case, I think what Dr. Sharma said, I completely agree that the patients require complete therapy, needs to complete therapy for the pulmonary tuberculosis, because TB in India is a major problem, and as Sir was mentioning that, you know, if the patient does not take complete therapies on incompletely underdosed medication, there is a high chance of the patient developing multi-drug resistant or in some cases XDR tuberculosis, which is a great public health concern. So it is no longer a patient which is going to be suffering, but patients across public as well as the healthcare workers who will come in contact with this patient. So in this case, this is being a special case, re-challenge will be conducted as mentioned by my fellow panelists. Re-challenge has to be slow and steady, and I think a lot of counseling has to be done, because patients, they would say that, you know, if the patient families are going to be very worried that if liver enzymes are going up, and nowadays everybody reads up on internet, and they would come that there will be high chances of hepatic failure if already patients have started developing these kind of adverse effects. And this has to be in a very slow and steady manner. And I completely agree with what Sir said, that yes, when it develops for the first 4 weeks, usually the offender is rifampicin, because that is, but you can't, majority, these are the two important drugs, rifampicin and isoniazid. Any therapy has to have these two therapy, and we need to actually take, depending on the evidence-based medicine which we want to introduce. We can introduce rifampicin, slowly, steadily we can introduce, we can introduce INH, slowly, steadily we can introduce the rifampicin, and eventually go on to the other drug. But pyrazinamide, to the best of my understanding, has the maximum hepatotoxicity. If we can avoid it, that will be good. I'm a strong proponent of fluoroquinolones to be added, because the second, if you look at the evidence, the second generation anti-tubercular drugs are to be used in these cases where it is affecting patients' quality of life as well. So some bit of enzymes will definitely climb up. The question is, how much will you allow? So re-challenge will definitely be performed, and it has to be performed in this condition. And just one small thing I wanted to add to what Sir said about causality. Easy also available tool is the Naranjo's causality scale, which is, according to me, a very easy scale to actually look in, because it has 10 questions in place. You have, if you have certain answers, so you can mark it as +1, 0, and -1. So at the end of the 10 questions, if you have a score which is positive, then it has a strong correlation, temporal correlation with the drug which you are looking at. If you are probably below 4, then it is possible. If you are below 1 or 0, then it's probably not related. So that is another easy tool which clinical pharmacists can use very easily. It's the Naranjo's causality assessment scale.
Okay, thank you, sir. So coming to the next, a day after the liver enzymes became normal, Mr. T was re-administered with rifampicin for 3 days. Post 3 days of treatment, liver tests were performed and it was observed to be normal. Later, isoniazid was added to the patient's regimen, and after 3 days, liver enzymes were elevated. So what will we do now? Should we stop isoniazid, or should we continue? Should we try with pyrazinamide, or should we go for second-line anti-TB drugs? I request Dr. Vijay to answer that question.
You know, it's a tough question, because you have to ask the patient what kind of risk they're willing to take. So, the ethical dimension comes in here, all right?
And in a country where it's not always easy to do a liver transplant, unless you're at Continental, we'll do it for you. But in most other places, you know, you would say, look, and really, you know, within a few days, you still cannot tell whether the enzymes are going up are because of isoniazid or rifampin. It could be either one still. So my personal choice would be to give the choice to the patient. I will tell the patient, I'm going to give you an option of choosing a non-rifampin containing regimen where the efficacy with all of the current regimens that are, I'm not talking about the newer regimens, efficacy drops from over 95% down to 65%, all right? That's a consideration that they have to factor in their choices. But today, the advantage we have is that we can go to a regimen that is better than 90% efficacious by using newer drugs, you know, pretomanid, delamanid, bedaquiline, linezolid. You know, there's a gazillion different ways to devise a regimen that has better than 90% efficacy. So I would think that in this day and age, you have to present all of the choices to the patient before you make a decision. And ultimately, it's the patient's decision.
Thank you, sir. So, the next question is directed to Dr. Sangeeta Sharma. Is re-challenge acceptable clinically? I think she's
I think I answered this earlier. Normally, you don't do re-challenge. You know, de-challenge at that stage only you stop. You know that this is the causative agent. But in this particular case, because of the public health concern and we want to complete therapy with PV, re-challenge was attempted. So here again, you know, if you follow up the patient and if you find that the liver enzymes are rising and the last drug added was INH, then perhaps INH would be the, you know, offending agent here. So causality assessment can be assigned to INH here. So this depends on at what stage do you find that the, you know, the problem comes back.
So does it depend upon the severity of the reaction or
yes,
the number of...
Of course, the impact, the severity, you have to take, you know, it's the patient, you know, it's not that we are doing it in a laboratory here. It's the patient who is going to suffer, and whether the, you know, the effect is reversible, non-reversible, is it emergent, you know, is it life-threatening? All these factors need to be taken into account before you attempt to do a re-challenge.
Okay. The next question is to Dr. Vijay. Will causality of the reaction change now with all this additional data? Not to Dr. Vijay, sorry, Dr. Ramesh. Sorry.
Pardon?
Will the causality of the reaction change with all these additional data and the follow-up what we did? Will the initial causality change at the end?
Yeah, definitely, because we have more data now that virals negative, all those things you told, and alcoholic history you told, and clinical history is more relevant now. And D-challenge is also positive, because after stopping the drugs, there is a positive D-challenge is there, which is again a more positive sign for causality. And after stopping, again they have started with a re-challenging with one drug, each drug. They started with rifampicin. With that, they waited for almost 3 days. There was no reaction. So there was a negative re-challenge for rifampicin. And then they introduced INH, which was a positive reaction for INH. So definitely the information is relevant now, and causation can be at least, we have some information, D-challenge and re-challenge reports are there, so that we can clearly come to a conclusion for that.
Okay, thank you, sir. So this is the last question to all the panelists here. What will be the implication on Mr. T's therapy? What would you like to conclude or the takeaway message from this case?
I think that, you know, firstly, I like to tell my patients before I give them a prescription, I tell them, this is the drug that I'm giving you. Here's the reason why I'm giving it to you. This is how it works. And by the way, these are the three most troubling, not the three most common, the three most troubling adverse effects that I would be concerned about. So please come back to me. And, you know, in this day and age, fortunately, we have lots and lots of therapeutic choices. So I don't think we need to box the patient into, you have to do this, you have to take the risk. No, the risk is not yours to take, the risk is the patient's to take. So ultimately, the patient decides. And believe me, even if the patient says, I don't mind having tuberculosis and dying of tuberculosis, you cannot force them to take their drugs. That would constitute medical assault. All right? So please understand, it is the patient's choice.
Another thing I think is to follow the standard regimen. You know, one take home, always, TB treatment has been standardized, dosage, everything has been standardized, so that should be followed. Don't, tweak with the regimen unless really warranted. And similarly, the follow-up schedule should be followed, adhere to the follow-up schedule. If under the TB program, certain investigations have to be done at the starting of treatment and follow-up 6 weeks later. So all those should be done, to safeguard the patients.
I think the importance of pharmacovigilance is very well described in this case. So we have to also understand that there will be adverse events which will happen when patients like this get anti-tubercular drug. Few questions which come to my mind is this, there will be certain events which will affect, but do we need to change the therapy or not? That's a very big question, and as Sir mentioned, it has to be in discussion with the patient and the clinician. That's extremely important. Proper, transparent communication has to be there that this is iatrogenic. We are trying to help you. You have these options. That needs to be in place. And finally, I would say that Dr. T's therapy clearly mentions that there will be hepatocellular toxicity with going ahead with other hepatotoxic drugs. So he needs to be counseled by the clinical pharmacist whenever he is, even after completion of the anti-tubercular drug therapy, that his liver enzymes might rise up if he's on any other anti-hepatic medication. This is a very important thing that he must mention in his clinical history whenever he's going to any other healthcare institution.
Yes. I thank the organizers again. Thank you for thank the panelists for encouraging a wonderful discussion. Thank you all.
Thank you.
I request all the panelists to be seated on the dais. Thank you to each one of the panelists and the moderator for the brilliant insights they have provided. May I now request Dr. Karthik Rakam to come forward to provide his insights into the importance of prescription labeling to improve patient safety. Dr. Karthik Rakam, co-founder and CEO, Avenida Innovations. Dr. Karthik is a resource. Dr. Karthik is a resource person for Pharmacy Academia and an educational initiative by Pfizer to impart training into practicing pharmacists. He is the winner of FIP Global Symposium 2021 on AMR, attended by 479 participants from 71 countries. He is the winner of national level case study competition conducted by IPA on the occasion of World Pharmacist Day 2015. He is the author of Drug Watch, a column dedicated to adverse drug reactions in IPA CPD E-Times. Dr. Karthik is the faculty for skill development courses like evidence-based pharmacotherapy, CR, PV, CDM, medical writing, informatics. He works with the University of Findlay, USA to provide Indian PharmD students an opportunity to visit USA as a part of an exchange program. Dr. Karthik is also the founder of NGO Havens of Humanity and volunteers with the Isha Foundation. We welcome you, sir.
So, hi all. Hi. Okay, so one way of testing how alert participants are, I realized recently. So I asked them this question. So somebody read my introduction. Can you recollect one line or one sentence of what she read? And most of the time participants failed unless they know me very well. So I said, I will give you a job if you can just tell me one sentence in what the person read. Yeah, because you have read my profile many times. So how many of you heard me before? So almost all of you. Okay. Okay. So ma'am, anyways, she's in position to give jobs, not take jobs. So sure. So I'll talk about some new concept. This I have not spoken previously. Many times I am very careful because I have done so many sessions, so I forgot where I talked what. So this is a new concept. So how many of you can recognize this? So what is it? Any guess? So you need a clue. So that could be the first thing you saw in the morning after you wake up. So what is that? You saw your own face in mirror. So this was the phone, okay? And even in second image it is the phone. So look at its size. So I don't remember all the stats, but they said to use it for 1 hour, you should charge it for 10 hours. And it was weighing 1 kg. So somebody like me can use it to exercise, okay? So dual purpose. So this could be your typical day. You wake up, you see your phone because you have so many important messages to answer. So you order food on Zomato using that same phone. And then today you are at Continental Hospital. Can you see the address? So you use the same phone, book a cab or an auto. You reach the venue and you might have traveled on one of the best possible roads. So I'm asking you a question. In last few years, do you think there is significant improvement in many aspects of our life? You agree? Okay. And when something is complicated, we compare it with rocket science. So we'll see what progress we have made. So I think this image is very famous. Can you identify what this was? Somebody selling ice cream. So in childhood, I used to recollect when somebody sells ice cream, we used to ask our parents and all, but this was scientists carrying rockets. And at some point they used bullock cart also, not because they did not have a better vehicle, but they said this will have less interaction with that satellite because it does not have any metal and other stuff, okay? And this is most recent image. So can somebody say what this is? So this is a reusable launch vehicle. We can use it again. So this is the progress we made in rocket science. So you might be thinking I came for patient safety conference and this fellow is talking about rocket science. So there is some relation, okay? So and here my intention is not to compare healthcare with rocket science, but it is as complicated or if not more complicated. Do you agree with me? Because maybe in rocket science there are fixed set of variables, but in healthcare there are a lot more which can change within minutes and seconds. So many people have said healthcare is much more complicated and difficult than rocket science. So Dr. Vijay was talking about how hospital is a complex adaptive system. So I will share my slides. You can try to interpret what is put here. So definitely it is not easy. Lot of interaction, so many people involved, so many variables, all this stuff. So this is a quote which I liked. So if patient care was a rocket science, we could have done a good job because we have mastered it and we have sent 104 satellites in one go. Okay. So that is the kind of progress we made in one of the most complicated sciences. But healthcare is, as I said, much more complicated. The positive thing is there can be simplicities arising out of complexities. So I will talk about one simple thing which we can do to improve patient safety. So my question on top, are we doing a good job in addressing most fundamental aspect, which is health and life? Do you agree? So we have easiest way to order food, transport, you can book right from your phone, pay using Paytm or Google Pay. I never used cash in last maybe few years. So we have made progress in all those aspects, but we can enjoy them only if we are healthy and alive. Do you agree with me? And sir was saying we cannot treat a dead patient. So you are dead, can you order your food and book a cab? Okay. Okay, so this is a question. So how do you identify a pharmacy in India? So my opinions might be sometimes too strong. So is it looking at the board or looking at the service they give? So at least in my experience, I can call a pharmacy by seeing board, but not the kind of professional service they give. So if I hide the board, so it is difficult to figure out if it is a pharmacy or a stationery where somebody simply takes medication out of a shelf, puts it in a cover and sells it. So did you ever visit a pharmacy? Yes, no, respond. Oh, thanks. So from morning, this is the loudest I heard from audience. So did the pharmacist sell medicine or dispense? Or is it both same? Okay, so before giving you your medications, did pharmacist ask any question? No? So he read your face, he understood what all complaints you have, and he gave you your medication. Huh? So along with medication, did he give you any information? No? Okay, so this is about pharmacist. Now about us. Did you ask if that person who is behind that counter is a pharmacist or not? Did you ask? No. Okay. So ask yourself all these questions, okay? Because there was some Kon Baranga Karupati joke, which all of you know, so I thought I will not keep that here. So, some images. So these people are not my enemies, but I found from Google. And this image I like the most. So this is discount. So discount on medication is okay, but this might lead to discount on health. So you understand what discount on health means? If you are supposed to live for 100 years, we will give you a discount 20 years. You can pack your bags and go. So last image I like the most, so I kept some animation. So some smart person like me thought, why should I keep an additional board of discount? I will name my pharmacy discount pharmacy. Okay. So here, like, people are encouraging, means pharmacists are encouraging people to come to them offering a discount, but not offering a professional service. So it might be, and they have stuck it on the boards like toilet board, 15% discount if you visit our pharmacy. So coming to my topic, so this is labeling. So instead of simply putting it in a brown cover, on the right side you can see, this is how most of the times medicines are dispensed and you don't know what is inside it. On the left side, I have picked it up from some source, properly labeled, which shows what medication it is, etc., etc. So did you see this kind of a label anytime? A pointer. So this is the ideal way how a label should look like, but most of the times we do it this way, so we don't know what is inside. Okay. So how many of you are students currently? So most of you are students. I will give you two options. Read properly, try to remember everything, go and take an exam. Option 1, prepare a label with all the answers, or it is called a cheat, not a label. Take that cheat to exam. So in which case will you perform better? Means if same question comes in exam. Okay. Simple question, no? You prepared, you relied on your memory, you went, but you did not trust memory in second option. So you wrote all the answers on a piece of paper, you went and appeared for exam. So in which case do you think you will perform better? So for this also, if you are thinking, I don't know, okay. So maybe in second case, because you have already written answer on a piece of paper, you took it, all you have to do is copy it in answer sheet. Or you want to stick it and paste. So what I am trying to say is, this is what we have done in one of the pharmacies in Hyderabad. So if you are staying back tomorrow, you can contact me. We can physically go and see that pharmacy. So we have introduced the concept of generating a personalized label for a patient and give it, because same strip we might give to 10 different patients, but the information on that strip is not tailored to that patient who is taking it. So we have created this concept where we generate a personalized label. Along with that, we also give cautionary label and we create a proper profile. So patient has a clear list of medications to take and the language will be simple, which he can understand. And here, not just the patient, somebody else is also involved in this interaction. The other one is the pharmacist. So to empower pharmacists, we don't expect them to remember everything. So while they are dispensing, there is a solution which gives them special directions, dispensing considerations and pregnancy and breastfeeding category. So this is the example of what we do. So I have pasted maybe 10 different examples here. It is not just for one patient, but for multiple patients. And this is all the information we give. Okay. So patient, with a hope that he understands his medication better, uses it, and ultimately achieve better outcomes. And patients are loving it. But unfortunately, though it is started by a pharmacist, they are saying there is a pharmacy where it is started by a doctor. So any good work, credit goes to doctor, even if a pharmacist does it. So they are happy because they have not been exposed to this kind of information which they are getting along with the medication. And in fact, few patients are traveling all the way from very far to come to pharmacy. So with this, I end my talk. Couple of examples I will share before that scary sound comes. I still have 8 minutes. So thanks for opportunity, very well organized. Most of the time, all pharmacists should sit together and talk great things. But here we are talking to a hospital where many consultants are there. So thank you so much for the opportunity. So coming to this few examples I will give. Very recently, I am part of a project setting up clinical pharmacy department in one of the hospitals in Bangalore. So when I went, I saw a patient diagnosed with diabetes 5 years back. Okay. So she used medications for first 2 years. She was following the diet properly, physical activity, all that stuff. So in 2 years, sugars were under control. And then this visit, she came to hospital not with complaint of diabetes, with some other reason. But routinely when we evaluated the patient, blood sugar was 450, around that range. So is it normal? It is abnormal. Okay. And her HbA1c was somewhere around 14-15. Okay. Yeah, so here I don't want to make fun. So generally I say we should control our emotions. So let's say you go and see a report of this patient and you shout in her ears, my God. Okay. So then I don't know the language. She could not speak Telugu. But I had an intern with me. So we initiated a conversation and it was very shocking to know. She said, we asked her, why are you not using medications for diabetes for last 3 years? Your blood glucose and other tests are abnormal. She told, I used for first 2 years, levels were normal and I thought it will continue to be normal for the rest of life. So is it a simple point or a complex point? That diabetes, you have to take medications almost lifelong, it cannot be reversed. And in this 3 years time, she might have visited pharmacy many times, hospital many times, interacted with so many healthcare professionals. It could be a doctor, a pharmacist, etc., etc. But it was shocking to know, but in this 3 years time, none of them could tell her that she should continue to take a diabetic medications. So then we evaluated the risk of cardiovascular illness. So there is some scales and all. So risk was very high, but prescription was not having any statin. And she might need an aspirin also, but all that was not done. So what I'm trying to say is there are simple things in topics like diabetes where things can be improved. Simply telling her you should continue to take medications and get tested regularly. So she was happy and she gave a very good feedback. The other example I can give was, there was again one patient where the order was take half an hour before food, but this half was written as 1/2. So when nurse was giving it, she interpreted that instruction as give half tablet. Okay, so she did not read the entire sentence, and maybe it could have written better. Maybe 30 minutes, if they write, she should have understood the intention of a doctor, but they wrote half. So she thought half tablet, she is breaking the tablet into half and giving, and patient was receiving half the dose. So she was supposed to get 30 mg, but this patient was getting 15 mg for last 10 days and nobody noticed. And when I saw this, it was because of instruction which was not written clearly. Even if it is not written clearly, she did not spend enough time to understand it, and that continued to happen for 10 days. So what I'm trying to tell you is there can be simple things which we can do which can improve outcomes. And third and last example, so there was a patient who needed eye drops. So doctor prescribed 2 eye drops. Eye drop 1, it was written, but it was not written in which eye you should put it. So at least you should get a doubt rate when you, let's say when you intent, you might not get it out. But at least when you are administering it, you should get it out. This is an eye drop. Should I put it in 2 eyes? Should I put it in only 1 eye? If it is only 1 eye, is it left eye or right eye? At least these questions you should be able to get. So this instruction was not given. So when we asked, then they told, put this eye drop number 1 in left eye, this many drops. The other eye drop instructions were complex. Put in both the eyes for first week 4 times in a day, second week 2 times in a day, third week 1 time in a day, something like that. So do you think verbally you tell this information to patient? Do you think patient to expect patient to remember all this? So this is definitely not a complex information, but still 2 eye drops, one has to be put only in 1 eye, that is also left eye, other eye drops has to be put in both the eyes. So it is a complex instruction, yes or no? But how can we expect patient to understand, remember all this? So I thought that is where having a label, reinforcing verbal instruction with something written and give it to patient so that they can go back and read. So I thought this is one way where we can so improve. With this I end my talk. Thanks for opportunity. I hope you learned something. More importantly, you will implement something. Ma'am was saying in the morning that you do all this analysis, you identify so many problems, you create some strategy and develop solution, but it should be implemented, right? So let's say we cooked all these dishes for you and close that hall while lunch. So what is the purpose of cooking all this if we don't eat? So in the same way, there is so much of information, what can be done, simple things to improve care. So my message is every day you get an opportunity to see a lot of patients, and each interaction will give you an opportunity to apply your knowledge and make somebody's life better. So use that opportunity, and thanks again.
I kindly request you to be seated on the dais, sir. Thank you for these amazing insights into the prescription labeling and how it improves the patient safety. We now move on to our next subject, NABH and JCI requirements related to medication safety by Mrs. Bobby Ramesh. Mrs. Bobby Ramesh, Nursing Director, Continental Hospitals, Hyderabad. Mrs. Bobby Ramesh graduated in nursing from a prestigious Armed Force Medical College in Pune. She has over 25 years of extensive expertise in the nursing and quality administration, teaching, and clinical fields. She is a faculty member for NABH and training courses for nursing excellence, as well as the NABH principal assessor. She has also led the teams in preparing for JCI survey and NABH assessments.
Thank you so much for that introduction. A very good afternoon to all. Respected Director, Mr. Raghu Reddy, distinguished guests, dear consultants, delegates, and my dear colleagues. I'm here to talk on NABH and JCA requirements related to medication safety. Before that, I'd like to share 3 incidents which says the importance of having these requirements in place in the hospitals to promote medication safety and patient safety. My dad, 3-4 years back, I just took him walking. He was a bit disoriented because of hypoglycemia, and I just took him walking to a nearby hospital, which was a very reputed medical college hospital near my house, and the doctor said, though his blood sugars are low, we need to do an MRI for him. And because my father was not cooperative, the doctor told the nurse to give midazolam, injection midazolam. So already in the morning, we discussed about injection midazolam as well. And the nurse gave a bolus of injection midazolam. And suddenly I couldn't hear my dad talk, and then I rush inside the ER and I see this nurse taking out the syringe, and I asked her, what did you give? She says injection midazolam. How much did you give? She says 9 milligram, that too a bolus. He went into deep sedation, comatose, and he was 8 months in the hospital, and later he expired. The second incident I'd like to share And that has put in a lot of agony in the family also. You know, everybody's routine gets affected and nothing we could do. In the ICU, then he was there for 4 months, and then in the ward, back to ICU, like that. The second incident, in my previous organization, one of my nurse in the recovery, patient who had had a surgery, he was in the recovery, and she went to give a painkiller injection, and she ended up giving a muscle relaxant, which is used, you know, for paralyzing the patient for putting on the ventilator. Now the nurse realized her mistake, and without wasting a second, she went running inside the OT, called the anesthetist and came, and the anesthetist intubated the patient and resuscitated, and the patient was saved on time. This was because there was no punitive culture there, and they were encouraged to do reporting of any incident. So she could tell it without, and she was aware of it. And the third incident I'd like to share, when a patient got discharged, this also happened in one of my previous hospitals. When the patient got discharged from the pharmacy, they, instead of giving a Dynel tablet, they gave a monotrate tablet, which was look-alike. So maybe in a hurry, when the pharmacy was busy, the pharmacist would have taken and given without reading properly. And the patient, after taking that, for a month or so, the patient reported to the hospital in a comatose stage. And then the patient relatives, the husband, the kids, everybody came to the CEO's office, and they made a big hangama. If the patient, anything happens to the patient, we'll kill ourselves. So it was a big stress and tension for all the team members in the hospital till she recovered and came out of that. So these all incidents are due to lack of policies and protocols, or lack of awareness related to policies and protocols in place. NABH and JCI requirements are nothing but the mandatory policies and protocols which should be there in place to promote patient safety. So now, considering the audience is mostly students, and most of them may not be exposed to accreditation, and how many of you all know NABH and JCI? Please raise your hands. So that's what, very few. So I'll just quickly discuss the importance of accreditation and what are the various accreditation which our hospital has, our NABH and JCI. So accreditation, you know, there are benefits to the patient. It promotes patient safety, it promotes staff satisfaction, and staff working in accredited hospital are wanted in terms of job opportunities. And organization, it will be better branding and better image because of better patient and staff satisfaction. And you get a national and international recognition. Our hospital is JCI accredited 4 times, and JCI is a US-based non-profit body. The mission of JCI is to improve safety and quality of care in the international community. NABH is National Accreditation Board for Hospitals and Healthcare Providers, which was established in 2006 in Delhi. And the mission of NABH is to operate accreditation and allied programs in focusing on patient safety and quality of healthcare. So now, coming to the NABH and JCI requirements related to medication safety. In JCI, presently the 7th edition is on, and there is an entire chapter dedicated to medication management, which is chapter 7, which is called as medication management and use. And in NABH, it is chapter 3, which is management of medication. Overall, the content is same, only the wordings will be slightly different. There are 18 standards in the medication management chapter in JCI, and 11 standards and 68 objective elements in NABH. So the medication management process, the process starts with planning, procuring, storing, prescribing, dispensing, preparing, administering, documenting, monitoring, reporting errors, and evaluation. So in all these processes, there are certain objective elements which have to be in place as per NABH and JCI, which if you are working in a hospital, in a nursing department or in a clinical department or in a pharmacy department, you all should be oriented towards it, and which are your areas, you should be well versed with it. So in a hospital, if you have a pharmacy, if you are using medications in your hospital, you need to have the required license, you need to have a retail license, you need to have a bulk license, you need to have a licensed pharmacist or pharmacist depending upon the size of the hospital, and you need to have a pharmacy and therapeutic committees in place. Then when it comes to procuring, first you need to have a formulary in place. Formulary is the list of medications for various departments as per the requirements and the scope of services in the hospital. The doctors have to be involved in deciding on the formulary. And you need to have a distribution between generic and branded medicine. In our hospital, we have one generic and 2 branded medicine for each drug. And we need to have different modes of inventory management based on fast moving, slow moving, very essential, less essential drugs. And you need to define your minimum order quantity and reorder levels. And there should be no stock out of emergency medications. It should be always replenished on time, and it should be in place. Now coming to the storage of medications, medications have to be stored as per manufacturer's recommendation. And as CPs, as nurses, we need to, whenever possible, we need to look for how it is stored as per the correct temperature, in the correct place. Light sensitive drugs have to be stored accordingly, covered containers. Narcotics in double locked cupboards. Radioactive drugs or radioactive agents should be stored as per the ARB guidelines, and high alert medicine should be under lock and key. While prescribing, the doctors have to use generic names. It should be written in capital letter, legible, only approved abbreviation should be used, and verbal orders. Every hospital should have a verbal order policy. I was mentioning about my dad, expiring due to not following a verbal order properly. If the doctor has not, that was a high-risk medication, a verbal order should not have been given. Verbal order should be for only minimum drugs, and high-risk drugs should not be included in the verbal order list. And if a doctor gives a verbal order, the person taking the verbal order can be a nurse or a doctor. They have to ensure whether it is as per the policy, and they have to read back. If they didn't understand the name and the dosage, they need to read back, and then they have to confirm and write it, document it, and within 24 hours the doctor has to countersign that. So the verbal orders were not followed. And storage, when I was mentioning, look-alike, sound-alike drugs have to be stored separately and apart from each other, so that in one of the incident I said, look-alike a dianyl and a monotrate, it was exchanged and it was given. So such errors can be avoided. Drug allergies, already Dr. Subro mentioned in the morning session that every prescription drug allergy has to be mentioned clearly. Only then these adverse drug reactions can be avoided. The CPs have a major role in audit of medication prescription, wherein whatever prescriptions doctors write, you need to look for the legibility, you need to look for the correct dosage, you need to look for drug-drug reaction, and therapeutic duplication, etc. So these all parameters you all have to look into and accordingly audit and present this audit to the consultants as well. Medication reconciliation, it was already discussed in depth in the morning. Coming to 3 points Dr. Sangeeta mentioned, we have to pay attention to when the patient comes on admission, transition point from ICU to ward or ward to ICU, and at the time of discharge it has to be done. Dispensing, it should be handled by authorized pharmacist. The details of the patients and the prescription details have to be verified. If it is high-risk medications, it has to be double-checked by 2 pharmacists. And medication recall is when a particular drug is recalled back to the pharmacy from the wards or from the ICUs or from the pharmacy to the company. So medication recall, policy the hospital should have in place, and it can be based on the Drug Control Authority's circular or from the company because of some manufacturing defect or due to any reactions which happen to the patient continuously, and then we recall the medication. So everybody, be it the doctor, nurse or the CPs, have to be trained on medication recall policy as well. And there has to be guidelines in place for return of medication to the policy, whether you'll accept all the medications when the patient goes on discharge, including cut strip. If cut strip is being dispensed, most of the hospitals do not allow that, but if you allow, you need to put in proper label, including the name and the expiry date. Preparation of drug can be done only by authorized and licensed personnel. You need to prepare under kind of controlled environment. In the wards, you need to prepare in medication preparation rooms. If it is chemotherapeutic drugs, you have to prepare in biosafety cabinets. And if there are multiple drugs, you need to label the first drug immediately after preparation. While administering, there should be no deviation from the prescription. Delays must be avoided because as per the hospital policy, if a nurse is taking care of 5 or 6 patients, maximum of an half an hour delay can be accepted, but not more than that. And 5 rights of administration, including right drug, right patient, right dose, right route, and right treatment should be adhered to. So many a times when there is an administration error which happens, it is because mainly patients are in a tin sharing room and the nurse doesn't go and check the patient ID band, and instead of patient A, they go and give the insulin to patient B. And then everybody ends up in problem, and then the first call I get from the consultant concerned. So people should avoid that. Always before doing any procedure or giving a medication, one must identify the patient first and double check for all the high-risk medication before administration. Also, we need to have measures in place to govern patient medication brought from outside the organization and also self-administration of medication, because most of the hospitals do not allow medications brought from outside or self-administration. Self-administration is mostly insulin, but if you are allowing in your hospital, you need to have clear policies in place, and the staff should be well versed with the same. And after administration, the documentation, it should be on time, not at the end of the shift. It should be timely, legible, including the date and time and name and sign of the staff who has administered the drug. Whenever possible or whenever required, test dose has to be given. ADRs, near miss, and medication error should be captured on time, and it has to be reported. Hospitals should have guidelines in place for situations requiring frequent monitoring, especially for high alert drugs. And as I had already mentioned, staff should be aware of reporting or capturing of ADRs, incident reporting, and also quality indicators related to medication safety. Now, if any incident happens, all the members of the team, be it the CPs or the doctor or the nurses or the operation team member or the pharmacist, all have to be part of the team. RCAs or root cause analysis have to be done by all the stakeholders concerned, not by one individual. And there are various methods to do root cause analysis, and properly we have to do a root cause analysis to prevent such incidents in future. And the trends, of various side effects or ADRs we need to identify. So wherever it is preventable, we can prevent it. And the quality indicators have to be reviewed on a monthly or a quarterly basis. We mentioned about pharmacotherapeutic committee. So in those committee, these quality indicators have to be reviewed, and respective department should review it on a monthly basis. So these are few of the quality indicators which are captured in a NABH or a JCA accredited hospital on a daily, monthly basis, and it is presented and reviewed in the PTC. So medication error, be it the prescription error, transcription error, indenting, dispensing, administration error are captured. Near miss have to be captured. What do you mean by a near miss? You are about to give it to a patient, you have taken a medicine, you are about to dispense, but before dispensing, you identified that, oh no, this is a wrong medicine or a wrong dosage, and you didn't give it to the patient. Many times it happens in the pharmacy, but then they don't capture it as a near miss. So such incidents have to be captured as a near miss. The more the number of near miss, there are more chances for being more alert and ensuring that the policies and protocols are in place, and trainings have to be in place so that errors can be avoided. Percentage of cases who develop adverse drug reaction, complaints to medication reconciliation process, complaints to antibiotic policy, complaints to high alert drug policy, admission with adverse drug reaction, error-prone abbreviation in drug chart. So all you participants who are here from various colleges, tomorrow you all will be CPs or nurses in various hospitals. You all should be well versed with these quality indicators, which are very essential in promoting medication safety, and these all are mandate as per NABH and JCI requirements as well. So these are, to summarize, medication safety is an essential part to promote patient safety. NABH and JCI, though the standards and objective elements numbers differ, but the content or the intent is the same, to promote patient safety and to prevent avoidable errors. And starting from a planning to procuring to administering and evaluation, lot of protocols have to be put in place, and each one of us have a role to play in promoting medication safety, thereby promoting patient safety. I'd like to conclude by saying that a great safety culture when people continue to work safely and do the right thing when even no one is watching. Thank you all so much. I rushed through because of lack of time. I hope I was not too fast. I was looking at the time, otherwise Nishla would have stopped me. Thank you so much.
I kindly request you to be seated on the dais. As we are running short of time, we will proceed with the felicitations. Can I at this point request Dr. Sai Sri Harsha, Senior Consultant Urologist, Continental Hospitals, Hyderabad, to come forward to felicitate Dr. Aksa Annie Paul, Dr. Karthik Rakam, Dr. Ramesh, and Mrs. Bobby Ramesh. I request Dr. Aksa to kindly come forward for the felicitation. Now I kindly request Dr. Karthik Rakam to come forward for the felicitation. Now I request Dr. Ramesh KN to kindly come forward for the felicitation. Now I request Mrs. Bobby Ramesh to kindly come forward for the felicitation. Thank you, sir. Thank you, ma'am.
We now move on to our next subject, the 3D approach to pulmonary medicine and patient care by Dr. Sai Praveen Harinath. Dr. Sai Praveen Harinath, Senior Consultant Pulmonologist and Critical Care Specialist. Dr. Sai Praveen is a Medical Director, Apollo E-Access, Tele-ICU Services, Apollo Hospitals. He is a Clinical Director, Apollo LAM Clinic, part of LAM Foundation, International Clinic Network. He formerly served on the Board of Regents for American College of Chest Physicians. He is currently a member of Telehealth Special Interest Group, International Hospital Federation, Geneva, Switzerland. Dr. Sai Praveen is one of the volunteers during Haiti earthquake. I welcome you, sir.
Thank you. Good afternoon, everybody. I think Nischala, thank you very much for this opportunity. Dr. Guru Reddy, thank you for this opportunity. I've been in India back about 12 years. I lived about 500 meters from this hospital. This is the first time I'm actually coming here. So thank you. There's always a right place and right time to visit a place like this, a wonderful hospital. Thank you for the opportunity. And it looks like you're all doing an amazing job at promoting medication safety. How many of you have heard me before? Okay, good. So I can repeat my slides. Thanks. Just checking. So I think the time chosen right now is a very peculiar time in the sense that most of us, the blood flow is right now not in our heads. Medicines, it's important to have a multidisciplinary approach because a lot of times it's not just writing the medicine moving away. A lot of times it might be the guy can't afford the medicine you wrote, or it might be that they're out of stock, or it might be that they can't swallow. So a lot of time, I do a remote critical care for the US, and a lot of times what happens is that like 8 o'clock they give me a message saying, can you change these medicines into a IV form because the NG tube is out, or they can't swallow, or they got tested and they're unable to actually make sure that they can handle the medication orally. So in that situation, you have to know what are the alternates. How many drug errors? Unfortunately, it's a fact of life. It's always tragic. And I heard Bobby Ramesh's story for the first time. I'm very sorry she had to go through that. But drug errors are really a fact of life. And if you look at this Venn diagram, and many of these sources, if you kind of magnify my slides, you'll see the references. But it's often a small portion of it is preventable, and another portion of it can be cured or treated, ameliorable. So essentially, you take a drug, it can be a wrong drug, but you can also have a lot of adverse reactions, but a significant percentage can actually be fixed. And I think it's important we focus on, one, of course, preventing these, but also focus on trying to make sure that if you do have the error, make sure that you can actually take care of that problem. There are many stories, some of them news, some are not in the news, which you've never heard about, which even the patient doesn't know. oftentimes the doctor doesn't know an error happened, but we all know cough syrup skill. You all heard about the WHO story, which has come out banning several companies now, where Gambia and Uzbekistan, some children died because of cough syrup. Of course, the other question is, do you really need a cough syrup? That's a separate story. I had a colleague of mine who had a patient who took rifampicin for 17 years. He just kept taking it. Somebody prescribed it to him 17 years ago, and he didn't stop taking it because he thought it worked. He kept taking it. So I was just telling him, can you publish that as a safety profile for rifampicin at 17 years? I'm sure all of you, how many of you had COVID? Actually got COVID? Okay, not bad. So we're all like not getting out of your homes, I guess, or not breathing. But anyway, so a lot of people in COVID got steroids. And last week I saw a patient who had avascular necrosis of the hips because of steroid use improperly. And they need hip replacement, and they're 40 years old. So steroids can cause avascular necrosis. So a lot of medicines can be used improperly. I had a patient who was swallowing his inhaler liquid. So he would open it up, take a swig, and say nothing's working. He was tachycardic, but otherwise the lungs weren't better. And of course, you can get multiple arrhythmias, some, Livolin. I have people with shaky hands. I have people whose checks were bounced because their signature was normal because they were taking too many of their sprays. So things like that can happen. And I think, we talk about success at any cost, but failure at any cost is what's happening now. And there are multiple factors. And many of them include things like using, you've all heard this all through the day today, but prescribing patterns, administration route, look-alike, sound-alike medicines. In fact, 1 in 5 dispensed medications ends up in an error, which is like a crazy high number. This is an approximation, but there's a range, of course, in all studies. But almost 1 in 5 actually ends up in an error. And I don't see this as an incorrect statement, because if I were to sit down and thumb through a chart every day, guaranteed I'll find 1 or 2 errors, and all of us will do that. 21% increase in risk of hospital readmission from medication error. And that just multiplies the cost of care. And again, these are all international data. How many of you are pharmacy students? So you have to kind of do studies in this country, because all the data we get is from somewhere else, which may be meaningful, but you guys should get in and start doing studies. You don't need a degree behind your name to do research, by the way. None of the guys who invented whatever gravity onwards, they didn't have degrees. Newton didn't have a degree, etc. So you need to figure out a way to really come up with a way to really solve these things. Now, drug interaction, if you look at the PubMed article trend just on drug interactions, the number of articles has been going up. So people are recognizing this more, which is a good thing. And of course, error is human, but it's also very common. And the main thing is to read, write, listen, understand, and communicate anytime you write a medication. There's a story of a 57-year-old woman who had a cough and sputum for 5 days. She got azithromycin, she got a bronchodilator, she died 3 days later. Why did she die? Well, her QTC was 545 milliseconds. Have you had talks today on QTC? Anyone talked today during the course of the day on the ECG thing? No? Someone did? So great. So you know the ECG has PQRST, so the QRS, the QT, right? So that number, if it increase your predominance, the chance that you end up with an arrhythmia. And this patient unfortunately had a long QTC. You know that bronchodilators can lower your potassium. So she had a low potassium, also had most likely a ventricular arrhythmia. Of course, this was preventable. She was also dehydrated. So it's important to recognize that even a simple thing like writing an antibiotic and giving an inhaler can kill people. How many of you heard of the Swiss cheese model? You all know that, right? So how many of you like Swiss cheese? How many of you ate Swiss cheese? You should. It's very good for health. Just kidding. It's very tasty though. So essentially Swiss cheese it's got holes in it. Anyone know why they have holes in it? They make holes in it. The Swiss are good at punching holes. No, it's a carbon dioxide, right? So you get these things, the gas forms it. And the theory is that this is just a model from Wikipedia on how the Swiss cheese model for the pandemic. Likewise, for any error that you have, there are multiple stop gaps, and then everything fails and you end up with the error. So just as you have seen several examples given today, you can end up with a situation where you have difficulty in getting the right medication given to the patient because of either a spelling mistake or an error in how it's written, or the dose is not there, so people approximate it. And if you look at, in my hospital at least, you see there's a list of do not use abbreviations, but people still keep using it. So heparin 1500 IU, you shouldn't write that. You should be writing 1500 international units as an example. So in pulmonary medicine, unfortunately, there are tons of medicines which can go wrong, where you can actually write the wrong thing. I see a case in point would be cough syrups, and come to that shortly. But the reason I bring this up is anytime you have an error, it's important to recognize what are the components of the error that can be fixed, what are the components you can't fix. And what you want to do as a pharmacist is look at each thing critically. Now, unfortunately, you may not have the time to go through this, which is where you need technology to help you in terms of evaluating things and doing a quick analysis of things. And there's also a very good website for pulmonology specifically, which some people who have trained with me would know. It's called Pneumotox. It's, I think, a French site. You can check it out, which has an extensive list of all the side effects of drugs which have actually been recognized. I trained at Loyola University a long time ago, and Dr. Eldandi was one of my professors actually a very long time ago. And I fondly remember his lectures and classes even when I was a student at the time. And one of the things we realized was that anytime you write a medicine, you really want to know the side effects pretty well. Because it's not that it's going to happen to the patient, but it's not that the patient won't get it. It's unlikely that somebody will get it, but there's no rule saying that this patient shouldn't get it. And unless you know what you're looking for, what the mind does not know, the eye does not see, right? So you really should know this stuff because you are the domain experts for drugs. In other words, you are the people with doctors will turn to say, okay, what do you think? You may not know the answer exactly, but you should know where to look it up. Google, or even just your textbooks, or even a website like this. So when I do my US work, which I do remotely, I'm relying extensively on the pharmacist to tell me what is the right dose of the drug, what is an alternate for the drug, what are the chances of a side effects if I use this. And they even send me reports on what is the bug that grew, what is the sensitivity pattern. And if some of you, some percentage of you are leaving the country, great, you'll be doing this there. But a larger percentage of you who are going to stay back should start practicing that way, because why should Indian patients get anything less? I mean, why should you or your families get anything less? Because ultimately, we've heard these stories where patients die because of simple human error. And it is in our hands and our power to actually fix this. How many of you know what that is? Any of you played with it? Any of you played with ChatGPT? So I typed into ChatGPT, please give me 20 slides on the 3D approach to pulmonology using drugs, doctors, and details. And in 4 seconds, I had 25 points. Of which I would say 90% were actually good. 5% was kind of staying junk, but 90% was actually good, and actually was able to use some of what I said today. I mean, I knew the points, but some of them were actually there which I didn't think of, and which is amazing. And you're going to either be replaced or you have to use it. I suggest you use it, because most of you don't have jobs already. So you don't want to get unemployed before getting employed. So what you really want to do is to figure out a way to use artificial intelligence, start playing with it, start looking at the technology, because this will help you go to the next level in terms of detecting errors, fixing errors, and also figuring out alternates to a drug, for example. So are doctors the problem? I mean, really speaking, maybe, because the human ego is huge. Doctors' egos are sometimes even bigger. A lot of times med errors happen because the doctor says, I know best. I know what I'm doing. I've been doing this for 25 years. I've been doing it for 30 years. Unfortunately, that is the reality of how a lot of medicine is practiced. And you all know of the Korean airline incident, right? You heard of that aviation accident where in 1995 or so, a plane crashed. And essentially the last 5 minutes of the black box recording were the senior pilot saying, let's descend to flight level 10,000 feet. And then the co-pilot says, I think we're going down too fast. And the senior pilot says, no, everything is fine. And the next thing you hear, the plane's crashed. So they went back and analyzed it, and they found that in the Korean airline culture, the boss was always right. So this assistant pilot, who was actually recognizing the plane is going down too fast, said something up. But then the chief said, no, you won't know. The plane crashed. After that, they had a complete inventory of what is actually happening, and they changed the culture where everybody has a role and they can speak up. In other words, in your own institutions, when you start working, you need to, if you're confident of the information you have, if you're confident of the knowledge that you already have about drugs, for example, you need to be able to tell the people there, I think this medicine is wrong, you should change the dose. But you say it politely, can you consider using an alternate because this patient has these side effects? So I think it's important that you recognize that. Anyone know what these numbers stand for? It's not, I have like 5.5 minutes, that's not that, but what is it? Think totally, if you've heard me talk, you know that I tend to go on tangents, so this is totally tangential, nothing to do with medicine. Anyone? Anyone? No idea? Any of you run? That's a clue there. Okay, you'll know. So, life is a sprint or a marathon, okay? So, what you need to know is, by the way, it's no more 10,000 steps, 7,000 steps. I mean, by the way, all of you got less than 1,000 today, so it doesn't count. But 7,000 is enough. So, you don't need to get to 10,000 is the recent data. But essentially, the reason I put this in is, a lot of these things we're talking about today need a marathon effort to keep it going. But you also need a sprint with a lot of energy, with the support of management, support of nursing, support of pharmacy to kind of take it off. Because these things won't happen unless you actually have a lot of effort to do it. Same thing, anything in your own lives. If you want to do a project, get a job, whatever, or finish your exam, you need to push that energy in, but then sustain it. And of course, this is, who is this? Anyone know? All right, you guys really need to stop watching Netflix and Korean drama. How many of you watch Korean drama, by the way? Last time I asked, the hands all went up. So you need to cut down your time. There's only like 24 hours in a day. Start reading some stuff. This is Kipchoge. He is the guy who did a marathon, which is 42 point something kilometers in less than 2 hours of running. In less than 2 hours. So, and this guy is, of course, Usain Bolt. And he said, repeating is harder than anything else. And he did a minute in like 100 meters in less than 10 seconds. That was a 9.58. So, it's important for us to sustain all of this effort, and I think it's important for us to recognize that unless you actually do this right, you're not going to sustain it. And my suggestion to you, the take-home message would probably be that you all heard today what needs to be done right, but take a step in the right direction. We'll very shortly get to that. Now, as you know, models of care delivery are changing. The patient can be anywhere. He can be in ICU, he can be at home, he can be on the bus. And with the remote technology you have now, you can actually communicate with patients. And, you know, I can look at my ECG on the watch right now. So the patient's data is going to go with the patient, doesn't have to be in a hospital. In other words, you would need to know what medicines they're on all the time. And with the help of AI and new technology, patients will know what medicines they're using. There are actually apps out there which can recognize a pill by looking at it. And many countries have numbers on the pills, so you can recognize it easily. So it's going to get easier in a way. But it's also important to know that you need an intelligent person like all of you to say, what is the next thing a patient should do? Telemedicine, which I do a lot of, is important to recognize in this space because you can actually remotely guide somebody. Here's a job idea for all of you. You can actually remotely guide someone to look at their medicines. You can remotely guide people on what is the correct way to take the medicine. You can actually help them in terms of their own families, in terms of saying, okay, what does your grandmother take? Let me look at it. So you can do all this remote. You don't need to be in a physical place for all that. There are, of course, challenges. These include challenges like cost, aviation analogy I talked about, where data matters. We also talked about the technical issues. We talked about autonomy, where the doctor says he's the boss, and he doesn't want to give up autonomy. So in which case, you really need a team effort and a team that can help you. There are many cough syrup. How many of you took a cough syrup? You all tried, right? There's hardly any evidence for it. I'm really not sure why we write for it, but almost all cough syrup just tastes sweet, so people like it. But and very few, some of them actually suppress the cough receptors, the codeine-based ones, but not really required cough syrups. And critical disease, we talked about tuberculosis. That's a chart from the Indian government's liver thing, which you talked about earlier. How do you adjust the dose? But it's amazing if you look at the data, and I'm sure Dr. Eldandy will can attest to this. A large percentage of tuberculosis prescriptions, even today around the world, are written wrongly. And they're written wrongly either for the duration of the medicines or the dose, etc. You can underdose, overdose. So in fact, despite knowing all this for over 100 years, we're still doing the wrong thing. Anytime you want to do something in life, I think it's important you have the intent, you have an incentive, you use innovations, you kind of remove the interference, and you need the support of an institution. And in medication safety, it's the same thing. You really need to think about this from a bigger picture. As junior students in pulmonology, for example, if I were to very specific say you become a pharmacist who's focusing on pulmonology, I'm going to kind of recommend that you all focus on the top diseases, tuberculosis, asthma, COPD, for example. But there's an entire new area like oncology for lung cancer. It's a huge area which requires expertise. And then you're also going to be getting newer medications coming down the line, including monoclonals for asthma, for example, where there's not a lot of expertise, but there's a lot of side effects for these drugs. So these are things which people don't know much about. And if you become the experts in this, you'll be able to guide others to do it. Ultimately, you need trust in a system. You need to generate value. You need to have faith. And the reason this is important is that you should figure out a way, how do I prevent the next medication error? And that can be your to-do. And today when you go home, you can definitely exercise, catch up on those steps, but check your family's medicines. How many of you have older people than you living in your own homes? How many of them take some medicine or the other? So once you get home, after you're refreshed, get out the list and say, okay, what medicines are you on? Hey, by the way, 10 seconds, all close your ears. Huh? Ignore it. That alarm's going to go off. So you want to actually make sure that you check their medicines, list out their medications and the indications, check pneumotox, look for drug duplication, which happens regularly, and look for polypharmacy. And of course, never stop learning, because life never stops teaching. Okay, we beat the bell, Okay, so now I can keep talking. So I think, so that's what Karthik did too, I think, right? So essentially, I think I'm just going to close there. I know you're all short of time. Thank you again for this opportunity to do this. But the take-home message really is that it doesn't matter what domain you're speaking about, the principles are the same. All of us are ultimately patients, and all of us need to realize that our families can be patients. So take a look at them, and the infrastructure should change. Each drug there's like 500 types of certain medicines. You can go to 1mg or Apollo, whichever pharmacy you go to, there's 500 varieties of a medicine. Like patients, we can't figure it out. How will patients figure it out? So I think it's important you recognize that some things have to change, but in the meantime, anytime there's ignorance and people don't know something, there's an opportunity. And you are that opportunity where you can fill the gap in giving that knowledge to people in an efficient and evidence-based way. Thank you so much.
May I kindly request you to be seated on the dais, sir? Thank you, sir, for that very insightful and interesting talk. The 3D approach is truly novel. Can I at this point request Shri Guru N. Reddy to kindly come forward to felicitate Dr. Sai Praveen Harinath. I would now request Sai Praveen sir to come forward for felicitation. Shri Raghuvan Reddy sir for felicitation. Thank you, sir. Our next subject is on opportunities for critical care clinical pharmacist by Dr. Mohammad Hisham.
I know it's going to be very difficult for both of us. One, for me to keep you awake. Second, for you to listen. So are we all ready for this, to explore more about critical care pharmacist, what you could do? Is it a yes? A little more louder. Yes. Okay, it's fine. I woke some people off. If the others were sleeping, and with the yes, you woke by yourself. Okay, so I do not have any disclosures. Just the objective of this talk is going to be low-hanging fruits. Critical care is like an ocean. So what you could actually pick. So those low-hanging fruits in critical care is what I'm going to discuss, and how can the strategies in which you can expand the role of pharmacist. So this is basically about what you need to identify, because it's going to be a very deep thing. If you look what all you could do in critical care. So my job is just to give you points in which you have to look. Okay. So why are ICU patients more complex? I know those are the most sickest patients in the ICU. Like in the whole hospital, these are the most sickest patients. So it's not like any other patients in the hospital, because multiple things have changed because of the disease condition. Apart from that, if you look from a pharmacy perspective, there are so many things which are running, which is what this slide is going to be. These are the low-hanging fruits. So I know it's quite complex, but okay, you look at any of these patients, one of these you pick, I'm sure this would change the practice. So I would say change the practice in the sense these are irrespective. A pharmacist is there or not, this has been done in the ICU. Whether it's done right or wrong is what we're going to learn. And how can you help in doing this? This is the most important thing. So what I'm going to do is, in each of these, so these are the low-hanging fruits. You need to choose from where you start, and in these, what is your role? So your role is not to do all of these, because as such the patient is complex, and critical care itself is complex, and if you start doing all this, you're going to make your job even complex. So I'm going to take these complexities off in a better way, in such a way that you understand what you need to do. So this is the low-hanging fruits. You are facilitators, okay? So you are facilitators in the sense, these, irrespective of ICU has a pharmacist or not, this is going to be prescribed by the physicians, this is going to be done by the nursing. But you as pharmacists, you facilitate by protocolizing and standardizing these things in such a way that what they're prescribing, you're changing the practice, and you put in a system where you make them practice the right way, and you could do audits, monitoring, and how it goes back. So if you look at each of these, it needs a pharmacist intervention. Say, for example, as I've discussed in the morning, rapid sequence intubation. So you need protocols which says which patient, what are the drugs, muscle relaxant, sedation, analgesia, what are the indications, doses, weight-based dosing if you have a pediatric ICU, and what are the contraindications. These are simple things which you need to know in all the drugs in rapid sequence intubation. Again, is this readily available? Yes or no? So all these are small things which a pharmacist, I'm just touching base with all of this because of sake of time, I'll be just touching base in all of this, but make sure that there are more than that which you could find on this. So small aspect, can you really make a big difference? Yes. Just not protocolizing that, but making sure that it's done in different techniques you can use to implement that. Just not really teaching. Teaching is not the, I wouldn't say it's the best, but it is one of the ways, but it could be done even in a more better ways in which you could practice setting up protocols, building order sets if you have electronic medical records, if you have documentation where you have to document a rapid sequence intubation after you intubate a patient. These are the things you need to document, and like you may have whiteboards or things like that where you can document the doses or like kind of refresher. So small things. So now when you look into the next one, therapeutic drug monitoring, there are a lot of drugs in the which would be used in the ICU which needs monitoring. So are they protocolized? What is the role of a pharmacist? Even if you're not there, they make sure that the drug levels are sent on time, and what are the drugs which needs to be monitored, and when do they monitor if you have this facility. If you don't have this facility, then if it's going outside and coming back, how frequently you need to do it on a cost-effective way. So small things like you need to keep in mind cost-effective, what you could implement to improve the quality of care you could do, and what change you could apply by being there. So drug information queries, poison information queries, you get all these day and out. You have to be in person there, or you must be available on paging services. Again, even if you're not there, make sure that you have these quick references, and these quick references would be useful for the physicians. Say you might have created some protocols. Say your ICUs, you receive poisoning patients. So these poisoning patients, it's more important you need to know what not to do than doing, because by doing what you should not do, you make the life of the patient easier to go or get worse. That is the most difficult thing. So it's most importantly, you need to know what not to do and what to do rightly. So all these, if you protocolize, that would be even better. Even if you're not there, they have the quick reference guide which you prepared in the ICU. Say if the patient's in advanced cardiovascular support, like extracorporeal membrane or ECMO or Impella or LVAD or any of these cardiac devices which needs monitoring, what is the role of pharmacists in terms of drug dosing, anticoagulation, things like that. So these are very crucial, because you could either end up harming the patient if there is no protocol. It's not uniform. Practice of prescribing differs based on different practitioners, things like that. A code blue, as we've already discussed in the morning, you have a big part to play. If you're ACLS trained, you have a big part in understanding and proactively being ready when a patient codes, or say for example, you're in between a code, you're a drug expert, so that the right doses are given, and if the patient's achieved ROSC, then you can also think about, if they have to be starting on inotropes, vasopressors, then you can think of how much dose, what rate you start, and what would be good for the patient. All these small things. The renal replacement therapy, hemodialysis, CRRT or any of these modalities, you need to adjust those. And if patients back with, say, after CRRT, patients back on hemodialysis or back and forth, you need to adjust the doses accordingly so that you optimally treat. It's not only for antibiotics, multiple drugs are there when you consider dosings. Reversal agents, when there is a need for reversing any bleeding or any antidotes, things like that, if you have a proper guidance, so that a quick reference for the physician, because they don't have to call you. First, you save your time. Second, they know where to go and look, rather than just having multiple references. You customize it based on your practice in your institution. So that would be really good. Glycemic control protocol. So these are things which are completely wavered, like variability in blood sugars. It's very high, it comes too low, then it kinds of come somewhere in between. Or you have patients persistently having hyperglycemia, and you may have patients with hypoglycemia. You don't have a protocol. Make sure that you have a protocol, you facilitate, you educate, and you see also how it works and how well your protocol is working, so that you can alter it and change it accordingly. So medication errors, adverse drug reactions, I don't have to go into more details because it's quite common in ICU, because a lot of medications, it's happening very fast, and it is something which is preventable, but how the eyes through which you look matters, because it has to be in a very good way so that you resolve the problem rather than for a long run, rather than for the short term. And if you look at multiple of these, like thrombolysis, anticoagulation, like you play a big part in monitoring these patients. And say any patient in ICU, say if there is any DVT, pulmonary embolism, or patient has atrial fibrillation, anticoagulation is most important. If it's parenteral or oral, your part as a pharmacist is very unique, and you play a big role to protocolize things so that it is not haphazard and all over the place, rather than this is how it has to be done. You engage the whole team in doing it, and you facilitate this. It's not that you have to do each of this. If you're there, it's good, and you can pick things which you have to definitely do on these. Arrhythmias, if patients like, say, simple things like patient has an arrhythmia, you need to look into how we can optimize, like QTC prolongation could be, or like electrolyte imbalances. How can you optimally prevent an arrhythmia from happening if it's not a kind of a code, like a life-threatening rhythm? If not, like anything which is ventricular or which is like premature, like small arrhythmias which could be sorted by simple electrolyte replacement, I think that should be something which you could optimize by having something protocol. Stress ulcer prophylaxis, you need to create a protocol where you identify which patients needs a PPI and who do not need a PPI. If patients transitioning from the ICU to floor, you need to know when you have to stop that, because that is something which is abused in the ICU. And also you also have to think when to switch from IV to oral, because these patients would be on feeding tubes. So it's very important, when do you start these IVs and when do you switch them to oral, and if the patient's on feeding tubes, what is the dosage form or what drug would work through a feeding tube. Things like that. Total parenteral nutrition. If you think like nutrition as such, like patients on enteral feeding, when do you switch to total parenteral nutrition? And parenteral nutrition, if it's central line or peripheral line, small things, and what you need to monitor as a pharmacist for that. Again, central line, peripheral line. There are drugs which should be given through central line, should in the sense only through a central line. There are drugs which can be given through both, but differences in the dose and concentration. So you need to identify those drugs. Simple example is inotropes, vasopressors. So you can't run all concentrations through peripheral line. It could definitely cause harm, extravasation, and multiple things. So to prevent that, you need to have a protocol which says this less than a concentration for inotropes or vasopressors. It should be peripheral line. Beyond that would be central line. Say inotrope vasopressor in the sense like norepinephrine, milrinone, phenylephrine. So if in case your IC uses any of these, dopamine, dobutamine, things like that. So that is one thing. Second, if it's say 3% sodium chloride or 2% sodium chloride, any concentrated sodium chlorides, if you're running through a peripheral, what is the rate at which you run through a peripheral line? What is the volume you can give through peripheral line? what is the duration, and beyond that you definitely need a center line. And some drugs like highly concentrated sodium chlorides or things which you definitely have to have a center line. So simple examples, and again dynamics of patient changes when patients on mechanical ventilation. So in these patients, how do you what are the problems caused by that, and what are drug delivery? If you have to nebulize a patient, what kind of nebulizers you use, hypersonic nebulization, and how much of the drug should reach if in case that does not reach in these patients, what are the different techniques? So simple things. Again, it could be other routes as well. If patients having intrathecal or any other route in which you have to give a drug, all these have to be protocolized so that it would definitely be good for the patient, and monitoring is done properly, as well as you have a part in protocolizing these and facilitating these. Say simple example, neuromuscular blockade. If patient, some ARDS patients, they would need prone ventilation and things like that when they would be on an infusion of neuromuscular blockade. All simple things like an eye drop to prevent exposure keratitis. These are very basic things as such, and as such if the patient's eyes are open, like eye care. So these are roles in which a pharmacist could play. Drug interactions, drug incompatibilities. Multiple drugs are running through an infusion pump, same line, through different Y sites. Even if they have a triple lumen central line, it could be through the single lumen, it runs multiple drugs, could be antibiotics, inotropes, all running, but are they really compatible or not? These are something which is very important. Drug dosing, renal dosing, hepatic dosing, weight-based dosing, simple things which could go wrong if you overdose or underdose a patient. Equally important, if you have these protocolized, you won't underdose or overdose of patients. Again, weight-based dosing, which drugs you do dose by ideal body weight, actual body weight, adjusted body weight. Simple things. It makes a big difference because you are the people who can optimize the patient care in the ICU. And like if you talk about infusion pumps, electrolyte abnormalities, all these, a pharmacist plays an important role. Antimicrobial stewardship, that I've put towards the end because it is not the last thing. That would be the first thing which you would be doing, but that's quite broad. A lot of things like starting from the right choice of antibiotic, duration, route, and even like if you have to escalate, de-escalate, simple things, diagnostic stewardship. If it, like say for example, sometimes ICU they order pan cultures when you have one source, and this could be the definite source, or unnecessary cultures, or unnecessary markers like procalcitonin. Some of the ICUs they keep repeating it, or unnecessary other tests which may not be needed to be repeated continuously. Simple examples, but these are the low-hanging fruits. I'm not saying that you have to work on all of these at one time. You just have to pick one. Definitely all the ICUs, these are, and this would definitely be there, and this is one slide where you could pick any of these, start working, and you are facilitators for these. It does not have to be that you do these by yourself, but you make the people do, and you there in observing the data and to improve so that they are kind of in practice with your recommendations. This is a question paper from SCCM, Society of Critical Care Medicine, along with American College of Clinical Pharmacy and ASHP. So this is a very good paper which tells a lot of things about patient care, quality improvement, research, scholarship, professional development, training, and education. What does a critical care pharmacist really have to do in each of these domains in an elaborate way? I would recommend you, it's freely downloadable, and you can definitely read this article, and I would definitely want you to go back and read so that you can optimize so low-hanging fruits already there, how we can do it in a better way. These are few things. So quickly going through what happens in a patient, like simple things, critical illness, pharmacokinetics. Patient may be on nasogastric tubes or duodenal gynostomy, jejunal tubes, things like that. Patient may be on high inotropic vasopressor supports. So the gastric absorption may be impaired, motility may not be there because these vasopressors, they compress and the bigger vessels. Along with that, they're also compressing the smaller blood vessels, which go through which runs blood to the stomach, intestine, and maybe even subcutaneous. Like say, for example, you take impaired absorption through the skin. If you are patients on high inotropic support, if you have patient sugars are high, either because of the adrenergic receptors, the inotrope as such acting on the adrenal receptors, or like as such absorption is less because all subcutaneous blood vessels which are underneath are kind of constricted. There's no blood supply. You give anything subcutaneous, it's not going to reach anywhere. It's just waste. So these patients, you switch to IV insulin. Simple things, gut flora changes. So all these could cause translocation infection, lung absorptions I've already mentioned could be impaired. So these are things, something which is quite importantly you need to look into, where it would matter a lot. So first we complete absorption, now distribution and excretion. So we look at acute kidney injury. So these are clearance increases, the drug concentration, clearance decreases, the drug concentration increases, causing toxicities, and like it could cause any other drug-related concentrations high, causing risk of toxicity as well. If clearance is increased, then the drug levels are decreased, so it means that you're under-treating anything, or your dose is underdose. Acute kidney injury, again, the drug concentration would be higher in the serum because kidneys are not working, it's not getting excreted. Augmented renal clearance, especially with early sepsis and trauma patients, some drugs get excreted off very quickly, and there won't be any drug, and you may be under-treating these patients. If there is capillary permeability is there, like any endothelial damage or capillary leak, if patients having hemorrhagic shock, blood volume of distribution is increased. There is no drug if you give, and it's completely decreased. Cardiac output in case of heart failure patients, that matters, low or high. Again, the clearance is altered, the drug concentrations are altered. Fluid shifts. So if it's third spacing like ascites, pleural effusion, or post-surgical any drainage is there, that will also kind of increase the volume of distribution, drug is decreased. If you're giving large volume resuscitation, fluid overloaded patients, heart failure, the clearance is increased and drug would be decreased. So GI bleeding, hypoalbuminemia, where unbound drug is increased, volume of distribution is increased, and again all these matter in terms of drug. Renal replacement, vasopressors, we've already discussed these. Same goes with hepatic. Altered hepatic flow, decreased hepatic clearance, similar conditions like hypovolemic shock, MI, heart failure. Just some examples of drug commonly used in ICU. Renal failure, you look into if it's increased clearance, decreased clearance. Whatever I showed on the previous slide, these are examples of drugs, most commonly antibiotics and anti-seizure medications, which are hydrophilic, which matters, risk of toxicity as well. So if you look at renal replacement therapy, like if patients on CRRT, things like that. So if you look at that, like the ones on red are the ones which are highly relevant and removed by renal replacement therapy. High filtration fraction is there and low volume of distribution, and it completely goes off. As you come down, you would see which drugs may not need to be dose adjusted. So these are few things logically which you need to understand the concept, and on practice you need to alter accordingly. If the patient's on advanced cardiovascular devices like ECMO, hydrophilic, lipophilic matters because the volume of distribution, again, concentration changes if the drug is hydrophilic, and again, if it's lipophilic, this is how it looks. And again, it's the circuit sequestration also happens for lipophilic drugs, which you may have to end up giving increased loading dose or normal loading dose for these patients, or alter the frequency, which could be a little more than normal. And you may have few literatures which is there, but those are literatures which you could follow definitely. How to get started? I've already told you, start with the easy ones because it's an ocean. You have so many things, and evaluate the metrics. Look into how you can do your facilitators for these. You don't have to do all of these. You set protocols, engage the whole team in doing this so that the whole team is aware what to do, and you kind of supervise, because irrespective of there or not, these drugs are going to be prescribed. And high areas of priority, is it surgical ICU, medical ICU, transplant ICU, which ICU you want to do it, and just make sure that these are realistic. I just have 2 minutes, yeah? It's red here, sorry. So yeah, so if you look into where do you start in identifying the drugs, you do medication use evaluation, which is very simple. You understand what question to ask, what is your research question to do a medication evaluation, what setting, what population, and you validate this study design, and kind of put in something which gives you a good your outcome of interest is served. It should be feasible and you disseminate a plan. So these are a few things, just quickly going through the order sets we have. These are, so you may think this is somewhere else, but these are order sets which is there in my hospital, implemented by clinical pharmacists, but these are being practiced by nurses and physicians. This is nurse-driven electrolyte replacement order set. So pharmacist or physician do not have any role in this, because whatever needs to be replaced, it's clearly on that, and they have to just follow that. Similarly, heparin infusion order sets, prepared by a pharmacist, driven by a nurse. They calculate based on the patient's APTT and what is the patient's rate at which it's going and patient's weight. They drive the heparin infusion. They don't have to ask a physician. They don't have to ask a pharmacist. The order set is built in such a way that these are electronic. But yeah, still it could be difficult in a practical setting, but you could really start with something which is small. If you look at pain, agitation, delirium, you have multiple order sets where you choose the drug based on CPOT scores for pain, RAS score for if you're looking to agitation, what drugs you choose. If it's delirium, you have, based on QTC prolongation, you choose which drug to choose, which not to choose, and based on patient's CAM ICU score, positive or not. This is procalcitonin, pharmacist-driven procalcitonin protocol, where you could prevent misuse or overuse of procalcitonin unnecessarily, and this is only good for de-escalation, mostly pneumonia. For these patients, based on this, you could kind of streamline the treatment. So us PharmD students are here. I would want, this is how we do in our hospital. We make interns, we make them responsible to do things so that you don't have to always be there. You empower them to do, and you train them to do. So if you could do, even if you are less than the 5th year or so, you can still practice these. You just need to, for education for nursing, physicians, and setting guidelines, protocols for your hospital. The FASTag is mnemonic, like it says feeding, analgesia, sedation, thromboembolic prophylaxis, head and elevation, ulcer prophylaxis, and glycemic control. So this is something which in the ICU we make so that all patients have been touched by a pharmacy student or a pharmacist under supervision, optimizing treatment, dose optimization, IV to oral, audit feedback, research, all these things. So this is something which you would say all this only happens outside of India. No, these happen in India. I've done this. I've done this all in 2016 when I was in India. And if you look at this, is one of the publications which came up just showing an incompatibility chart. You can see the drug particles inside the IV set, which is because of incompatible two drugs which came in. And if you look at the whole paper, you'll find what are the different findings. And whatever I've told is something, the low-hanging fruits, all I've done when I was in the ICU in India. It's not something, I facilitated that. It's not that I went and did each of these things. And if you see research, there's time for research. It's just not to show, I'm just showing you things so that you know that this is happening in India. It's not something which is outside outside India. So this is a paper, I protocolized a glycemic control protocol in which I received an award for the best research paper. And this is from the past president of ISCCM. And this is recognized by medical practitioners as well. And this, I only created the protocol, supervised it. It has been practiced by the nurse, and it's been ordered even. It's a nurse-driven protocol, by the way. And a physician oversees it. I see how it's working. And it actually reduced the variability, plateaued, and reduced the hyperglycemia, hypoglycemia. You can publish research. This is something which honorary award got by, this is Dr. V.V. Pillai. He's the head, like he is the top in toxicology. The books you read in toxicology is by him. And I told you references for ICU. I get calls midnight asking what should I do with this poisoning. I thought, why should they call me when if I create a protocol? And this book is being circulated all throughout the region around my hospital, so that even if we get a call from outside hospital, they don't have to call me and ask what to do. They directly have this reference. They have to refer the patient. They come back to our facility. So simple take-home message. Start with low-hanging fruits. Be proactive. Don't wait for the patient to get worse. Just be more active and think what you can do. Innovate, progressively think. And just these are all clinical things. There are non-clinical things, leadership, teaching, research, which it takes time, dedication, and networking to do better. Just make sure that you do these. All these competencies are may be unrealistic in the beginning, but knowing all things in ICU may be unrealistic. But just one last message is, it is when you start, an inch deep or a mile wide versus a mile deep or an inch wide. So this is what you have to understand. So where do you have to go? When you start, I would say a mile wide is fine, an inch deep is okay. But when you improve, start going up miles deeper and miles wider. So that's the message. Thank you so much.
Dr. Hisham, I wanted to add here, when you were showing the compatibility chart, I just recollected the day I came for assessment to Kovai Medical Center, though I don't remember meeting you there, but this compatibility chart I was very much impressed with, and we implemented in our hospital also the compatibility chart, and whenever possible, wherever I could talk about this drug-drug reaction and all, I used to always quote Kovai Medical Center had a good system of this drug-to-drug interaction compatibility chart, and the nurses also were trained by the CPs how to check for the compatibility post which, to give it, and it is really excellent, the compatibility chart, I must say.
Thank you so much.
And you all were doing at that point of time itself an excellent job in terms of clinical, as a CP. You all used to have a different set of CPs for the ICUs and the wards, and so many things like this, new things. It was a new learning for me also at that point of time, and very good practices.
Yeah, this is actually way back in 2013,
13
and
14 maybe,
it's
yeah.
almost 10 years now. I would say we are still the same, because only few of them practice or make a change in some ICUs. I know a couple of people who do a really good job, but everyone can do it. It's not like only some people can do it, and all of you can do it. That's the message. All of you can definitely do it.
Thank you, sir, for the very informative talk dwelling on the opportunities for a critical care pharmacist to optimize patient care. All right, everyone. We now have the final session of our day. Now we have the fun activity. Can we take a quick quiz?
Good afternoon, everyone. I hope nobody is sleeping. Can I get a hi from everyone? Louder. Louder, I can't hear. Dull, come on, louder. You can do it. You had a good lunch. Okay, I'll take that. We're going to go on with the Mentimeter quiz again. I'm just briefing on the instructions. A link will be shared in the WhatsApp group through which you will be redirected to the Mentimeter quiz site. If you're unable to join through the link, you can use the code to join the quiz. Please enter your registered name. Do not go along with the screen name. Once everyone joins, this quiz can be started. Come on, guys, join. Quicker. I need some more energy. Only 75. Let's move to the first question. Fastest finger first. You remember that, right? Come on, we know this. Okay, we really know this. Most of you have answered right. The correct answer is benzodiazepine. Let's check the leaderboard. I think the previous winner is competing this time too. He's on the top as well. Moving on to the next question. Quicker, guys, quicker. Not the website. Come on, guys, you should be faster than the timer. Majority gave the wrong answer. The correct answer is gentamicin. Chaitanya, are you not competing this time? We have Sheikh Muhammad Irfan on the top this time. Let's see. We have the question. Antihypertensives. Pharmacotherapeutics 1. Come on, guys. Quicker. That's it. Guys, come on. Are we forgetting antihypertensives? The correct answer is clonidine. What happened, guys? The first round you were excited? We have Hariharan on the top. Last but one question. Answer fast to get more points. Let's check the answer. We have Visalakshi on the first place. Last question. Last question, may you're lazing up. Okay, we got this right. Let's check the leaderboard. Okay, we have Saida Conan Fatima as the winner. Can you please come onto the dais? I request Dr. S.K. Gupta, sir, to felicitate the winners. Second place, Visalakshi. Third place, Saida Afia. Fourth place, Richa. Fifth place, Soha Amreen. Could you all please come onto the dais? You can introduce yourself.
A very good evening to you all. I'm Sayyida Conan Fatima from CBCP, PharmD 6th year intern.
Visalakshi.
Good evening, everyone. Myself, Visalakshi, faculty from Chaitanya Deemed University, Hanmakonda.
Good evening to everyone. I'm Sayyida Afia from MNR College of Pharmacy.
fifth year Pharmacist. Thank you.
Good evening, everyone. I'm Richa Indil from CBCP College, Pharmacist 5th year.
Good evening, everyone. I'm Soham Reen from Deccan School of Pharmacy and Pharmacist 3rd year. Thank you.
Sayeda Fatima, can you please come on to the dais? Yes. I hope this was fun. Thank you for participating.
Thank you, everyone. Thank you, sir. Our penultimate talk for the day will be delivered by Dr. S.K. Gupta on the journey of clinical pharmacologist with hematology and bone marrow transplantation. Dr. S.K. Gupta, HOD, Hematology and BMT Cellular Therapy, Continental Hospitals, Hyderabad. Dr. S.K. Gupta was one of the best outgoing students during his MBBS journey. He has completed his post-graduation and super specialization from the most prestigious All India Institute of Medical Sciences, New Delhi. He has received a Six Sigma Award 2016 as a Best Emerging Young Hematologist, Bone Marrow Transplant Specialist. He has established the Department of Hematology, Hemato-Oncology and Bone Marrow Transplant Cellular Therapy at Continental Hospitals, Hyderabad. Dr. Gupta is the founder of Hematology BMT Institute International. He has completed over 300 bone marrow transplants with a high success rate, which includes complicated half HLA matched bone marrow transplants too. We welcome you, sir.
Thank you for the kind introduction. And at the outset, I would like to congratulate Nischala, Sufia, and all the organizers for conducting such a wonderful symposium of the CME. Keep it up. Right. Thank you. So I know it is, I think we, our next speaker and myself, we are behind between you and the exit. And today being a Sunday and the Easter day, so I would like to complete my talk in 20 minutes itself. And for that, I have well prepared. In fact, Nischala messaged me, sir, you'll be have to hand it and a bit early also. So I made 20 slides, and during these 20 slides, I would like to make the awareness about the my department, hematology and the bone marrow transplant, which I think is when some CPs comes to the department, or even nurses, they comes to the department, I think it's always better to know what actually the department does. Right, so I'll start with that. So these are the 5 points where I'll be summarizing my talk. And to start with, what is a hematology and the hemato-oncology and the bone marrow transplants? So so how many of you have heard about this department? Yeah, so good, nice. I think 50-50. Yeah, so I think you can learn some more. You can improve your knowledge, and it's one of the fascinating branch in the medical field. It's growing, and various treatment modalities are coming up. And it's I think I should say, I apologize with my earlier speaker. It's more complex than the ICU. Patients will be stable. They are not on a ventilator, but they are sick, and their dynamics are highly variable. You know, the patient will be something in the morning and the afternoon will be something different. So it's highly dynamic and you have to be on the toes, and without the CPs or the nurses, I can't run the department. So I salute all of you. And so let's start with the first of it. What is the hematology? It's a branch of the medical field which deals with the liquid organs. So liquid organs, I think, may be a new term for you, and I'll be describing what are the liquid organs. And these liquid organ disorders can be the cancerous disorders or non-cancerous disorders. And the most important thing is that these disorders, the liquid organs, the functions and the origin of these liquid organs are linked with each other. And there is one cells which makes all these liquid organs. There will be 4 liquid organs. I'll be describing in my subsequent slides. So that is hematopoietic stem cells is the originator, is the maker of all these liquid organs. So if any defect is there on these liquid organs, we can treat with this therapy that is known as a bone marrow transplant, and nowadays we are coming up with a cellular therapies, gene editing and the gene addition as well. So let's start with what are the liquid organs. So the liquid organs, I said there are 4 liquid organs. One of the liquid organ is one of the component is the blood cells. So I hope all knows, and one of the most commonly used tests in the nowadays, but we do see that a lot of cases are being underdiagnosed or misdiagnosed, or they come late to us because of the wrong interpretation of this CBC test. So what is the CBC? The CBC has the cellular component and the plasma component, and the cellular component contains the red blood cells, that which is the hemoglobin, white blood cells, as well as the platelets. The white blood cells have the different subtypes: neutrophils, eosinophils, basophils, lymphocytes. And the plasma component, is, I think, extremely important, contains our antibodies. So antibodies, anticoagulant protein, procoagulant proteins. So a lot of things, I think, in the plasma components are there. So any disorders of these blood cells and the plasma components, let it to be the benign or malignant, comes under the hematology and the hemato-oncology. So that's one of the liquid organs. Now, the blood cells, as we know, the immune cells, we know they decrease in the numbers and increase in the numbers. So there should be something production. And the production happens in the bone marrow. So bone marrow is the origin of these blood cells as well as the immune cells. And the bone marrow contains the hematopoietic stem cells. And the hematopoietic stem cells has the 2 types of progenitors, myeloid progenitors and the lymphoid progenitors. And I think various subdivisions we can learn it. Now, the blood cells, I said, they changes in the numbers as well as the functions. So that's because one of the production can decrease or increase, can cause the hematological disorders. Second is the development. So the development happens, some of the blood cells known as the lymphoid cells, the lymphocytes, you know, T cells, B cells, NK cells, they require development. They need certain trainings. Without that, they can't function. Neutrophils, monocytes, eosinophils, basophils, hemoglobin, red blood cells, I think they do, platelets, they do, comes from the bone marrow and directly they can function. However, the lymphocytes, they do need certain trainings, and the training happens in our lymphatic system. Right? So that's a third liquid organ disorders. So I think how beautifully they are linked with each other. Starting with the blood cells, origin, bone marrow cells, development happens in the lymph node, lymphatic system, which includes the thymus as well. Now finally the 4th organ is our destruction. Right? So the dead cells has to be removed. Right? So that's being done by the spleen. So that's the organ what we know as the spleen. So how beautifully. So if you know so what I try to make it understand is these 4 organs is the Brahma, Vishnu, Mahesh. Lord Brahma, Lord Vishnu and the Lord Mahesh, which creates this nurture. So, so we ourselves is the populations created by the Brahma, that is a bone marrow, being developed or nurtured by the Vishnu, that is the lymphatic systems, and the destroyed, at the end, right, we have to go, and that's by the Lord Shiva. Right. So in the one slide, if I want to summarize all these things, so we have the 4 liquid organ disorders, that's the 4 liquid organs, blood cells, immune cells, anticoagulant proteins, procoagulant proteins, the bone marrow cells which makes it, the lymphatic system, thymus, and the spleen, which is, and some part of the liver as well. And all these 4 liquid organs, they arises from these cells, hematopoietic stem cells. So if you replace these stem cells, either by the gene editing or in toto, which the bone marrow transplant or gene therapies, nowadays we are coming up with that, so that I think we can treat these disorders. So one of the therapeutic modality, and I'll be touching on that aspect, how do we do the bone marrow transplant. And that's one of the diagram, pictorial diagram, which says what is that actually these liquid organ disorders. So right now we finish with the one talk, that is what is the hematology and hemato-oncology. Let's go to the next. What are the disorders which we do treat? And there are something which need to be understand, our limitation that we don't treat certain disorders. Right? So we do treat the liquid organ disorders, and the liquid organ disorders can be the cancerous or such as leukemias, lymphoma, multiple myelomas, myelodysplastic syndrome. Majority of are the benign hematological disorders, non-cancerous hematological disorders. Refractory anemia, refractory thrombocytopenias, aplastic anemia, TTP, I hope you have heard ITP, HLS. Majority of the disorders, I think I tell you, when somebody is required the admission, they are quite critical. The patients, and I'll showing the subsequent slides, how they are critical. So we don't treat the solid organ disorders. As a hematologist, I do try to limit myself with the liquid organ disorders. There are solid organs such as the brain, head and neck, lung, breast, prostate, gynecology organs, bones. So I don't touch on that one. And these slides deprecate why. We want to provide the quality care to the patient. We don't mix the treatment, and you learn and you've seen in I think since morning the medication safety, how important is the drug interaction, how important the drug dose is to be looked on, which patient to be given the what dose, sometimes overdose, underdose. These I think, and that has the most important in my department. Among all, maybe all department also has these issues, but the situation changes, and I'll be showing in some of my slides as well. Now, what I want to say is, you look if suppose terrorist attacks, they attack a single specific organ, say the kidney, or you can, in the layman language, you can suppose they attack say one bank. Now, simultaneously, the same terrorists divide in the groups, and they attack the bank as well as their protector. That is nearby the police stations or the army area. So that's a second category comes with the liquid organ disorders. So liquid organs, the disease is likely to be cancerous or non-cancerous. They are quite sick, I tell you. They may be looking extremely well to you outside, but a lot of things changes in them, and that if you do not identify them properly, or you give the wrong dose, or don't give the dose on the time, I think they are going to succumb. So that's what the criticality of this, and they end up in the ICU. Right, so that's what we do in the hematology and the bone marrow transplants. And so I'll be coming back to the following, the bone marrow transplant, actually what we do in our department during the bone marrow transplant. Before that, let's touch on there are certain myths about the bone marrow transplant. Very interesting slides. One slide I'll summarize. The patient's perspective, there are certain myths, and the donor point of view, there are certain myths. I hope all of you sitting over here may be thinking about those. The patient thinks it's the last resort of the treatment. It's a palliative treatment. Bone marrow transplant, like we do the kidney transplant the last time, liver transplant, it's recommended, like some diseases we do at the beginning, the liver transplant, kidney, but certain diseases they do at the last. So, but the hematopoietic stem cell transplant, if you have gone through the earlier slides, it's one of the first modality of the treatment. Hematopoietic stem cells give rise to all the 4 organs. So any defect can be treated by replacing those unhealthy stem cells. So this is not a last resort of the treatment, this is a first treatment. We don't do any surgery. It's all medical therapies. We don't do any surgery, and I'll be showing in my subsequent slides. Blood group match is not at all mandatory. Not at all mandatory. Again, I'm saying which is one of the least thing which we bother about. So what is mandatory is the HLA groups. HLA groups should be there. Other things comes is compared to the solid organ transplant, where they do need the lifelong treatment. The patient thinks, okay, I'm going with some transplant. What's that? I have to take the lifelong treatment. The beauty of the bone marrow transplant is that if they have done well over the next 6 months to 12 months post-transplant, there's no lifelong treatment is required. All treatment will be stopped at the 1 year. So there's no lifelong treatment. Now coming to the donor, when somebody wants to give the cells or the thing, they think I'll be having a lot of side effects. Like liver transplant, they remove some part of the liver. Kidney transplant, the one kidney is being removed. So in this, something will happen like this? No. So hematopoietic stem cells has the self-renewal capacities. So what we do we try to remove only 1% of the cells. 99% will be remaining in the donor's body. The 1% what we retrieve from the donor, that 1% we infuse to the patient, and that 1% will convert to the multiply, and they become the 100% cells. How beautiful now. There's another perspective is that, sir, I have diabetes and hypertension, or myself is a thalassemia minor patient, so that's not possible to do the transplant. It's not like that. These are the well-controlled diseases. If they're in good control, they can be a donor. So all these things, what I written is all myths. Let's come back to how we do the bone marrow transplant. So the journey of the patient, I think if you know this journey, you can understand the complexity of the patients. I may sound very simple on while presenting the couple of the next slides, but the complexity is over there only. So let's see how the patients being treated in my department. So I'm talking about the inpatient care of in the department. So as I said, it's not a surgical procedure. It's all medical therapy. We don't do any surgeries, right? So during this medical therapy, patients require almost 4 weeks in hospitalization. Now what happens in these 4 weeks? Patient thinks it's a big time, right? Family will say 4 weeks in the hospital. Now let's see what happens in the 4 weeks of stay. It's just there are sub parts of these 4 weeks. So the one thing is the stem cell infusion, and that stem cell infusion, before the stem cell infusion and the after stem cell infusion is the therapy what we look at. So stem cell infusion, before the stem cell infusion, we have to prepare the patient. And that preparation is in form of giving the chemotherapies or targeted drugs, biological agents, or we can take the help of some radiation as well in certain cases. So that's time period is almost 5 to 7 days. Sometimes it goes to 10 days or even more as well. So that's on an average 6 to 7 days is required for the patient before infusing the stem cells. So that's a critical period. Clinical pharmacologist help is almost, it's a important. What dose, what timing, certain drugs we have to give that time gap. Say 4 hours gap is there, the drug interactions will be there. So we need to look, I think, these aspects, and we need I do take care of our clinical pharmacologist on that setup. So once we have prepared the patient so that he can accept the stem cells, then we infuse the stem cells. Following the infusion of the stem cells, the third part starts. And the third part is almost extremely critical. The patient's immunity will be almost zero. He'll be like a preterm newborn baby. So almost zero immunity. Platelets will be 10,000. Hemoglobin will be, if you don't transfuse, it will be 3, 4, 5 grams. There will be fever, ongoing fever, decrease in appetite, the vomiting goes away. So it goes on. So this is supportive care, what we take care during. And this supportive care lasts for almost a couple of weeks. Right? So almost 3 weeks is over. Then comes the recovery of those hematopoietic stem cells. So the hematopoietic stem cells start generate hemoglobin, WBC, and the platelets. And that's what is a breathe for us when we see the patient has started to regenerate the donor stems. The donor's blood, the donor stem cell has started to generate the blood. Post-transplant follow-up, extremely important. Apart from these 30 days, another 2 months are extremely important. So patient may require the patient may need the admissions, but he need to have the constant follow-up. The clinical pharmacologist roles again comes over here. What medicines, whether he's taking the medications, at what time he's taking the medicine, certain blood tests to be done before taking the medications. So we need to counsel the patient, we need to look when you're post-discharge also, if somebody follow-up, how you are doing, how you are taking the medications, and is there any problem with the medication, you are able to purchase the medicine. Sometimes medicines are not available. So we need to have the good follow-up during this post-transplant period. So this is stem cells actually. If you have not seen the stem cells, which contains this is looking like a blood only, and the way how we transfuse. So there is no direct bone marrow infusions, all through the blood. Collect through patients also we do collect through the blood, and for the donor also we do collect for the blood, and the patient we infuse by the blood only. There is no bone marrow insertion. So I hope you understood. There is no surgery, not at all, right? So how many of you are from a village background? Yes, good. Okay, so I'm from a small village, and I've seen the farming. I'm not in the farming, but I've seen the farming. So I thought, you being from a not from hematological department, so let's try to make it understand in a layman language the whole process of this bone marrow transplant. So this is our end result. Think it's maybe rice or the wheat that we want to crop. We need the seeds. We need to bow the seed. That's one of the steps what we are doing for as a hematopoietic stem cells infusions. So that's the middle of the step. Before that, what happens? We need to prepare the patient. HLA match seeds will be there. We need to prepare the soil, and then we need to put the fertilizers, then pesticides, water, and all these things we procure. So all these 3-4 steps what I have shown is it's almost similar to that only. There are certain risks. Time requirement is also there. Right? So, and this risk period can be minimized, can be modified, can be delivered in the qualitable way if we take care as a team. So that's what some of the results I'm sharing with you. We have this like AML patients, adrenal, these all COVID. During the COVID, we have done it at the Continental Hospital. I thank Raghu sir, Dr. Guru sir to help in all the ways for us. So these are during COVID as a team, the doctors, my clinical pharmacologists, some of them might be there, the pharmacist, blood bank staffs. So the high-risk myelodysplastic syndromes, the benign hematological disorders also can be treated. Beta thalassemia major we did, a small baby. Sickle cell disease came with the sickle crisis. During peak COVID time, we have done the transplants. So that's what that journey. Right? Now let's see what happens with how you can help in this journey. What's the role and responsibilities during this journey from a clinical pharmacologist? So I have a couple of slides on this, basics and the advanced. You have heard with the various speakers, right? What the requirement from the clinical pharmacologist? Similar thing I think I'm putting over here in my perspective. Steroids. One of the wonder drug, no doubt, but if you give at the wrong time, wrong dose, long durations, it can kill the patient. All of you aware. So the request from my side to my all nurses and the clinical pharmacists, look on the steroids, how long the patient is on the steroids. Mention the dates mention the day of the steroid during the rounds. Other immunosuppressant. Patients will be there on the immunosuppressants for the first 6 months, so check on that one. Whether he's on immunosuppressant. Drug modifications. I think that's the basic mentioned. The ICU also required. Look at renal and hepatic functions and look on the dose. CBC also another important factor. We can modify the dose. So I think from clinical pharmacological perspective, we do need that. You look on these data as well when we do for the patient, and if there is a change, kindly update us. My previous speaker also mentioned on this one, I like his statement that polypharmacy. I try to minimize the drugs. Polypharmacy is not at all, I advise for my patient. I try to cut down on all the medications as much as possible. So that I think you guys also can help on this one. I want the clinical pharmacologists, when they do come for the rounds, look on the dose, timings, and look how the nurses are giving those medications. It's being administered on odd time. So I think the simple thing, but makes a lot of difference. Another important aspect when we discharge the patient, it's as important as what you have taken care. So discharge summary explanation to the patient in their own language, and ask, are you the, you may explain to the different person, but he may not be the right person who takes care of the patient. So sit with the patient at the bedside, don't ask them to come at the counter, sit with the patient, ask the attender who will be taking care for you, and explain them in their own language. Right, so I think discharge summary explanation makes a lot of difference, has made a lot of difference. I tell you, daily basis I see a couple of errors, or maybe more also. So we need to look on that. I think that's what basic requirements I call for from the clinical pharmacologist. Some advanced things, there are drug interactions happens, chemo drugs, the blood thinners goes on, chemotherapy drugs, sometimes we need to reduce the dose. For example, venetoclax and the posaconazoles or the voriconazole, we need to decrease the dose almost 25%. So we need the help of the clinical pharmacologist in looking on those aspects. Blood thinners, I think you all know it. Drug levels, my earlier speaker mentioned about drug levels. We do the drug monitoring. So look what's the target drug levels. Based on that, we can modify the dose, and so that it can get the proper effect, and we can avoid the side effects. Chemotherapy, yes, if you want to learn, you can learn on the chemotherapy. Nowadays, immunotherapy, targeted drugs are there, which have a different side effect profile. If you want to look at it, I think at the end, research, you can make it something, research on these hematological patient, this one. So these are one of my favorite slides. I think since morning the talk goes on this one. Medical error, medical errors, medical errors. Non-avoidable, there are unavoidable errors. Third leading cause in the US, I don't want to say what the answer will be for the India. So as a team, if we work, I think we can minimize those errors. We can give the quality outcome. I think patient journey also important. Whether they are satisfied with our treatment, how you address them, how you take care of their queries, concerns, that's all possible. And I think I would like to thank, being an ex-nurse, I would like to always thank the nurses who helps my department. Not possible without them. They are the forerunners for the department. I don't much rely on the doctors. The doctors, they do change because of various reasons. The nurses. So I demand a big applause from my nurses. Because of them only, I'm able to run that hematological department in this hospital. I think it will be injustice to say that thanks not to say the housekeeping, canteen, security staffs, my doctors, and various clinical pharmacologists, I put that at the end, but yes, they are the forerunners. Referring colleagues and the seniors, the outside laboratory doctors and their staffs, I think they do give the reports on time. CME, PCR, we do get tacrolimus level, sometimes we do issue. They provide the report on time. I think with that, we can avoid a lot of errors. We can help the patient in recovering. I think I would like to acknowledge the patients, their parents, and the donors. Sometimes the donors, they are not aware they help the patients. Right, so those I think they need the critics. I think I always love the critics in a positive way. I do take the critics in the positive way. Somebody gives the feedbacks, okay, negative feedback, learn from them. They may be right on that one. Yesterday, a couple of days back, Dr. Guru said something on one of the patients that admitted currently in the ICU, G6PD deficiency, commonest. I have been treated many patients. Something, it was not looking too odd to me. He searched the literature and he said, hey, Dr. Gupta, look on this one. Yes, there something is there, and I gone back with my academics and yes, there is something is there. So I think take the feedback in a positive way. Don't get annoyed with the feedbacks and reportings. I think drug reporting is important. Take them in a positive way. So with this, I think my take-home message will be learn and practice. Previous speakers also somehow mentioned learning never stops. Life never stops teaching. So learn and practice it on the basic way. Ask the doubts. There's no harm in asking the doubt. Ask the doubt. Ask the doubt in a proper way. Sir, I know this one. Is this because of this I'm asking this? So make a proper background and ask the doubts. Communicate properly. Communication skills is the key. Even you know the lot of theories. If I know the lot of theories, if I don't communicate well to my patient, I don't address their questions, queries on the time, no use. It's all on the vein. Even you have survived him, you have brought him out from the ICUs. If you're not able to understand, if you're not able to communicate to them properly on time, no use. So communicate them properly, communicate with the other colleagues in the proper way, get them, they may be right also. Nobody's wrong or the right. They all the principal changes. COVID time we have seen, right? A lot of changes has happened in the treatment decisions. So learn from other colleagues, important. Follow up You had to follow up. You have given the orders, look on the follow-up. How, whether it's being followed due to some reasons not able to do, your staffs may need the help, so follow up with them. One of the reasons, I once again thank Nishchala, try to update yourself, be creative also. Creativity comes, I think you have creativity, make the life simple, right? You have a creativity, I think you'll learn you'll enjoy your things, right? At the end, I think I should say take care of yourself and enjoy your work. So with this, I think I conclude. Thank you. Thank you all. Thank you all. If there is any questions, comments, please. Suggestions? Yep, why not?
So audience, do you have any questions?
Yeah, okay. Thank you.
Okay.
Thank you. Thank you.
Thank you, sir. May I kindly request you to stay back on this dais for felicitation. Thank you, sir, for that very insightful and interesting talk for outlining the journey of clinical pharmacologist with hematology and bone marrow transplantation. Can I now request Dr. Anuradha to kindly come forward to felicitate Dr. S.K. Gupta.
I would like to thank Madam. I think it's strong pillar for my department. Thank you once again. That's all that can happen, right? So, Madam, you should help a lot. Thank you, Madam. So, Madam, you are coming at the round.
Thank you, ma'am. Thank you, sir. Our final subject for this day is the role of clinical pharmacist in oncology, followed by a case presentation by Aksa Annie Paul.
Again, a warm good evening to all of you. I know you're all tired and waiting to go home and rest. I'll make it as simple and short as possible. So I request your kind attention for the next 15 to 20 minutes. So who is a clinical pharmacist? I know you're all, most of you are clinical pharmacists or aspiring to become one. So a clinical pharmacist is an integral part of the healthcare team, and according to the definition given by the American College of Clinical Pharmacy, they have to ensure that the medications prescribed for patients contribute to the best possible outcome. Now again, why this topic? Why in oncology? Why have we set out 20 minutes for the role of clinical pharmacist in oncology? It is because cancer is a very complex disease with a complex regimen. Okay, there are about 100 different types of cancer, and each cancer is treated differently, and the regimen is complex. There is radiotherapy, there is immunotherapy, there is chemotherapy, there is surgical prophylaxis and therapies, surgery. So there are a lot of treatments, and because of that, it is very complex disease with a complex regimen. And cancer patients are usually susceptible with low tolerance. They're very sensitive. Okay, in normal patients, takes time to see adverse drug reactions or so, but in cancer patients, it's much faster, it is much rapid, it is much severe when compared to normal patients. And then geriatric patients. In the morning session, we discussed that India is going to become the geriatric hub, right? So about 3/4 of the cancer patients belong to the geriatric patients. As you know, geriatric population have altered pharmacokinetics and pharmacodynamics. So everything is different with geriatric population. So we need someone to check the drugs given in this particular area. And cancer chemotherapeutic drugs are the most ADR causing drugs. So you need monitoring, you need careful follow-up for patients who are on chemotherapy. So coming to the roles of clinical pharmacist in a cancer setting. Dosing and preparation of chemotherapeutic drugs. It starts at the prescription level when the doctor gives the dose, when the drugs are mixed, and to the administration. So coming to the dosing. Almost all chemotherapeutic drugs are calculated using body surface area. So body surface area is dependent on height and weight. And it is not like once the patient comes, takes treatment and patient gets cured and go. It is, chemotherapy is given in cycles. So some cycles last from about 4 months to even years. So patient has to keep on coming again and again. So when the doctor writes the first dose, that dose might not be followed for the coming cycles. Patient's weight may change, vary. So it is very important for the pharmacist who is posted in an oncology setting to check if the patient's the right dose is given to the patient. It should not be underdose nor overdose. Coming to toxicities, as I said before, as the dose increases, the toxicity also increases. So each patient's tolerability is different, susceptibility is different. So the dose has to be according to, it should be patient specific. Age, again pediatric and geriatric population have different dosing to be monitored. Comorbid condition, this is again one important aspect. So usually in India there is a huge patient load, so doctors usually don't take, or it is impossible to take a elaborate medication history or medical history of the patient. So what happens, some comorbid conditions can lead to toxicities or decrease the medication safety. For example, if the patient is having a cardiac condition or a heart disease, you're not supposed to give drugs like anthracyclines, which are cardiotoxic. Okay, so if you're not taking the correct history and the patient is prescribed with cardiotoxic drugs, it is a matter of time before patient ends up with permanent heart damage, cardiac damage or disorders. So it is very important to take the medication history of the patient before prescribing or deciding the dose of the drug. And then type of cycle, some are weekly, some are monthly, some are 21 days or a 28-day cycle. So dose also changes. So it's very important for a clinical pharmacist to cross-check the changes in the dose according to the duration of treatment. And then goal of the treatment. Again, cancer goals are different. Some will, treatment is given on a curative intent. Some is given on a palliative setting. So the dose is again different for each and according to the goal of treatment. So coming to the mixing of chemotherapeutic agents, again, there are a lot of roles that the clinical pharmacist can do in supervising and training of mixing in of chemotherapeutic agents, and you have to ensure that the proper safety procedure and is maintained, and incompatibilities. As a speaker before me said about different incompatibilities, when you mix, you should know which is incompatible with what. Okay, so that is also very important, and the cold chain maintenance and ensuring that all the medications are, the stability of the drugs are maintained. So all these are small things which can make a big difference. Cancer is actually a very costly disease. So small things can at least, add or improve the outcome and benefit economic, improve the economic outcome as well as the clinical outcome of the patient. So small things, small steps, not tailing to take big steps and improve patient outcome. These are all small steps which you can monitor when you are in a cancer setting that can improve patient care. Coming to administration of chemotherapeutic agents, proper pre-medications and appropriate time. Infusion rate is again important. Usually, I've seen patients in my hospital, infusion will be a 24-hour infusion. They increase the rate of infusion by themselves so that they can catch the next bus and go home. So it is actually increasing the toxicity, decreasing the efficacy of the drug. They increase the infusion rate by themselves. So it is the duty of a clinical pharmacist to counsel to make sure that the right infusion is given, right infusion time is maintained, and even training the nurses to do so. And then make sure that proper techniques for IV administration to decrease the risk of extravasation is also maintained. And in case of photosensitive drugs, some of the cancer drugs are photosensitive. So when you're administering, for example, doxorubicin or epirubicin, these are light sensitive drugs. So when these drugs are administered, it should be covered with a dark cloth or a black cloth. Most of the nurses or most of the patients ignore that. So it is that is where you can, and the drug can become inactive when exposed to light. That is where you can take a role. You can do something about it so that the efficacy is maintained. And then ensure proper post-medications. The second role, important role, is detection, monitoring, and reporting of adverse drug reactions. As I said before, cancer drugs are the most ADR-causing drugs. So it's very important to monitor adverse drug reactions in an oncology center. The success of chemotherapy comes with a word of caution regarding the toxicities of anti-neoplastic drugs. So pharmacovigilance activity is mandatory in these settings. So these are some of the common adverse drug reactions. And then identification and management of drug interactions. There are drug-drug interactions and drug-food interactions. So sometimes it can be one cancer drug interacting with another cancer drug, or sometimes it can be immunotherapy which is interacting with antibiotics. Antibiotics will reduce the efficacy of immunotherapeutic drugs. So what happens is that patient will go to some other setting, go to a physician, get an antibiotic, but will not tell the oncologist that they are on antibiotic. They will come, get the chemotherapy or the immunotherapy as well, but patient will not have any effect. So it is your role, you have to act as a bridge between the doctors and the patients and ensure that the right therapy is given and there are no interacting drugs in the regimen. Coming to patient counseling, again about the disease, comorbidities, about drugs, about lifestyle modification. It is not how much you know, but how well you can communicate and convince the patient on what to do, what not to do, what to take care, what to be careful of. That matters. So communication is very, very important skill a clinical pharmacist must possess in a hospital setting. And then medication reconciliation, I won't be discussing again about this because in all the morning sessions we talked about admission, transfer, and discharge reconciliation. So this is just a cartoon like in the previous sessions about taking rifampicin for 12 years. Similarly, a patient is taking amoxicillin for years without proper reconciliation. And providing drug information. Cancer or oncology is such a field that every month new drugs or new molecules are being discovered and used. So drug information, providing a drug information is very important in this setting, and it is an important role that a clinical pharmacist can play. Sometimes every time you might not get an answer. Sometimes you might go through the specific question for hours. You might do wide literature search to find that this question has not been studied yet. But still, you have to try. You have to ensure that all the queries which the doctor or the oncologist or your team asks is answered. And then medication errors. Again, identifying and resolving medication errors in oncology is of utmost importance, and recognizing untreated problems that could improve with appropriate medication therapy. So these are some of the roles of clinical pharmacists. Now I would like to take you through a case which we saw in our study hospital. Very briefly, so this is about a 28-year-old female at 28 weeks gestation who presented with a 5-day history of fatigue and fever. It's not often we see a pregnant patient presenting to a cancer hospital. It's very rare, right? So this patient was in her 3rd trimester and presented with a history of fatigue with fever. And she had already had all her investigations, okay, which showed that she had acute lymphoblastic leukemia, and the disease also was in an advanced stage. So she had gone to various other hospitals where they rejected the treatment. This was the 4th hospital she visited. So patient was given, because her hemoglobin was low, she was given with 2 pins PRBC. Prednisolone is also used, it's a corticosteroid, but it is also used in the treatment of leukemias. And this was one of the safe drug which can be given to the pregnant patient. So they started with prednisolone. And what happened is that she was given with 20 mg for a period of 28 days and was tapered over 2 weeks. And then we didn't know what to do because, as you know, most of the cancer drugs are either category D or category X, right? So if you don't treat the patient, we will lose both the patient as well as the fetus. And if you treat, it can harm the fetus. So it was actually a dilemma. We didn't know what to do, and there was not much literature or studies done in this particular area. There was not much case reports here. So, and it was it is a very rare case. It is actually 1 in 1 lakh cases where a pregnant woman presents with ALL. So we didn't know actually what to do. So we got together as a team, the treating gynecologist, the medical oncologist, and the clinical pharmacist got together as a team, and we had a panel section, and we tried to examine each and every drug, what can be given for this patient. And then as discussion pursued, since patient was in the 3rd trimester, the organs would have already been developed. So the risk of congenital abnormalities are actually less. So we thought we'll take a chance with category D drugs because patients, the fetus organs would have already been developed. So we gave a list of the drugs which can be given, and the medical oncologist and the gynecologist sat together. The gynecologist said only 1 chemotherapy is enough. After that, we'll do a C-section and remove the fetus so that the risk will be minimum. So we decided to give 1 cycle of chemotherapy to this pregnant woman. So it was decided to start chemotherapy with injection vincristine and daunorubicin. Both are category D drugs. So this is where pharmacist's role comes. We provided the drug information which was required, and we referred, and we gave this, and patient was given with the first cycle of chemotherapy. Soon after chemotherapy, patient complains of chills and a fever, but symptomatically patient was treated. CBG was very much elevated. Again, it can be because of gestational diabetes, or it can be because of steroids that the patient was on. So again, it is an ADR. And then insulin was also started according to the sliding scale. Patient completed 30 weeks of gestation. We corrected what all possible to correct. And then C-section was performed. And patient gave birth to a healthy baby boy weighing 1.7 kg with no surgical complications and congenital abnormality. So that is the baby, and that is the medical oncologist, the gynecologist, and that is, he is the MPharm student who went to the hospital for the procedure. And this is the baby. They are, mother and baby are both doing well. So this is how you can play a role as a clinical pharmacist in the setting. When it is all chaotic, or when you don't know what to do, when information, sometimes not everything is available in the net or in the books. So this is how you can make a role for yourself take a chance, work as a team, and do something beautiful for the community, for the patient as well. So with this, this is the clippings of the surgery and the cancer that was covered in the newspapers. And I thank again the organizers and everyone for giving me this opportunity. Thank you.
Thank you, ma'am, for providing us with such amazing lessons on the role of clinical pharmacist in oncology.
All right, everyone. As all good things must come to a close, we are at the finale of the symposium. Before we close, I request Sri Raghuvan Reddy to come forward and give the valedictory address for the evening.
Good evening. I'm totally surprised that there is something called valedictory address. I'm not a clinician, I'm not a clinical pharmacologist, nor a pharmacist. But the way in which this international symposium on medication management and clinical pharmacy was put together by Dr. Nishchila and her team is commendable. My impression, by arranging this array of 7 speakers from different parts of the country and abroad, speaks volumes about the way in which the topics were chosen and put together. I'm pretty much sure when Dr. Nishchila was a clinical pharmacy student, she never had this opportunity to go through this, what the speakers, both who have come from other than Continental and the Continental speakers, have expressed their viewpoint, their experiences so vividly, enlightening. Today's delegates, I understand there were more than 290 people who participated in this symposium, and 75% of them happened to be students drawn from different colleges of Telangana and Andhra Pradesh. Many of you may not be aware, Continental is not just a quaternary care hospital, but it is also an academic institution which has DNB program in more than 17 specialties. And above all, it is also a sponsorer for the MSc Clinical Pharmacy program of Reddy Women's College since last 5 years. Continental is the center for all the MSc students. In fact, their program started when Continental has given its permission to accommodate the students and go through the various training programs, a program which is taken care of by the nursing director, Dr. Nishchila, and some of these things. What it affects me, what it was going through my mind, whenever I have my grievance officer calling me, I'm okay to receive that a nurse has not responded to a patient, an operation guy or a billing guy did not give the bill in time. But what it sends shivers down my spine is when they say there was a medication error. Truly, students, and all the gentlemen and ladies who are seated here, please ensure medication error, as I was listening to Dr. Baunik this morning, every patient, every day, undergoes a medication error, which, in my opinion, I feel is quite high. In fact, let me be candid in expressing, 3 months ago, when I happened to see such medication error at Continental, I called Dr. Nischila and said, do you know why this has happened? Then she expressed, sir, we have clinical pharmacists deputed in alternate floors of the hospital, and one of my trainees happened to administer these medicines when the patient was living. I said, we have 7 floors, IPD floors. How many clinical pharmacists do you require? Put a requisition. I will ensure that in the next 15 to 30 days, you will have this clinical pharmacists in every floor of Continental hospitals, and also ensure that these pharmacists are taking care of alternate floors even in the night time, which she has done. That is the importance. As they say that Florence Nightingale has defined the medical empathy and other things in healthcare industry. When I was listening to various speakers, what it goes through my mind as I look after the operations and visited at Continental Hospital, clinical pharmacy is going to be the most important and integral part of the day-to-day operations of the hospital. Believe me, friends, you all have a bright future. Learn this. Learn whatever the various speakers have expressed. Where were the various deficiencies? Fine, medication errors, what the clinicians write. I have not encountered many at Continental hospitals, but medication error, as Bobby Ramesh, when NABH inspection or JCA inspection, and a couple of years back, when I was attending a CEO's conclave conducted by the CEO of Joint Commission International at Bangalore, when they asked how many people report these medication errors, there were very few hands in that particular hall which has gone up. But my emphasis to the chairman, to the nursing director, be open, be frank when such errors are being reported, because it is so important to secure the life of every patient who walks into the hospital. Thank you, Nischala, for putting up this wonderful program. I have no words to express. To be frank, this is perhaps one of the first programs in my 10-year journey at Continental hospitals where our contribution in the venue arrangements and other thing was very minimal. And as expressed by Dr. Reddy, the way in which you have put up the whole program was commendable. The only request, whenever you have the next conference, ensure that there is a topic of how the administrators react to these medication errors. You know? Thank you, one and all.
Thank you, sir. I would request you to stay back on the dais. I would like to request Dr. S.K. Gupta to kindly come forward to felicitate Sri Raghuvan Reddy.
Now I request Sri Raghuvan Reddy to felicitate all the organizers from Clinical Pharmacy Department.
I request Dr. Sufia Iram Ishrat to come onto the dais for the felicitation. I request Mohammad Sameem to come forward for this felicitation.
Now I request Dr. Chaitanya SV to kindly come forward for felicitation. Now I request Dr. Zuveria Siddiqa to kindly come forward for the felicitation. Now I request Dr. Pratyusha to kindly come forward for the felicitation. Now I request Dr. Mohammad Madani to kindly come forward for the felicitation. Now I request Dr. Sandeep Chakravarti to kindly come forward for the felicitation. I request Dr. Shaini Rosalind to kindly come forward for the felicitation. Now I would like to request Dr. Mohammad Mishal to kindly come forward for the felicitation. Thank you, sir. Thank you, everyone.
I request Dr. Sufia ma'am to please give a vote of thanks.
All right, everybody. I know it is a hectic evening for you all right now, but just coming at the fag end of the day, I'll keep it very short and to the point. I would like to thank a few people, important ones. First and foremost, I'd like to thank all our faculty and speakers, Dr. Subrajyoti Bomik, Dr. Sangeeta Sharma, Dr. Mohammad Hisham, Dr. Sai Praveen Haranath, Dr. Karthik Rakam, Dr. Aksa Annie Paul, and Dr. Grace Marie John. Our in-house faculty, Dr. Vijay Yaldandi, Dr. S.K. Gupta, Dr. Ramesh K.N., Dr. Shilpa Aralikar, and Mrs. Bobby Ramesh. Thank you to all the speakers and consultants at Continental Hospitals in helping us putting together this symposium. My heartfelt thanks and gratitude to Dr. Guruvan Reddy, the visionary and guide behind this entire endeavor. Thank you, sir, for all your support and for your constant encouragement. Thank you to our dear Raghu sir for all the operational and on-ground support. Sir, this would have been impossible without your support. Thank you to the entire operational staff led by Mr. Arun Kumar, facilities personnel led by Mr. Lakshma Reddy, branding led by Mr. Raju, Sridhar and Karthik for photography and video, F&B led by Aruna ma'am and Mr. Anil, purchases led by Mr. Mani, IT led by Mr. Subramaniam, digital marketing led by Mr. Riaz, and finance led by Mr. Lakshman. Also, we would like to extend our thanks to Mr. Venus for his endless support. Thank you, Vinay, for your support right from the time of registrations. And thank you, Mr. Sulesh Pillai, for your great coordination with the speakers. My special thanks to Dr. Anuradha for your help and support with the media personnel. Thank you to all the media personnel present today. Thank you, Mr. Srikanth, for your continuous support and cooperation. Thank you to all the on-ground support staff, vendors, and external help. Thank you to all the volunteers and personals from my Department of Clinical Pharmacy who have been working tirelessly behind the scenes and all day today for the success of this symposium. Finally, my sincere thanks to each one of you for being present here and making this symposium a grand success. Thank you and a good evening to one and all. I'd request all of you to please go ahead for the high tea and snacks. Thank you.
Section, okay.